always open up the joint, drill the joint, use my Colorado cautery needle to dissect and coagulate the joint capsule. And then I always use bone chips and place the bone chips after opening of the joint. This is the joint drilling I am demonstrating here to make the joint more favorable for the fusion, which is our ultimate goal. So this is I'm placing bone chips in the joint, and then as we move forward, after placing the bone chips, it helps us in reducing the BI at that moment only, and definitely it progresses our fusion rates. So, and then after that, I always try to make a space for the C2 tulip to sit so that we can always achieve a very good V shape of our screws. So this is what I'm talking about to get a V shape. And then this is our case where pre-op there was BI and AD in this case, and post-op we can see the reduction achieved. So this is my next case. Unfortunately, I don't have the scan images now. So I use this 3D model where in the complex cases I need to do a planning. So in this case, definitely we are seeing both the vertebral arteries crossing through the joint. So initially it was looking difficult to achieve the C1 lateral mass screw. So here what I have done the drilling of the C1 posterior arch from both sides, and then I have made the vertebral artery free on both sides. Then I have mobilized the vertebral artery superiorly to put C1 lateral mass screw in this case. So as we go here, we can see I'm mobilizing the vertebral artery. Sorry, from this angle, I'm not able to put. So this vertebral artery being mobilized here. Opening up the joint, putting the bone in the joint. So in the end, after mobilizing the vertebral artery superiorly, putting the C1 lateral mass screw. So this is our initial picture of pre-op X-ray and comparing the post-op reduction. And there is one small video in the end where this is the mobilized part of vertebral artery on one side. I'm showing after freeing it completely from the posterior arch of the C1. So this is another case where it was very difficult to open up the joint and put the C1 C2 open up the C1 C2 joint because of the pseudo joint and vertical alignment of the C1 C2 joint, where it was not a very aesthetic radiology, but achievable reduction was get in the end. So another case where there was AAD with BI, but C1 arch was completely fused here, and it was looking like difficult to reach the C1 C2 joint initially. But then one side vertebral artery mobilization was also required. This part of the C2 facet was drilled, superior facet was drilled, and vertebral artery mobilized on the right side to place the screw. And before putting the screw, the joint was open and a good amount of bone chunk was placed inside. So this is pre-op image and this is post-op image showing good amount of reduction. And in these cases, I try to use reduction screws to achieve good reduction. And the benefit of reduction screw is we need not use a longer lag screws, which I don't prefer to use. So because the fusion rate is always better when we use the short length of the screw. So this is another case where we can see the branch of vertebral artery which was crossing through the joint, C1 C2 joint posteriorly on the left side. So here also difficult radiology. So I have placed one side, I have placed a spacer so that normal side, if we place the spacer and achieve C1 C2 fusion on one side, it is always easier to do the another side. So that's why the normal side was done first, and then same procedure of opening up of the joint and drilling. Then the vertebral artery branch which was crossing the joint was mobilized superiorly with the using this Penfield retractor, and the C1 C2 spacer was placed. So here we can see. So this was the post-op image and pre-op image for comparison, where almost assimilation of C1 was there, but in the end, achievable reduction was achieved. This is post-op images. So another case where there was left vertebral artery absent and C1 arch was fused and C2, C3 fusion was there. So I will run a little fast. The joint vertical angulation was very difficult to put the joint spacer or, and this 3D model always helps you in planning. So in this case, one side I did C1, C2 fusion, and the other side when I was doing C1, C2 fusion, and when I was doing the reduction, the C1 screw came out, and for the rescue procedure, other side I had to do a OC2 fixation. One side. This is post-op images. So one more case where this was easy to do C1, C2 fixation with the placement of spacer. This another case where again the C1 was occipitalized and both vertebral arteries were crossing through the joint. You can see here. Same thing here also the vertebral artery mobilization was done and we can see the amount of AAD and BIR. AAD is reduced very well in the post-op images. Another case which was a very difficult and complex anatomy, even in this case, I did not try to even go for the C1, C2 fixation of my earlier cases. There I did OC2 fixation with a good amount of foramen magnum decompression. So this was about C1, C2 fixation for complex CJ, but what about Arnold-Chiari malformation? What is our plan? Because there is always a debate whether to do only FMD or FMD plus C1, C2 fixation or only C1, C2 fixation. So in my cases, now I have started doing C1, C2 fixation. And like this case where the anatomy was little difficult because the C1 lamina, C1 posterior arch was absent and the vertebral artery was exposed. So I have mobilized drilled the C1 lamina and opened up the joint and placed the C1, C2 screw and good amount of reduction was achieved. So this post-op images. In the same another cases where the abnormal anatomy was present, where the fusion was achieved by C1, C2 fixation.
Please conclude.
Yes. So complications I encounters were wound essence, post-op ventilator support was required. Dural injury in one cases, there was necrosis of skin flap where I have cut down the C2 nerve root. So lesson what I learned was most important, the pre-op radiology with 3D reconstruction is important and whenever it's required, always use a 3D bone model. Try to preserve C2 nerve root, but whenever needed, I used to cut it. And pre-op discussion with radiologists is very much important and continuous learning process is important. Thank you.
Thank you. Thank you, Dr. Arvind. We'll move
Can I
on to
have one question, please? I mean, you have gone through all this and there were complications. You see, there is an excellent technique in complex situation where you go transarticular.
Yes.
Transarticular C1, C2 fixation is a safe, much easy, and gives very good stability. If you start from C2, sit C1 and go up. Magal's technique, go and read that. That gives an excellent fixation in these complex situations, and you don't have to then dissect all that and do all those things because there's a lot of issues with the complex anatomy also. And secondly, it's not well established that in every case of syringe you have to fix the spine, and I know Dr. Goyal talks about it. It's not accepted universally, and most of us we do that. The decompression of these the area, it works very well. The syringe disappears. So it's not always mandatory to fix
Yes.
it. There's no logic still established in the literature as a first-hand evidence on that.
Thank you, sir.
Thank you, sir.
Thank you, doctor. Any more questions? Yeah. Thank you, Dr. Arvind. We'll move on to the next paper. We invite Dr. Arvind Bhattaja from Bangalore to talk on future of CVJ surgery. Dr. Arvind.
Good morning, everyone. I'd like to, first of all, thank Dr. Manas and Dr. Savitar for the opportunity to be here. I don't know whether I'm going to be able to talk about the future of C1, C2 fixation or CV junction surgery, but I just share our experience with a few cases of minimally invasive C1, C2 fixation. So why should we consider MIS? In my opinion, patients do suffer from quite a lot of postoperative pain, especially with linear longitudinal incisions where the muscle is being reflected off the occiput, right, all the way from the inion till C3. There is definitely, I don't have evidence for this, but there is probably better preservation of muscle function. The posterior tension band is definitely better preserved. There's possibly a lower risk of infection, although not enough evidence to say so. And most of our patients were mobilized the same day and were discharged within 24 hours. Few important considerations when we began using minimally invasive techniques for C1, C2 fixation. One is we preferred if the cases were relatively straightforward, reducible, with a minimal rotary component, ideally patients without basilar invagination or C1 assimilation, patients who did not have Chiari malformations because that obviously required further decompression, which was probably not going to be easy for us in our early cases with minimally invasive approaches, and patients with aberrant vertebral artery anomaly. So we have a few cases which we have just started doing. I think our experience is about 6 months old altogether. Requirements that we think are important and which we use regularly for these cases is rigid head fixation. So we use neuromonitoring, fix the head in head pins, and try to reduce the atlantoaxial dislocation using the head pins and traction soon after positioning under the under neuromonitoring. O-arm and navigation guidance is definitely very crucial in these cases, in my opinion. We use expandable retractors with the muscle splitting approach. Microscope, of course, to section the C2 root, define the joint anatomy. One very important component is the navigable drill, which is down there in the corner, because that is something that prevents too much manipulation of the CV junction, particularly when we are drilling the screw holes, because any movement can alter the navigation data and cause errors in navigation. And of course, since we are not harvesting any bone, native bone, then we need to use allograft as well. So just a brief reminder of the muscular anatomy of the posterior cervical region. So first we have the trapezius, then the splenius capitis, and then just to define how we dissect the muscle fibers along their length, along the course of their fibers. So this is a case of atlantoaxial dislocation, fairly straightforward one. And this is the MRI showing cord changes at the C1, C2 region. A brief video showing how using the O-arm and navigation images, we use the navigable drill, create the pilot holes, and we can actually measure the diameter and the length of the screws that we intend to use by measuring it on navigation. The post-op X-ray of the same patient. Another patient with reducible atlantoaxial dislocation with an os odontoideum. These are the CT images. This is the post-op image. Case 3 was a very sick patient who required post-op ventilatory support because of extensive cord changes in the CV junction. This was a child, so we ended up using a C2 laminar screw on one side. And as you can see, the laminar screw actually pierced through the lamina into the canal, but there was no neurological consequence as a result. Patient is doing fine and we achieved a good reduction. This is a video of how we prepare the facet joints, again using the navigable drill. So I prefer to use the same retractors that we use for anterior cervical surgery, the trimline retractor system, because I feel it's radiolucent, it's easier to get C-arm images. I just need to retract medially and laterally and we get good exposure of the joint and the anatomy. This is placement of the screws. Once the pilot holes are created, then the joint is drilled, bone graft is packed, and then the screws are placed. This is the post-op image of the same patient. If there are any questions, be happy to take them. Thank you.
Thank you, Dr. Far.
Dr. Bhatia, just one. Can you show us the steps from the beginning and how is it different from the open procedure? The steps from the skin incision onwards.
So we usually mark the skin incision using the navigation itself, that we make sure that we're right on top of the joint, because we really don't need to expose the midline structures in reducible atlantoaxial dislocation. So once we make the skin incision, then I prefer not to use any dilators, because again the anatomy there is quite delicate. So I prefer to use small Langenbeck retractors and under magnification dissect the muscles, reach the joint. Again, at each step we use the navigation to enable us to assess how deep we are. So once we reach some familiar bony anatomy, then I confirm the accuracy of the navigation using visible bony landmarks. Then put in the trimline retractors, create the pilot holes, drill the joint, put in the screws and the rod. First we create the pilot holes, drill the joint on one side, and then we do it on the opposite side. And once that is done, then we insert the bone graft and then the screws.
Yeah.
So the reference arc I showed you in the first few slides is on the head fixation that we use on the patient. Sorry, that slide is gone now, but it's fixed to the head frame.
Arvind, thanks. Great presentation. The question is, you stressed reducible. What happens if the C1, C2 reduction cannot be achieved pre-op?
I think we've so far been able to select cases where it's fairly certain that the reduction will be possible to achieve. We still haven't ventured into doing more difficult cases where the anatomy is different or the anatomy is aberrant, altered, or patients who have relatively fixed dislocations. But hopefully in the days to come, we should be able to try and do that.
Questions. One is an extension of what Dr. Pathak said.
Transarticular.
MIS transarticular screws.
So I have one issue with doing a standalone transarticular is that it does not resolve rotary dislocation or rotary instability. So you usually need to add on a cable construct when you're doing a transarticular. So since we're doing minimally invasive, this seemed to be a better option.
Fair enough. The second question, have you ever had to rescan a patient?
In the OT?
Yeah. Once you've done your initial acquisition, has there been a situation where?
Yes, there are instances where we felt the accuracy of the navigation was inaccurate. So then once we rescanned, then it was okay. And sometimes we can rescan if you have any doubt about the position of your implants, or if you feel that because of drilling the accuracy has changed, then you can always rescan.
Thank you, Dr. Arvind.
Thank you.
We'll move on to the next topic. I invite Dr. S.S. Kale from New Delhi to speak on status of posterior CV junction surgery. Dr. Kale. Not there? Okay. Yeah, then we'll move to the next one. Status of anterior CVJ surgery by Dr. Christopher Gerber.
Good morning. I have to say I'm very disappointed Dr. Kale is not here, as I was hoping to refute his arguments. So maybe he'll have a chance to refute my arguments. I think what I want to talk about today is the philosophy of anterior cervical surgery. I was brought up in the days I worked in London where we did a lot of transoral surgery, and transoral surgery was the operation for irreducible AAD, rheumatoid arthritis, etc. And one of the points here, and I think in India you have a very, very large population base. You get a lot of basal invagination, a lot of operations, much more experience than we used to have in the UK before I came here. And there's papers like this which said that basically transoral surgery is out of fashion. transoral surgery you don't need to do. It's only for people who can't do proper posterior C1, C2 surgery. We've learned about lots of techniques this morning about approach to the C1, C2. But, you know, we have cases like this. This is a case I saw in outpatients yesterday. A young woman, 35, difficulty walking, and on flexion extension X-rays, she's got no significant instability. I haven't put in traction yet to see if it reduces. But she's got a Klippel-Feil abnormality. She's got basal invagination. She's got upward migration of the dens. And I think personally, this cannot be treated purely by posterior approach. And I'll give you the reasons for that in a minute. So what I want to talk about is really the middle bit here, the transoral surgery. There's endoscopic transnasal and there's lateral cervical. I'm not going to talk about those, but my experience is mainly in transoral surgery. And as I say, in the 80s and 90s, it was a very popular procedure. This is the first description of it was in World War One, where there was a soldier with a bullet wound to the oropharynx, and it was the first documented case of transoral surgery. Then it was advocated for platybasis. As neurosurgeons, you've all heard of Schofield. He's done the aneurysm clips, etc., etc. And he published a series of 10 patients. And at that time, he also mentions the possibility of transoral surgery. But what people miss is the fact this was just a description in a cadaver. He never actually did a transoral operation himself. So that hasn't come out, but in the 60s, it was popularized by Fang, mainly for pathology of the CV junction, tuberculosis. But what he found was a very high mortality. 3 out of a patient, 15 patients died. And this is where I come from, working in London, Maida Vale, Queen Square with Alan Crockard, who you probably heard of. And it was a really sexy thing at that time. In the 80s and 90s, really sexy. We even did it for aneurysms. And we did transorally. This was in the days, obviously, before endovascular surgery. We did approaches to the skull base and clipping of aneurysms this way. There's one case, infamously, which the problem is every time he tried to swallow, he became unconscious because of vascular compromise. Each time he swallowed, the aneurysm clip would wiggle up and down and block the artery, the vertebral artery. That wasn't a very successful surgery. And this summarizes the status now. This is, again, it's Alan Crockard's paper. When he first started doing it, it was very popular in the 80s and 90s. Then it died off. So instead of doing, when I was at Queen Square, we were doing 2 or 3 a week. Then by the end of the 90s, early 2000s, there was like maybe 10 a year. And the reason for that was because the rheumatoid arthritis, which was like the mainstay of all the operations, the actual surgery indications died off with the advent of, first of all, disease modulating medication and also posterior cervical techniques. Again, look at posterior cervical techniques. In my day, we never had C1, C2 screws. When I was training, it was always loops. So you had to do occipitocervical loops. You had to do all sorts of things. And they only had like 3 or 4 C1, C2 screw fixations. This was the very early days of surgery of CV junction. So what happened? This is probably all well known. This is Scott's parabola. This is actually from a gynecologist. What happens? You have a really new, exciting technique. Everybody starts doing it. Then you get complications. Then basically it's the person who invented it starts doing it. And he sits down in the coffee room with his juniors, say, this is a wonderful operation. We don't do it anymore, blah, blah, blah. But what's happening now, it's coming back in favor. So again, this is Dr. Chandra's paper. And the big thing now is endoscopic. Everything in spine surgery is becoming endoscopic these days. It's been around for a long time. And this, I think, has reinvigorated the use of transoral surgery. And there's different techniques. I won't go through all the techniques of this because this is beyond the remit of this paper. But what they found, this was a cadaver study. they found that the actual area you could see with the endoscope was much higher, the exposure was much better than compared to microscopic surgery. And I have to admit, I don't do endoscopic spine surgery. I'm too old-fashioned from that point of view. But what the big advantage I see of endoscopic spine surgery is the actual view you get at the end of the endoscope. Otherwise, the operation pretty much is the same, and you can do with the endoscope what you do with a microscope. That's my view. Again, but there's still surgeons doing transoral surgery. The first paper we had this morning, 5% of his patients had transoral surgery. So it still happens, and it's coming back in fashion. I think, again, this is a paper from locally here, which they did 146 patients, 6 patients of which had transoral surgery, and they list the indications for transoral surgery there. Again, this is for 2024 paper, I think, from China. Again, transoral surgery. It's coming back in fashion. I think the reason it's coming back in fashion is because usually the patients you operate on have a fixed deformity. So this is ideal for endoscopic surgery. It's ideal for neuronavigation. It's ideal possibly for robotic surgery. And again, these are the different approaches. I won't have time to do that. So we're moving on. We haven't much time. This is where we're at now with transoral surgery. It was a big hype right at the start. This is Gardner's hype loop. You must have all seen this. Big hype at the start, then there were problems. People stopped using it, but now it's coming up again. And I believe that there is more and more of indication for transoral surgery, particularly in these cases. If I go back here, this will be my final slide. If the patient has irreducible or non-reducible AA dislocation, basilar invagination, I think that transoral surgery should be indicated right at the start as opposed to a salvage procedure, which it is done at the moment. Thank you.
Thank you, Dr. Christopher. Any questions?
Thank you for bringing this issue. I think there is still a lot of indications for transoral surgery.
Yeah.
Rheumatoid arthritis is one.
Yeah.
Where CV junction involvement is very common, with the penis sort of pressing on the CV junction. That's a very, very common indication in my understanding. And now that a lot of fixation of the C1, C2 is being done through transoral route. That's from China. And I've done a couple of them, which goes very well actually. There's a fear that if you go transoral and fix the CV junction, C1, C2 by transoral route, there will be infection. At least I've done 2 cases, nothing happened.
Yeah.
So the Chinese are coming up with that idea that it's more safe corridor and you can still fix the C1, C2 by that route. So that's there already.
I just asked the audience a question. Who now is still doing transoral surgery? Maybe, 20%. And I think most of the people are older people. I think it's something the newer generation, the tuberculosis. But I think I haven't talked about pathologies of the CV junction other than AAI or anything like that. But I think TB, I still use it. Rheumatoid, to me personally, rheumatoid is like a last indication, because most of the time with posterior fixation and disease modulating drugs, it's enough to seal. The other indications I have are, there was a case we saw this morning about traumatic osteodontoidum, fused, irreducible, a lot of cord compression, and this is the case I have here. I did transoral surgery, and there's I won't show you the video, but basically I did a front and back approach to the same sitting, and it doesn't take very long at all. But the slides have gone. But I think this is probably where robotic surgery is going to come. If you have irreducible, you have fixed bones, robots are going to work much better than they are. For example, we had the previous minimally invasive C1, C2 fixations where the structures are mobile, then robots there aren't as useful.
Thank you, Dr. Christopher, for an excellent presentation.
Has Dr. Kale arrived? No? If not, then we will move on to the next speaker. I'll invite Dr. Ashutosh Kumar from Lucknow come and give his talk.
Morning, everyone. I'm Dr. Ashutosh Kumar, Assistant Professor, Department of Neurosurgery, SGPGI. Today, I'll be talking about three anomaly problem. It is quite often in syndromic atlantoaxial dislocations that there are associated vertebral artery anomalies. A conglomeration of such anomalies result in a heightened surgical risk in these patients. So I'll be discussing my experience with these anomalous craniovertebral junctions. So one of the these are the three anomalies that we may encounter and commonly be encountered in case of Klippel-Feil syndrome. The first one is a persistent first cervical intersegmental artery. In this anomaly, it is the V3 segment of the vertebral artery which is anomalous. It tends to run below the C1 arch and courses over the OC1 complex and the C1-C2 joint. This precludes a safe corridor to the C1 lateral mass and the C1-C2 joint. The second of the anomalies is a high riding vertebral artery. The high riding vertebral artery has a very narrow isthmus. Because of this, a C1-C2 transarticular screw or a standard C2 pedicle screw is contraindicated because the risk of vertebral artery injury is very high. As you can see, especially in case of sandwich CVJ where the C2, C3 is fused, the course of C2 pedicle screw will actually go through the C2 vertebral artery foramina. The third of the anomalies is a sandwich craniovertebral junction anomaly. The sandwich craniovertebral junction anomaly is a subset of Klippel-Feil syndrome where the C1 is assimilated and C2, C3 are fused. The surgical nuances associated with this sandwich CVJ anomaly is that the OC1 complex is often very small in volume, such that the C1 lateral mass purchase will be very difficult. Also, the corridor is narrowed because the foramen magnum is very much close to the C2 spinous process. So, I'll be discussing the surgical nuances and management of such cases with the help of this illustrative case. Over the last 2 years, I have operated over 24 cases of sandwich CVJ with encountering a high riding vertebral artery in 14 cases, and though the cases who had all these three anomalies were around 7. So in this case, this was a 26-year male who had presented with features of high cervical compressive myelopathy, and he has restricted respiratory pattern also. On MRI, there was cervicomedullary compression and features of Chiari malformation. CT CVJ was suggestive of atlantoaxial dislocation and a high BI. The flexion extension CT suggested there was no reduction. The C1-C2 joints on both the sides were asymmetrical. 3D reconstruction of the CT images is a very key investigation in all these procedures. It is very clearly seen in this case is that the C1 is assimilated, the C2, C3 are fused, and we have a very narrow isthmus on both the sides. The vertebral artery on both the sides is coursing over the joints, and on the left side, the vertebral artery is even dysplastic. So we had a diagnosis of high cervical compressive myelopathy in a syndromic case having bilateral anomalous vertebral arteries, and we had planned for a C1-C2 fixation. Now, what is the rationale for doing a C1-C2 fixation? Here, because the C1-C2 fixation gives a robust construct, and secondly, C1-C2 joint mobilization is essential because we need adequate neural decompression. For achieving both these surgical goals, it was essential that we do a bilateral vertebral artery mobilization. So this is the surgical video. We have positioned the patient a little bit different from the usual cases, and it was in neutral, and a traction was applied. The first step is to resect the overlying soft tissue, and afterwards the C2 ganglion is exposed. Then, using subperiosteal dissection, the margins of the vertebral artery foramina are defined all around. This is the first step in vertebral artery mobilization, essentially because this is the point where the vertebral artery is most consistently found. On the medial side, over the vertebral artery, the joint capsule makes a thin sheath of tumor, and it is to be resected with dissectors. Here, this is the proximal part of vertebral artery being dissected from the overlying soft tissue, and now we are dissecting the C2 ganglion. The C2 ganglion is dissected all along its course. On the proximal part of the C2 ganglion, it is very important that before cutting, we dissect it completely from the vertebral artery. Just below that, you can see the vertebral artery is present. Then the C2 ganglion is completely resected in these cases. This gives a wide corridor into the C1, C2 joint. The overlying soft tissue is then resected. Then using caving it technique, the rest of the vertebral artery is scalinated. This is on the medial side, the joint capsule. Now we are cutting it. And once the joint capsule is removed, we have a wide access to the C1, C2 joint. Then, using a dissector, the vertebral artery is mobilized cranially to access the C1, C2 joint, and with the help of a 15-number blade, we can resect the end plates very well without any risk of vertebral artery injury. In these cases, the end plates are thin, they can be very easily removed. In limited access areas, we can use a drill. In these cases, we had to use extensive drilling only in few cases. Then reduction is done using SGPGI technique and bilateral spacers are inserted. Insertion of spacers help in immobilizing the C1, C2 joint and then helps in insertion of the screws. For insertion of C2 pedicle screw, we use a modified technique called C2 direct pedicle screw. For this, a limited mobilization of vertebral artery is done within the foramina, and then the C2 pedicle is completely exposed. The entry point for this screw is the anterior and the medialmost part of the vertebral artery. The trajectory is cranially and going parallel tangential to the C2 pedicle. There is no bony breach, and then we proceed with first C1 screw, lateral mass screw placement by caudal mobilization of the vertebral artery. Afterwards, before putting the C2 screw, we need to prepare the base for the C2 tulip. By preparing this base, we confirm that the screw is going till the base of the tulip. This gives a divergent construct which is mechanically most robust. This is the post-operative course. Of course, the immediate post-op was very stormy. The patient needed tracheostomy and RT feed, but by 2 years of follow-up, he was well to do his all routine activity and was self-ambulatory. So this is the post-operative radiological outcome where the BI is completely reduced, the ADI is reduced. The importance in these cases is the insertion of C1 lateral mass screw. If it's too much cranially directed, it can go into the hypoglossal canal, causing a transient 12th nerve palsy, which we had encountered in this case. These are my references, take-home message, and you can find this whole video on operative neurosurgery. Thank you very much.
Thank you, Dr. Ashutosh. Any questions? Yeah. Okay. If there are no further questions, thank you. And I see that Dr. Kale has arrived. I would like to welcome him to give his talk straight up. We've had the status of anterior CV junction surgery already finished. So I'd like him to give his talk on the status of the posterior CV junction surgery.
Can I have the slides, please? Just upload it. Does it come here? इधर आता है क्या? Anyway, good morning, ladies and gentlemen. Apologies, I think it got preponed by a few minutes, so I was kind of caught unawares. Anyhow, so today I'm just going to go over some of the. उधर जाना है. So how the approaches to the CV junction have evolved over the last few decades. If you look at history, The first surgical interventions in the CV junctions were done from the back. It was all posterior surgery. There wasn't any anterior surgery. And hence the kind of ironical title, Back to the Future. We are now back in CV junction surgery. We are back again to the back, and we have stopped doing anterior surgery, or at least that is what Dr. Goel would have you do. No front surgery. That's what he says. Anyway, let's look at what happened to back surgery or surgery from the back for the CV junction. So the problems, as we all know, is instability at the facets, malalignment, lax ligament, whatever ligament injury, infection, destruction of the ligaments or the joints, leading to high mobility of the joint, difficult to achieve adequate fixation because of the difficult area or difficult access to that area. And you have a downside to it. If you manage to fix it, then you lose some mobility. You lose some important movements at the CV junction. And there are risks in the exposure. As it was very nicely demonstrated how sometimes you have to move the vertebral artery around to get at the joint. So it's a challenging thing. And not just the bone, sometimes you have other problems to deal with. For example, a Chiari or a syringomyelia or a syringobulbia. And earlier, there used to be a concept on X-ray, if you see mobility, you call it reducible. I mean, it reduces, it moves a little. And if it doesn't, you call it fixed. And I remember Dr. Jan used to have a very nice lecture, what fixes the fixed AAD. You know, he tried to explain that why we call it fixed AAD many years ago. But that was a very important conceptual learning lecture for me. That why, and now because of the new approaches, this reducible and fixed kind of have become redundant words. So the first description of a C1 C2 fixation goes back to 1891. You know, somebody just tied the joints together. They tied the two bones together. Osgood and Mixter used braided sutures. And in 39, galley fixation was the first thing, the C1 C2 laminar wiring. But these were all semi-rigid constructs where there was still movement. All the three axes were not fixed. And hence, it gave rise to a lot of problems, as we all know. And I think we have been, most of us who have gray hair or no hair, I see many of them here, have been through these operations. You know, earlier we used to do these galleys fixation, very simple surgery. You fix the ring of C1 to the spinous process of C2, you put in a nice chunk of bone in the middle, and it fuses quite well. It works well most of the times, but it doesn't fix in all the three axes, and it sometimes gives rise to breakage of the wire and slippage of the graft. Then there were modifications of this. There was this Brooks fixation, then the Dickman Sontag, all kinds of things. One side, both sides, one wire, two wires, under the C2 lamina or under the C2 spinous process, all kinds of variation. But essential, the purpose of this operation was to fix the C1 ring to the C2, either to the lamina of C2 or to the spinous process of C2. These were quite popular when I started doing CV junction surgery. You know, these Halifax clamps, you just put one over the C1 ring, one under the C2 ring, and then you tighten it and it holds together. But as you can see, it can move in the other axis. It doesn't stabilize it completely. And then we must not forget Dr. Jain's technique. It was an ingenious technique, especially where the C1 was fused to the occiput. You know, you would wonder what to fix to what. And then to avoid the joint, he used to drill away some part of the occipital bone to make a channel, to make an artificial C1, he used to call it, and then fix the C2 to that C1. So that worked very well in his hands. And especially when there is the C1 arch is missing or it is occipitalized, this is a handy technique to follow if you don't want to open the joints and you don't want to fix the joints. So this Jan's technique also became popular, and this was published in quite a few journals. But all these are ultimately semi-rigid constructs. There is no screw going into the bone. And unless you have a screw going into the bone, the orthopedic principle says that these are semi-rigid constructs and a certain number of failures are bound to happen. So the next step, what happened? Okay, so two people simultaneously developed techniques to fix this C1, C2 joint. One, our own Dr. Goel in Mumbai. He used a small plate, which I will discuss later. And Dr. Harms in Germany, he used screws to put it into the C1 lateral mass and the C2 lateral mass and fix them, those two screws with a rod. And then if you couple it with a bone graft in the middle, it works very well. You get a 3-point fixation. And Dr. Magel said, why put two screws? Why not just put one screw? One screw through the joint. It goes through the parts of C2, goes through the joint, it goes into the lateral mass of C1, and you're done. You don't need 4 screws. You just use 2 screws and fix the joint. And in his hands, in the huge Magel series, I remember, I think the first publication, Dr. Magel, was 160 odd cases of this transarticular fixation and very little number of complication, very small. But as you see that hole in the vertebra, that's vertebral artery there can be a little bit dangerous. And if you have a high overriding vertebral artery, then you would have trouble in putting the screw in the right place. And the risk to the vertebral artery are ever present, and it can be a dangerous complication. But it worked well in his hands, and it became gradually it became popular all over the world, and many people still use it. It's a very handy technique to know, especially if the vertebral artery is not overriding and you have a good pars, or if you have a good pedicle, the C2 bone is adequate, at least 5 millimeters wide. You can safely put a C1, C2 transarticular screw. And if you couple it with a Galli's fixation, a bone between C1 and C2 arches, it works very well. It gives you immediate 3-point stability. That's the overriding vertebral artery I'm talking about. So if this loop goes high up and you have very thin bone here, then your screw, which is going to go from here through the joint into the C1, is going to hit the vertebral artery. So you must look at all the images in the CT, sagittal images, and see that you have enough bone here. And then you had these posterior fixations, rigid fixations, use the occiput, use C2, C3. This is the easy way out if you don't want to get into a messy affair with the vertebral artery or the joint. You fix above and below, you're done. You're done. And many times it really doesn't make much of a functional difference if you fix the occiput to C2, 3. So in young hands, in inexperienced hands, this is a safe way out if you want to avoid the C1, C2 joint and the vertebral artery. So this is what Dr. Goel did. He used small screws and small plates, and it worked very well. Basically, it fuses the joint. The main thing is the bone which he shoves between the two articular surfaces. And once it fuses, it really doesn't matter whether you used a screw, a small screw, a plate, a rod, whatever. The bone has to fuse. So the essential step in this surgery is the fusion. So this was Goel fixation. Much has been talked about, and now Dr. Goel says it is the panacea to all illnesses of the CV junction. Everything you just do a C1, C2 fixation. Sometimes it does work, but I don't know if it works for all the cases. So just some beautiful pictures to show you exactly what happens in this. There are disadvantages though. You have some of the disadvantages. You really dissect off all the muscles if you want to put screws C1, C2. And sometimes you get into the joint without mobilizing the vertebral artery, but sometimes you have to. The vertebral artery can be a little bit tricky, or at least the venous plexus around the vertebral artery can be tricky. So if the C2 pars is not so good, you can use the lamina, and you have these screws going crossways and still fix it up with the C1 screws and work. And then we moved a step further, manipulation of the joint. You reduce it or you drill away. And I think Sharad from my institute in Delhi and Praveen Salunke from PGI Chandigarh, they have contributed significantly how to make the joint come to a better shape so that it can take a spacer. And both of them used slightly different techniques, but the essential concept of both these surgeries is the same. You get the joint, you manipulate the joint so that it gets into a proper shape for a spacer to be put in over there. And then you do the same thing. C1 lateral mass, C2 parse, and you fix it together. I think he's also trying to develop a reducer, which is a little bit complicated still. But once a universal reducer is there, then these things will become much easier for everybody. So they developed some joint indices, they did some studies, and that's how they came up with these two surgeries. However, the simplest and the safest one of the surgeries here, if you don't want to get into the joint or the vertebral artery, is fix the occiput to the C2 or C3. So there are difficulties, risk of vertebral artery injury, subsidence of the cage can subside. If you drill away a lot of cortical bone of C1 and C2, I'm sure the cancellous bone there is not going to hold the cage. So it's going to wobble. You need all kinds of monitoring. So ultimately, we have come back to this surgery from starting from posterior surgery, going through anterior surgery, which has been discussed by the previous speaker. And today we have come back to the future that you need not go anterior at all. You can manipulate everything from the back and simple surgeries. I must not forget to mention Dr. Patkar and his innovation of what he says that you fix the joint, but you do it from the anterior side. That is also a useful technique to know, and it works very well. In his hands, it works really well. He says it's a simple technique. I've never done it, but you can try that. And I think I've overshot my time, but I think briefly I tried to give a picture of the past, the present, and the future. Maybe the future is joint replacement, gentlemen. If we can somehow reproduce the C1, C2 joint, that will end all our troubles. It will not sacrifice mobility, and it would work just like a good knee joint or a hip joint works. I think that's the way the young people should think about how to replace the C1, C2 joint. Thank you for your attention.
Thank you, Professor Kale. Any questions? Yeah, Dr. Christopher.
Rebutting your impressive. At any times these days we still do anterior transoral surgery.
I actually this talk is it's a teaching talk. It's a bit longer. It discusses anterior as well. So there are a few indications still. For example, if you have a tubercle in the front, if you have a huge abscess in the front, you can go on fixing from the back. But if there's pus or there's a cold abscess in the front, you'll have to go anterior. There is no way out.
Yeah.
1, 2. If there is a huge pannus in rheumatoid arthritis, which is pressing on the CV junction, causing neurological deficits, causing swallowing problems, you cannot wait for 3 months for the fusion to occur. The patient will die before that. So then you have to go anteriorly, remove the pannus, and then fix posteriorly. But the indications are definitely getting lesser and lesser as our techniques become better.
If no more questions, thank you, Professor Kale.
Thank you.
Yeah, we'll move on to the next speaker. I invite Dr. P. Hemant from Hyderabad to speak on outcome of surgery with extradural FMD and Atlanta axle fixation with FMD and duroplasty.
Good morning, everyone. I'm Dr. Hemant Kumar from neurosurgery resident. A comparison of outcomes of FMD with duroplasty and FMD. So, KRE malformations are associated with herniation of cerebellar tonsils below the foramen magnum and abnormal cerebrospinal fluid flow dynamics. So, foramen magnum decompression is the gold standard treatment for symptomatic cases with the presence of syringomelia. But in 2003, article quoted by Sacco and Scott reported that 17% required reoperation, but this rate reached up to 30% in the literature. The technique and limit of effective decompression are still controversial. And in 2009, quoted was symptomatic subdural hygromas and hydrocephalus developed following decompression. So FMD only foramen magnum decompression with the duroplasty associated with complications like in postoperative, like a subdural hygroma or hydrocephalus may develop. So this may, while surgical intervention may be necessary in some circumstances to treat these complications, while non-operative measures may be effective as well. In 2019, Atul Goyal quoted that atlantoaxial instability is the prime factor in the genesis of KRA malformations, even when there is no abnormality, no bony abnormality in the craniovertebral junction. So, on treatment wise, KRA malformations, that C1, C2 distraction and fixation was followed with. Foramen magnum decompression without bone removal and C1, C2 posterior fixation for Chiari with congenital atlantoaxial dislocation with basilar invagination was later said by Salunki. Is C1, C2 and FMD may fail even with gyroplasty, and the treatment of Chiari malformation in recurrent cases is still controversial. Recently, atlantoaxial instability has been reported to be the main pathology of Chiari malformation, and cure for the pathology is to treat the instability. So in UK, there is a practice going on now, and there is a wide variation in pre and intraoperative management of Chiari malformation, and many neurosurgeons are willing to participate in randomized controlled trials, comparing bony decompression alone versus dural opening with or without gyroplasty. So, is there any superior surgical technique for Chiari malformations type 1? And the rate of revision surgery was highest in patients who had a bony decompression without dural opening. So, rate of postoperative complications were highest in durotomy group. So, overall, in this study, duroplasty had the best results. So, in my study, foramen magnum decompression with duroplasty traditionally described for the management of Chiari malformations, but recently described C1, C2 distraction with fusion has sparked controversy. So C1, C2 fusion has been reported to be more effective than traditional FMD, but the results of this procedure are not being well validated. Hence, in my study, we want to validate the results of C1, C2 distraction with fusion by comparing with the traditional FMD in terms of postoperative surgery pain and complications and serings and Chicago Chiari outcome scale and recurrences. So my aims and objectives are compare outcomes of these two techniques, foramen magnum decompression with duroplasty and without duroplasty, along with C1, C2 distraction bony fusion, which is study was done at Kim's Hospital, and it was a retro and prospective study. Collected data from May 11, 2017 to till now. All patients who underwent foramen magnum decompression for Chiari malformations with these two techniques are included. So this is a Chicago Chiari outcome scale, which was included is pain and sensory symptoms and functionality and complications, and total score was highest is 16, which was excellent score. It was resolving all pain symptoms, and sensory symptoms are resolved like numbness and everything, and functionality is fully functional and capable to all his work, and without complications in postoperative status. So my case is 35 years old female with the presentation of left-sided neck pain since 6 months, radiating along outer aspect of left upper limb till elbow, which pain has aggravated since 2 months and unable to her daily activities, and history of giddiness present and compelling her to sit, and history of swaying while walking noted to all directions, and no history of trauma or fever or bowel bladder symptoms. So an evaluation with MRI, we have found to have Chiari malformations, and it was an X-ray, and postoperatively that we have done X-ray to see whether the symptoms are resolved or not, and postoperative outcome is good, and postoperative there is no complication and patient discharged on POD3. And second case is 56-year-old male patient with pain along occipital region and neck and upper mid-back region since 1.5 years, and aching type of pain which was progressive, associated with right hand paresthesias, and history of progressive flexion deformity of and right fingers, and unable to grip objects with the right hand, and history of constipation present, and no history of trauma or fever, His power was 4 plus in all limbs except in right elbow. It was weakness is present, and right hand deformity and right hand gripness weakness was present. So an evaluation with MRI which was shown here, there's a KRA malformation with cervicodorsal serines can be appreciated. Sir. Cervicodorsal serines up to D11 to D12, which is appreciated. On X-ray, it was showing the in C1, C2, there is no rotatory AED, or we have excluded rotatory AED, Atlantic axial instability or dislocation, and underwent surgery. And postoperatively, that pain was relieved, but symptoms are still persist. That grip weakness are still persist. So we have discharged in POD3 without any postoperative complications. And my results are based on this. Mean age of diagnosis of foramen magnum decompression with duroplasty is around 31.5. Our C1, C2 distraction fusion patients are 32.8. With this prolonged stay in hospital is more with duroplasty, and postoperative pain and complications are also high with the duroplasty. But so cranial nerve symptoms improved in most of the patients, and recurrence was actually less in duroplasty patients. The cranial nerve symptoms improved in most of the patients, followed by cerebellar related and pain related symptoms like improved. Motor symptoms improved in the least number of patients. The symptoms that most significantly improved were hoarseness, nausea and vomiting, and dizziness and headache. Symptoms that least significantly improved was muscular atrophy. So, my conclusion is Chicago GRE outcome scale was 73% in FMD with C1, C2 distraction, and with duroplasty was 62%. So, rate of postoperative headache, nausea, syrinx was highest in duratomy group, and recurrence is somewhat highest in C1, C2 distraction patient. Overall, C1, C2 distraction fusion had the best results so far. And we have a limited data, so we need more of the data to add in and follow it up.
Thank you, Dr. Hemant. Just one question to you. How did you decide which procedure to choose for which patient? Patient comes with Chiari and syrinx, and there is no instability. How do you decide you want to do a upfront FMD versus a instrumentation? What is your decision based on?
MD is.
And we need to see some post-op images of both the groups. Follow up.
Yeah, means here the the concept is not that instability is there we are fusing. Here the concept is distraction, because carry is because of baseline invagination. So what the principle is distraction, and to maintain distraction you have done fusion. So it's not only fusion. So distraction, if you have a retroflexed odontoid, it gets corrected when you distract. When you have baseline invagination, it gets corrected. So then in turn they have a better recovery. And that's what we use the Chicago score to compare with and without distraction patients. Either either they have a retroodontoid or asymmetric lateral mass. Baseline invagination was there. Yeah. Right. Means the treatment of Chiari malformation means any procedure you do, it works. That's what people tell. You don't do anything, also it works. So we wanted to improve our results, and because whatever we were doing all these days only FMD, and then still we had unhappy patients, and then we thought that if we distract also in addition to FMD, they'll do better. And this is for the past 1 year we are doing, and then we are getting good results. So it's an ongoing study. Maybe 3-4 years later, I can answer more. Without, without also we are doing. With- Yes, we distract not with, we put only bone graft. Bone graft with, we actually cut the C1 arch and the C1 arch into two pieces like a shape like a peg and then impact it in the joint. So because the C1 arch is very hard, it distracts. We don't put any foreign body. Yes, sir.
I think you have to have the concepts clear. In the West, Chiari malformations have hardly any CV junction anomalies. Because I've worked there for 8 years, I know. Here, of course, there can be a combination of anomalies and Chiari malformation. And the term Chiari malformation there is called as hindbrain herniation because of this small compartment, the posterior fossa. So if that is there, just a simple foramen decompression is the answer. If an anomaly, then of course you have to think about fixation, things like that. So conceptually, you have to study the case, individual case properly, and then decide rather than making a random sort of effort to fix everything.
No, we accept that, sir. But upfront, uncomplicated carry with syrinx. Do we go an instrument in the first case, or I mean, first instance? I have my reservations for that.
We don't instrument. We put a peg graft and leave it with just a collar. No instrumentation.
Even
It's
that, is
only
it required?
distraction.
That's my question. Is it required for an uncomplicated case?
But that is what we are doing the pilot study. No, I mean, and our results are at least in the initial results are better.
So I have a comment here. So till now, I guess debate is about that there are two group of carry malformation. One is the carry without any BI. One is the carry with BI, right? So everybody is very clear that the carry with BI will definitely will get advantage with the distraction with or without foramen magnum decompression. Now debate is without carry, we should go for distraction or not. So we had some study in SCPJ also in which the 400 patient operated and reoperation rate was 18%. These are those patients in which carry malformation without distraction we have operated. After that, that 80%, 18% underwent fixation, C1, C2 distraction, and out of that 90% improved. Those with carry malformation, without any anomaly, were only FMD, underwent FMD. Out of that 18% underwent complicated after surgery. Then in second stage, they were underwent fixation and 90% of them were improved. So maybe we find something about that. We cannot conclude it, but still, yeah, it may. So maybe in carry malformation, maybe underlying C1, C2 instability is the main factor.
Probably that requires a proper pre-op evaluation in various.
Patients with Chiari, sir, we can in preoperative we can evaluate this flexion and extension CT. Many of these Chiari they will show some type of facetal instability, either type 1 that C1 is moving ahead of C2 facet, or type 2 facetal instability in which C1 facet is posterior to the C2 in one of the view, either in flexion extension. In those cases, we can choose to fix rather than going only for FMD.
Sir, I have operated at this ACM in last 20 years, more than 50 patients. In initial my patients, I was used to do only FMD. But in last 25 patients, I did with fixation. Even there was no instability on dynamic axis and the dynamic CTs. For operatively, I found there is a lot of instability. When I moved the C2 spinous process, there was a lot of moment. So I think it is better to fix rather than only FMD.
Thank you, Dr. Hemant.
I think we are ahead of time, which is good. And three speakers have not come. So I think we'll move on to the next session.
Thank you, all the speakers and the chairpersons. Thank you, sir. We're just moving on to the next session, that is CVJ session 2. I would request Dr. Pratap Kumar, Dr. B.K. Ojha, and Dr. Subbaya Tirupati. Sir, please come on to the stage for chairing the session.
Very good morning. Now we are moving to the second session, that is the CV junction. The first presenter is not here, so we'll start with Dr. Venkata Raju Mandagiri. Our recent experience with type 1 carrier malformation and persistent challenge.
Good morning. Thank you for giving me this opportunity. I am Dr. Rajiv, a neurosurgery resident from NIMS Hospital, and I am going to present our recent experiences in type 1 carrier 1 malformations, which is a persistent challenge. So KRE1, as we all know, it's a like caudal displacement of the cerebellar tonsils from the foramen magnum, which lead to disruption of the CSF fluid and formation of syrinx. Significant advances made in to know, but pathophysiology is still is uncompletely understood, which therefore the lack of clarity contributes to the variability in clinical presentation and challenges in predicting the surgical outcome. Patients with KRE1 may present wide spectrum of symptoms ranging from headaches, pain, neck pain, to the sensory disturbances and weaknesses. And the associated syrinx can further complicate the clinical picture, and often leading to progressive myelopathy. So surgical intervention, as already mentioned, is typically like posterior fossa decompression, which elevate the compression of neural structures. And the surgical management is not always predictable. Some patients experience significant comfort relief, while others continue to struggle with persistent symptoms. The factors of degree of tonsillar herniation, presence and extension of syringomyelia, associated bony abnormalities may influence the success of the surgical treatment. In this study, we
We retrospectively analyzed 62 patients who under diagnosed with ACM1 underwent surgery in 2000 from 2019 to February 2024 in NIMS Hospital, and data analyzed preoperatively with collecting clinical presentation, imaging findings, surgery management, and postoperative outcomes. Demography, most of them are like equally distributed with slight margin of more female patients. Age groups, most of the age is patient presented in between 20 to 40-year-old, which is productive age group of patients presented. And patients usually present within 1 year, most of the patients, and some patients also present after 1 year within. This is a tertiary institute, and most of the people are hardworking laborers. So they come even after prolonged duration of symptoms. Most of the symptoms were neck pain, headache, and also sensory. And some patients, half of the patients presented with motor disturbances, and few also presented with bowel and cranial nerve involvement. On imaging, along with the tonsillar herniation, we see basilar invagination in 14 patients, associated platybasia, and there were 6 patients with axial skeleton abnormalities, with 5 of them having scoliosis, and 1 patient with kyphosis, and 6 of the patients with hydrocephalus, and 1 patient presented with odontodium, 2 patients with AAD. Imaging varied significantly from mild tonsillar herniation to significant tonsillar. First image shows the mild herniation to significant tonsillar herniation with with platybasia, and significant basilar invasion with platybasia. You can varied this imaging is variable. Surgery, most commonly we performed foramen magnum decompression and with C1 arch removal. This is most commonly performed surgery with or without duroplasty. In duroplasty, recently we are using alternative dural substitutes like Duragen, which are giving good results without any complications. And out of 62, we have done only 7 patients we have done fixation, and 4 patients we did syringosurbanoid shunt. Outcomes, we analyzed outcomes in our method, like we like postoperatively we after talking with the patients, they like we categorize them into mild, moderate, significant improvements, and 23% have significant improvement, and mild to moderate is around 50% of the patients having that mild improvements, which is mild in 25% and moderate in 30%. 3 patients worsened, and 2 deaths happens, and most of 16% and 20% of the 10 people doesn't have any improvement. 2 patients had pseudomeningocele, which was managed conservatively and resolved. 2 patients had COSF leak, which reoperated and corrected. 2 patients expired because one because of worsening of symptoms, and that patient has not been followed with us, and 1 patient postoperatively is succumbed with meningitis, and intraoperatively 1 patient had anomalous vertebral artery course and vertebral injury. So these are preoperative image, and first image shows the preoperative post-op image with the with the pseudomeningocele. These are below the patient having persistent of symptoms. We did a syringosubarachnoid shunt. We are patient is still improving. We have 6 patients with scoliotic patient. If any, we conclude that the patient with any axial bone knee deformity like scoliosis, they won't improve much. They won't improve much. They just have mild and moderate improvement, not complete resolvement of symptoms. And fixation, we did see 4 C1 C2 fixation of 3 patients had moderate improvement. 1 patient doesn't have any improvement. OC2 fixation is done in 3 patients, which is mixed result. And shunt has been placed in 4 patients. One patient who initially underwent subarachnoid shunt, later underwent syringopleural shunt, which was revised again. Now patient got worsened and she is not been followed up. This patient, 15-year-old, diagnosed with mucopolysaccharidosis, initially presented with weakness of all limbs and underwent shunt followed by foramen magnum decompression. He is doing well and he also has a YouTube channel, and he asked me to subscribe also. He's doing well. So, to conclude, despite many advances, ICM remains a complex challenge. See, in spite of doing more and more in surgery, the improvement we see is very less. The more surgeries we do, the improvement we find is very less of improvement. And optimal use of additional surgeries has to be further studied. We want to conclude that further prospective studies should be conducted, and formulation of lucid guidelines that to institutionalize guide is our target. Thank you.
The floor is open for discussion. Any questions? If not, let me have a discussion on this. We need dynamic imaging, so that whether the case to be fixed or not. Decide. MRI, at least on X-rays, dynamic flexion extension views to decide on that.
Yeah, sir. We most out of 62, we do only FMD, sir. Only if there is instability, if there is basilar invasion, like significant basilar invasion, then only we go for these OC2. Different surgeons few of them go for OC2, and C1 C2 is done very recently. We are doing more of C1 C2. Upfront, we did only one patient only upfront during C1 C2 fixation, but there is only minimal improvement we saw.
And you showed one case of vertebral artery injury.
Yes, sir.
So what are the strategies you do preventing on this, anticipation or preventing on that, or intraoperatively? What do you do on that?
The vertebral artery, it was happened in 2021. We spoke with the surgeon. They the preoperatively CT, CT angiography was not done. We usually don't do. We don't want to burden the patient. We usually in our institute we usually routinely don't do. It is stopped, sir. Like they said, they stopped.
What I would suggest is that intraoperative Doppler is very useful. Intraoperative Doppler mechanism is very cheap and best to ascertain.
Recently, in our institute, we got intraoperative ultrasound, and we are using Doppler. Okay, sir.
Micro Doppler is available, very cheap also, and it is very, very useful delineating the vertebral artery when you go with these surgeries. Anybody experience on that? Floor can discuss on this.
Okay.
Nothing, sir.
6 patients are having hydrocephalus. So what you have done for that? You have done the shunt, or any patient with post-operative CSF leaks? 4 or 6 patients you have shown you are having hydrocephalus.
Yes, sir. 6 patients we have done. Like we place Omaya shunt. Omaya reservoir placement has been done in 4 patients. Only 2 patients underwent shunt procedure. Post-operatively, we removed Omaya, so that we didn't.
Had any patients with CSF leaks following surgery?
Yes, sir.
Even when you do the neuroplasty, few other patients may develop CSF leaks because there is hydrocephalus is there. Do you have any come across any CSF leaks? Because one patient had meningitis. And what is the reason for one patient was deteriorated following surgery?
One patient, patient she was operated in 2019, she initially she got improved after surgery after FMD, but she was bedridden, and she succumbed because of other reasons. Because the patient, I followed up with with her brother, she told no one, because of lack of patient, someone taking care of her, she succumbed. Other patient, because of meningitis, she immediately in within 1 month he got expired.
Okay. Before the next speaker, there are some few official announcements, please.
Thank you. Some housekeeping announcements and couple of bits of information. We do have a lucky draw running, so the forms are available at the registration counter. Also at the registration counter, we have access to become NSSA Life members. There's a standee with a QR code that will allow you to pay the lifetime fees, and we'll have the registration forms there shortly. So all delegates who are interested in becoming lifetime members of NSSA can move over to the registration counter when free. We also have scrub suits, which are a part of everything that everybody is getting. They can be picked up from the INTA stall. And I also request all the delegates who signed up for the workshops to bring the scrub suits along with them on Sunday. And finally, we have two robots which are fighting each other in the teal room, which is behind us. We have the BrainLab Circ and the Medtronic Mazor. So when free, please check them both out. It's probably the only time you'll get to see both of these next to each other and figure out which one is better. Thank you.
Thank you, Dr. Venkatraju. Now I call upon Dr. Sanraj MK from Chennai, Chair-1 malformation. Do you need to fix it or institutional experience?
Good morning, all. I am Dr. Saranraj, fifth year neurosurgery resident from Apollo Hospital, Chennai. So we all know that the management of carry malformation remains a gray area in our literature. And I'm here to share our institutional experience about carry malformation and its management. So carry malformation is a spectrum of disorders ranging from herniation of fine brain contents to cerebellar hypoplasia with impaired CSF circulation through the foramen magnum. It has been first described by Professor Hans Carey in early 1890. Carry malformation being the most common subtype, which is characterized by tonsillar herniation of 5 mm below the foramen magnum, and it's been commonly seen in adults. And approximately 50 to 70% cases are associated with syringomyelia. Foramen magnum decompression with or without duroplasty is a widely accepted treatment of choice in the current clinical practice. However, of late, C1, C2 fixation with FMD without FMD created a controversy in the management of carry malformation. The regression of syrinx after FMD ranges from 12% to 100% within an average period of 3.6 months. However, the rate of regression of syrinx after fixation and decompression is not well established. So the main aim of our study is to analyze the regression of syrinx in our patients who underwent FMD with and without duroplasty, and in patients with FMD plus C1, C2 fixation. And the patient who underwent surgery at our institute between January 2012 and January 2020 were retrospectively analyzed for a period of 36 months. All preoperative dynamic X-rays, CT angiogram, MRI cervical spine, and post-op MRI cervical spine has been analyzed at the regular fixed intervals of 1 month, 3 months, 6 months, 1 year, and annually for a follow-up period of 3 years. So the mid-sagittal section was analyzed for the syrinx length and the syrinx AP diameter, where the significant syrinx regression indicates more than 75% regression in the AP diameter of the syrinx. Clinical outcomes are also measured using Chicago Carey outcome scale, and has been grouped them as improved, unchanged, worse based on the scoring. So a total of 48 patients diagnosed with carry malformation are included in our study, where 31 were male and 35 were female, and most of them are in 4th and 5th decades. Most of the patients presented with suboccipital headache, followed by paresthesia fans, followed by neck pain, weakness, myelopathic features, small muscle wasting in hands. And the average duration of symptoms ranges from 20 days to 5 years. And the average tonsillar herniation noted was 7 mm, ranging from 5 mm to 17 mm. All of our patients had associated syringomyelia, where cervical dorsal region being the most common site, followed by cervical, dorsal, and 3 cases had ovilocord syrinx. Out of 48 patients, 39 patients underwent foramen magnum decompression, of which 7 underwent FMD with lax duroplasty. 32 patients underwent only FMD without duroplasty. However, the neck constricting band was removed. So 9 patients underwent FMD with C1 C2 fixation, that is C1 lateral mass and C2 pars crus, where 4 patients had associated basilar invasion, 5 patients have only isolated carry-on malformation, that is without any radiological C1 C2 instability. Results of all patients, 83 patients had clinical improvement in symptoms in an average period of 4 months, ranging from 2 to 30 months. 15 patients had persistent paresthesia in their hands even at the end of 36 months. 1 patient deteriorated after FMD on POD2 who underwent tracheostomy and gradually recovered. He developed stridor and breathing difficulty for which underwent tracheostomy and he gradually recovered. We also found that there is no significant difference in clinical improvement between patients who underwent FMD with duroplasty and without duroplasty. FMD plus C1 C2 fixation group was noted to have faster recovery than the FMD group with an average period of 2 months, ranging from 2 to 12 months. The post-operative MRI showing a more than 50% degradation of syrinx and an average of 8 months, where in duroplastic group it is 84.3%, where without duroplastic group it is 74.3%. Surprisingly, we noted that 85.7% of the patient who underwent FMD with C1 C2 fixation have significant syrinx regression, that is more than 75% of the AP diameter of the syrinx within 2 months of the surgery. 6 patients had no regression of syrinx even at 36 months of follow-up. However, it remained stable and patient had no complaints. This is an illustrative image of 49-year-old female who underwent FMD without duroplasty, where the first image showed tonsillar herniation with cervicodorsal syrinx, where this second image is a post-operative MRI after 18 months, where you can see more than 50% regression of syrinx. This is another illustrative image of 35-year-old female who underwent FMD with C1 C2 fixation with you can see a tonsillar herniation of 14 mm, the first image with a cervical syrinx, where the post-operative image showed a significant near total regression of syrinx, that is more than 75% regression of syrinx. This is another 31-year-old female who underwent FMD with C1 C2 fixation, where you can see the post-operative MRI with significant syrinx regression. So to discuss, syringomelia is often present with carry-on malformation at about 50 to 70% of the cases. Various theories has been proposed. The most common and widely accepted was Wolfius theory, where the CSF pressure was from the outside, not within the spinal cord, it's from the outside, where during every systole, the tonsillar herniation happens and there is an increased CSF subarachnoid pressure leading to CSF pushed out from the perivascular spaces and the interstitial spaces into the parenchyma, leading to cavitation and syrinx formation. So most surgeons currently accept FMD with or without duroplasty as a treatment choice of CM1. However, the need for dural opening is still controversial debate, where the duroplasty group showed a higher complication rate in the literature, where the patient underwent without duroplasty had less complication rate. But the point here is the patient who underwent duroplasty has a better regression of syrinx, where without duroplasty, the patient had a less syrinx regression. Although additional procedures like syringotomy, syringopleural shunting, arachnoid shunting, obex plugging, and cauterization of tonsil was practiced by many surgeons, FMD with or without duroplasty remained the mainstay of management. But of late, Professor Goyal proposed a new theory of C1 C2 instability, which being the most common reason for carry-on malformation, and the treatment modality of only fixing C1 C2 has been raised a lot of criticism and controversies in the management of carry malformation. In his 2 case series of 67 and 55 patients of CM1, where patient underwent only C1 C2 fixation without FMD, had significant clinical and radiological outcomes. Our current clinical practice, C1 C2 distraction plus fixation with FMD is only practiced with associated A1 C1 C2 instability or with associated CVJ anomalies like basilar invasion. And it is done primarily to relieve the additional ventral compression rather than the C1 C2 stability. In our case series, FMD with C1 C2 fixation showed better clinical outcomes and faster recovery and significant syrinx regression, that is more than 75%. And the patient had a significant faster clinical recovery. And to note, the dura was not open in this group. So to conclude, the significant syrinx regression and the faster clinical recovery in FMD plus C1 C2 fixation group call into the question whether C1 C2 to be fixed in isolated carry-on malformation without any CVJ anomalies. However, the optimal management of carry malformation still remain the gray area, and further studies are needed to establish this concept. The limitation in our study are that like FMD with C1 C2 fixation group are very less number, and the other variables such as age and the duration of symptoms are not included in our study and not analyzed in our study. Thank you.
Good talk. Have you measured the posterior fossa volume in this patient? Because you see some of your pictures, the tentorium is almost sloping and very near to the foramen magnum. So I think the cause is very clear in these patients, where you see the volume of the posterior fossa is so small that squeezing all the contents of the posterior fossa in the foramen magnum. So that's one. And in Anomalous CV junction cases, obviously, the cause of the syringes and the all these things might be different. So obviously, by fixation, you are getting a good result. There's no doubt about it. My question is, what do you use for your duroplasty? What material?
It's facial data only, sir.
Sorry?
It's facial data only, sir. And only 32 groups of patient we didn't do duroplasty at all, sir. The patient who underwent duroplasty, we did facial data.
Facial letter,
Yes, sir.
right. I practice something different. You know, when you're making the midline incision, the ligamentum nuchae, which you're going through actually, if you nicely dissect that and splay that out, bisect it into half, becomes an excellent membrane, natural body membrane, which can be used as a duroplasty material instead of making another incision in the facial letter. And then when you close it, you tent it up so that there's enough space in the posterior fossa and the foramen magnum region to have a good CSF circulation reestablished. So that's something which I practice. You can try that.
For the first question, we use this whole brain software to analyze the posterior fossa volume, sir, but it's not been incorporated with all the patient. It's been under study. We use a software called whole brain, which is a free software, and we have started analyzing the posterior fossa volume in all arachnoid, all carry one malformation. So we yet to publish it. And one more question to the previous speaker, where we didn't find any criteria to fix the C1, C2 in isolated carry-on malformation. But one thing, we selected the patient who are very young, and we selected the patient who have a long segment syrinx. The focal syrinx is not being included in our study. Means even without instability, the focal syrinx is not included. Only patient who had a long segment syrinx and a patient who are young, we did C1, C2 patient without any instability. Okay, there. Yes, sir. FMD with C1 posterior also has been removed. Even in all cases, the C1 posterior also is
Not C1, it is coming.
below C2, sir. It can be, sir. Yes. Lamb. Hmm. Okay, sir. Okay, sir.
That it will go up. Remove.
But even in fixation group, it's not.
Fixation is different. If you do fixation, it
Then you can do.
totally different.
Fine, sir. Okay, sir.
You have to fix it.
Yes.
Have you considered in any of those patients with did you make a difference between carry 1 and carry 2 malformations in terms of considering fixation?
No, sir. We just took only a carry one malformation.
Carry 1.
Carry one only, sir. Purely based on only carry one group. Yes, sir. Fine, Brian.
So I have one question. All the literature says that we are doing foramen magnum decompression. The underlying concept that
pulsations start coming. The pulsations start coming shows and that your decompression will be adequate. As you see in this picture where you have a case where I have done decompression, but also the dural band release. This is another patient. I think you're mixing up the. I don't know. Yeah, this is one case, and this is the second case with the dural band stain. You can see the syrinx becoming smaller after the surgery. The duroplasty was not done in this case, but you can see the syrinx, and the patient also has a good clinical improvement. The next case is foramen magnum decompression, durotomy, and facial letter graft. we look at this case as Dr. Suresh Nair was asking about, if the syrinx goes down, how much? That shows that, the problem is more fulminant than what a small syrinx is considered. Then you can do a duroplasty, and you open up nicely, and then you can do the decompression. At the same time, sometimes you do get problems like this, where there is already here is a patient, you can see durotomy, facial graft in a failed bony decompression. In this case, the surgeons have done only bony decompression. It did not improve. It's a more complex case of KRE type 1 to type 2, and you have such a huge, large syrinx. But then, and after the second surgery, you find a very good improvement. The second surgery is that you do the durotomy and you do the facial lateral grafting. This is the second surgery. This is not the primary surgery. This is the second surgery. And sometime back, Dr. Tirupati was asking about some questions about the arachnoid bands, which is below the dura. After we open the dura, many times we refuse to do the dura, but then in some cases where it is an extensive syrinx, and when there are no result after just a bony decompression in a primary surgery, if you open it, then you can see a lot of additions, and also you can see some additions, and then there are a lot of arachnoids which are adherent very close to the dura, and those things can be released as much as possible. And at the same time, not only that, this is the other way. I've changed on the opposite side. I'm standing now on the opposite side. We also can excise the dura as much as possible, as lateral as possible, as you wish, and then put a facial lateral grafting. So the idea is very simple. The idea is just to change the cranial CS of pressure and equalize to the spinal pressure. And that is what the final concept we are all thinking about it. And so this is the surgery, and then you can put a very liberal facial grafting in this case. Now, another complex cases here is much more complex with the basilar invagination, C2C3 clipple field, platybasia, assimilated C1 posterior arch, abnormal vertebral artery. What we can do with a descendant of something like a type 2 KRE here, very complex. In these cases, it's very difficult. Whether you just want to do decompression, we have to address the basilar invagination also. But here it is reasonably okay. So what we did in this case is that we did a posterior decompression and also did the C1 C2 fixation on one side. On the other side, we could not do because very abnormal anatomy. We could not place the implants there. Now, C1 C2 fixation, is it really giving a big word? We have to wait and see. So there are studies. We keep on talking about our own experiences, but then you need some 20-25 brain to come together, and you read about the literature in the past 10 years. This is the Development of Spine Committee group in 2022. So 2022, we met in Brazil, and we had a lot of questions, and then we realized we formed some statements. These are the common statements. Statement number one is indication, KRE malformation 1. If it is symptomatic, you do surgery. If it is asymptomatic, you can always wait and watch. And if there is a progressive in MRI and then you have become symptomatic, you operate on these patients. Whatever I put in the percentage is the consensus result. And then when will you do the osteoligamentous decompression alone? Mainly the pediatric population. You don't need to open the dura. When the headache is the only presenting complaint except any other thing, and when no syrinx is associated, then you can do only posterior fossa bony decompression alone, osteoligamentous. If you have a failure of bony decompression alone, is more common in KRE malformation associated with syrinx and in adult population, then we have to consider very seriously about further treatment. Extra arachnoid opening, durotomy, and facial lateral grafting is done in symptomatic C1, that is a carry malformation with and without syrinx may have FMD and duroplasty in 60%. Here is the one where everyone had a little bit of difference of opinion. You see, only 60% have given the consensus for this statement. Although the literal opening could be done in failed previous surgery, it is very, very clear arachnoid opening. So 90% it has been accepted by majority of the specialists. Extra-arachnoid opening are safe with less complication in short-term follow-up. As we all know that when we go ahead with the dural opening and meddle around with the soft tissues inside, then you have the complication very high. As in this case, where one of the surgeon has taken out the tonsil, arachnoid membrane dissection can be done when morphological changes are visible during surgery. This is what the answer to Dr. Tirupati, who made this statement. In short term, tonsillar shrinking can show better outcome compared to decompression alone. However, can lead to more complication. As in this case, you can see it's a very nice decompression done, but over a period of time, at present, this patient is under my follow-up. At present, I find there's so much of addition. You can see that here, they completely see at the lower end, it has come and got stuck over the dura here. So this needs a resurgery. It looks like this. And then finally, regarding Atul Goyal's principles of C1, C2 fixation alone, can it be done in all cases? It's still not got about 100% consensus, but got 70% consensus for AA fixation can be done only when we have AA dislocation or instability, or if you have basilar invagination. Another way, finally, we can say if you have a syringomyelia, what are the options you have? When you have a syringomyelia, but the available scientific data suggests syringomyelia is due to obstruction of CSF dynamics at CV junction and not a separate identity in KRE malformation 1 because of the theories. If you see the theories, there are so many theories available. But one thing is very clear, there is an obstruction. That obstruction has to be taken out. Decompression of CV junction in the form of foramen magnum decompression with band excision on foramen magnum decompression with duroplasty is sufficient to treat syringomyelia in KRE malformation 1 in most of the cases. In cases of failed previous surgery and progressive syrinx with symptomatology, then a re-exploration is a must, and widening of the decompression and duroplasty should be considered very seriously. Syrinx drainage is the last option. This has got 90% consensus. Now, finally, to conclude, I have a very clear idea about this KRE malformation. Earlier days, when we were taught as a student, I think Professor Suresh Nair knows about it because I was with him when he was the senior postgraduate. We always used to open the dura, but nowadays we stopped doing it. Now, what we do is that you see open the dura and you find if the dura is very pulsatile, you leave it. You don't leave it. But if you have a large syrinx, significant syrinx and very severe, then it is better to open the dura and see the adhesions be removed. And if there is a dislocation like AA and basilar invagination, we have to seriously consider fixing C1 and C2. Thank you very much.
Wonderful talk, Pati. I just want to add, or probably maybe I missed part of your talk. Do you ever dissect the tonsils of the brainstem so that I think it helps in decompression, doing a good arachnoid decompression, lifting of the tonsils and dissecting all the adhesion between the tonsils and maybe the brainstem, and so that it promotes a good CSF flow. Do you do that also?
Yeah. Now that is earlier we can indirectly call it as an obex opening, right? So I tried in field, but I was a little bit significantly concerned about the so-called complications experienced by other surgeons. So in some places where you can find the tonsils both are equal, in some cases it is not like it is like this. But I try to open the arachnoids, not lifting the tonsil. I try to avoid that, but then I open the arachnoids.
Many times you have seen the dural band causing a depression along the it forms a groove along the tonsils. So that is, I mean, you can even record it photographically. That there is definitely a dural band which compresses the tonsils, and once you dissect the tonsils, I think the CSF flow, I mean, it should improve.
To add to what Bhatto has told, see, sometimes you get plastered tonsils. Both the tonsils are plastered. Answer to that question is what he has told. You have to remove the tonsil, establish CSF flow. But we had published, long back. Unfortunately, sometimes you have a large syringe on MR imaging. Patient is virtually intact. Vice versa. A small slit-like syringe. Patient is grossly disabled. We don't have answers for that. So we did long back publications and all. I say when we do this foramen magnum decompression, you don't know what helps, whether it is just bony decompression or just outer layer of dura or just duraplasty or just open the dura, leave arachnoid intact, or you explore intra-arachnoid or go and establish flow for the fourth ventricle, put a shunt tube or whatever, or put a muscle. So many things have been explained. All these patients will show some improvement, but many of them will come back on long follow-up. I don't know answer to that. Maybe say maybe our Atul Goyal fixation. I don't know.
I remember Nair sir. I remember when we were in the final year. I still remember one lady came with a very severe syringe finding, and we did those days. We did this uroplasty. That patient never improved, and of course, maybe after many years, we all came. You went, and we came out. We do not know what happened to the patient. What's wondering us is that nothing is changing over there when there's a huge syringe extending from cervical to the lower dorsal.
Talking time is over. No. Just, so we had published a clinico-radiological correlation. We had published an article based on radiological clinical correlation. It got published in 1997 along with the World Congress at Amsterdam. I can share that article where there are some guidelines to tell which patients may improve. But those days we used to do only foramen magnum decompression. I can share that article, clinico-radiological correlation for KRE syringe.
Sure, sir.
Jyoti,
Yeah.
very nicely sort of concise presentation. Since you talked of that international consensus thing, was there any consensus on patients who had a decompression, but the syringe did not change and neurology did not change? So what was the consensus? Just to follow them up?
No. Yeah. This is a very good question. If these patients, there are two things. One is basically it is decided by clinical. If the patient is not clinically improving and it is going to clinically worsen, for those patients we have to re-explore and re-explore thoroughly. That was the consensus. That is, you open it well, do your microsurgical dissections of the arachnoids. Tonsillectomy was not recommended.
No.
Tonsillectomy, most of them says, please avoid it because we may produce further.
I'm dead against tonsillectomy or shrinking and things like that. I mean, I would rather fix and open more widely rather than do anything to the tonsils. I mean, so
the one slide which I showed where a tonsillectomy was done by a very good surgeon 20 years ago, 15 years or 20 years or 15 years ago, has now come with very severe problems. But I find that entire posterior, that is the lower part of the stem, is getting adherent to the dura. Now we have to open it and we have to separate it. That I'm just waiting for that patient to, second surgery. Second surgery is the most interesting and very
difficult.
Thanks. Just 2 points. One, taking off from where Ashish Pathak was saying about hitching the dura. So this was a lesson that Arnold Menezes in the late 1990s used to propagate. So when you open the dura, you hitch it up so that you create more space in the posterior fossa. That's one point. Second, if I understood what you said right in your consensus statement, is that you said that you do a duroplasty only when there is a large syringe. The question is, what is large? Because then that becomes subjective. So what I consider large may not be considered large by somebody else. So is there a definition for large, or is it a symptomatic large syrinx is the question.
Mostly symptomatic. Mostly symptomatic. That's what the whole question. Some patients, they do stay with the same thing. Because now today we are in MRI era, we are able to see the syrinx better. See that? So the small syrinx, most of them we call small syringes within the cervical region.
Okay. The third point is, I think the not going for intra-arachnoidal dissection is because when we were younger, the concept was the more dissection you do intra-arachnoid, the more adhesions you cause. And
Yep.
therefore, and that has been proved by your case. I think that is what is the concept.
I'm just wondering, I think we may have to take up even a study on this, because I know there are hundreds and thousands of KRE1 malformation is operated with bony decompression alone. If we, with the tonsillectomy and all this thing, we have to follow up and see how they look radiologically and how many patients are, because patients who come have symptoms only, they come back to a second opinion. Otherwise, they'll be lying at home. So we do not know those patients.
Yeah, Dr. Parthiban, like I have an observation on all the cases that you have shown as illustration. Like in all those cases, like you have a cervicomedullary kink. I mean, one after the other, I've just have been following, and we kind of started looking at those things, forgetting the bone, and seeing that that's probably the thing that we need to correct. So somewhere, I mean, we are trying to look at our things. So in all the images that you have shown, there is a cervicomedullary kink. Probably, I mean, what is your thoughts on it? Like, I mean, have we missed the actual thing and started looking around it? There are only C1, C2 fixation is the answer for these things.
Yeah, I'm also a little bit confused on this part, but then we work more with the MRI findings. We do with MRI findings, but when you open the dura only, we see the tonsils and all those sites in and around. But still, I'm a little bit, because C1, C2 fixation, but concept, I tell you, I have to say Atul is not there, but still, it is my feeling. Sometimes what he's telling is right, because if you see the hypotheses, which I put, all the hypothesis shows two things: difference of pressure between cerebral and spinal, number one. Number two is paravesicular pressure. Now, probably something is happening over here, and you fix that with C1, C2. I think that will stop that difference. This point I didn't tell Atul, because probably he may take my point and then. My feeling is that I'm telling you, you stop C1, C2, that movement is less. So both pressures are reasonably, there is no transaction there. When there is a movement, small movement is happening. I hope Atul has not come here. I think at this point, please, in front of you, I'm telling it. Probably the C1, C2 fixation is doing that. He may be right, we have to wait and see. Sir, Professor Ramani.
Want to make one comment that we talked, and Sridhar also mentioned about menaces. But we forgot about a contribution that is made by our own colleague Rangachari.
Yep.
Sridhar Rangachari also mentioned that do not cut arachnoid. He said you make a vertical incision in the dura, then hook the dura on either side, and make a long shape fascia. And that was more than enough. And without
Anal Beniz's old papers have this technique. Actually, I remember talking to him also in Chennai. He came, and those days he used to come regularly. He opened the dura vertically and also slice it and then hook it to the sides and stitch it like Ashish was talking. And then if you want, you put a fasciolata and then. So actually you're widening the room. It happens in. Yeah.
Thank you, sir. It's always good to have some consensus. Just one, whether these consensus have been converted further as evidence-based medicine.
Yes.
That is
see,
very
that is what. See, I tell you, this is a very important point. You're right. Consensus keep coming, and consensus may change after 5 years or 10 years. It is up to us to see, verify.
Whether it's classified as class 1, class 2, like that.
No, consensus are not it is not classified.
Why can't WFNS, NSSA come with some guidelines with the class 1, class 2, A, B, C evidences on these lines?
Yeah.
Recommendation. Okay, sorry. Recommendation.
This
So, recommendation, sorry. Recommendations. Class
The-
1, class 2.
This whatever I presented is going to be published, and we are waiting for publication. Thank you very much.
Thank you, sir.
Yeah, thank you, Dr. Parthavan, for the excellent talk and excellent discussion. Now I'd like to call upon Dr. Nupur Pruthi from Bangalore, recurrent CV junction surgery, challenges and enhanced experience.
Respected chairpersons, august guardians, my teachers. I think we had excellent talks since morning, and we are discussing to fuse or not to fuse. I take the talk to a different level in which the question is how to fuse, and the other question, more relevant question, is when it's already fused, still how to fuse. Outside, I thank Dr. Savit and Dr. Manas for this kind invitation. Well, if you have not had any complications, I think we just haven't operated enough. I just show you three case examples, and through that we are going to give very important pearls of surgery to manage these difficult cases. So this we start with the first case. It's a 40-year-old lady operated 14 months back, and now her improvement lasted after the surgery for only 11 months, and she came to us in a condition in which she was much worse as compared to her condition prior to her first surgery. She was in fact bed bound for a month duration. Interestingly, pre-operatively she had only some mild neck pain which had improved transiently. She had also had some transient CSF leak, the dreaded CSF leak in the post-operative period. She comes to us with this MRI. You can see that there is a crowding at the CV junction. There is AAD, there is probably a bit of BI also. You can see that foramen magnum decompression has also been done by the primary operating surgeon. And you can see some cord changes also extending, maybe a pre-searing stage or something. This lady is really in a bad shape. When you see at the CT scan, and this is where all the problems we see. In spine, we have a concept that if we do a long segment fixation, it will take care of almost 90 to 100% of the problems. I think it may be correct to some extent, but I think this statement is more often inappropriately utilized. So the operating surgeon, as you can see, has done a occipito C, in fact, not even C2 fixation. It's going much more beyond 5 or 6 fixation, which worked for maybe few months, but then again, patient has started to develop again BI in AD. Interestingly, what I want to show you is that both the joints on the right side and the left side are still looking virgin. To complicate things, you have a KRE also, because foramen magnum decompression is already done. There was a history of CSF leak in the previous surgery, and you wonder now whether you have to add duroplasty in addition to what else we have to do. Demonstrating instability in these patients is not easy at all, and standard methods like flexion, extension, X-ray and all do not work because of the implants being there. Do a CT angiogram. Luckily, the vertebral arteries are in good position. So now, how we ended up in this position in this patient? A patient who has undergone for a classical BI with AD has undergone an occipito C4-5 fusion. There remains, and we need to understand that even without showing by a demonstration that there is a persistent large segmental instability. What was the graft strategy of the patient of the primary surgeon remains a matter of concern, because you don't see any graft at the end of 14 months there. Probably everything has disappeared, has not fused, or only local bone graft was used, probably from the foramen magnum decompression, which is again a big mistake if you ask me. You know what are the challenges here? We all know of our patients, of CV junction patients who have been in ICUs for a long time, for years sometimes, and you don't want your next patient to go in that position. Absolutely no. The exploration is always a challenge. Previous surgery, CSF leak has been there. How to dissect without monopolar? It's a very because with all those critical structures around vertebral artery, first you have to remove the implants and then your surgery starts. You have to reach the joints through all those scars and all that, and you have to then plan your fresh implants, and you don't want to be operating this patient third time. What we do, and we have been doing this for a period of years now, we put all these patients on traction now, and we wait for a few days. What that gives is us a couple of things. One is, does the patient improve neurologically? Does the patient improve radiologically? These patients, and a person who doesn't improve radiologically or clinically at our current level of thinking, we don't offer surgery to these patients. So this patient was given the offer of traction for a few days, and she did improve neurologically as well as radiologically. And so we planned her surgery, in which we took out the long segment fixation and did simple C1 lateral mass, C2 pedicle screws, and placed a nice rib graft there. We loosened the joints and did the deformity correction. So this is the immediate post-op X-rays for her. This is the immediate post-op CT. The BI has been reduced, AAD has been reduced. Joints most probably have been realigned, and we have not used any kind of spacer here. You can see only the good old graft, rib graft is there in these joints. Patient started to walk and with support at the time of discharge. 9 months CT scan is already showing you fusion here in the joints. So that's what the patient wanted. Patient wanted bony fixation, and we gave it a long segment fixation, which was absolutely not required. 9 months after surgery, that lady is independent for all her activities of daily living. So we need to address the segmental instability, and we need to understand the importance of bony fusion. Please do not think that a long segment fixation is a solution for everything. You need to find out what exactly are the segments which need to be included in that fixation, and please do not overlook or neglect the choice of graft and where exactly to place the graft. So the second question, you may say in the second case that yes, I think the previous problems have been addressed, but still this patient ends up and requires, in fact, this patient required a third surgery. So this patient has been operated twice. 15 months back, before he came to us, he underwent, again, everyone likes to do foramen magnum decompression. Post-cervical approach, foramen magnum decompression, C1, C2 fusion using bilateral C1 lateral mass and C2 translaminar screws and rods. And again, the problem of local bone graft. 3 months later, after this first surgery, there was an issue. I'll come back to that. But to us now, patient comes with insidious onset, 3 months progressive weakness, especially on the left side. So this is the scan of her even prior to her first surgeries. As you can see, again a BI with AD, with probably crowding at the CV junction, foramen magnum. This was the scan. These were the joints prior to the first surgery itself. They look quite fine, maybe a little tilted. And after doing the first surgery by the main operating surgeon, as you can see, foramen magnum decompression has been done, but quite a good reduction has been achieved. And if you see that even the joints have been opened up, the local graft has been put in the joints. So yes, segmental instability also has been addressed. But then what happens? I think this is one of the concerns in this patient. I'm not sure how many of you are big fans of laminar screws. I'm not, and over a period of time, I use them less and less often. But to rely on 2 laminar screws with a C1 lateral mass screw for this amount of instability, persistent instability, height of instability, I don't think is the right option, even despite getting a graft and getting your work in the joints done. So 2.5 months later, the patient came with resubluxation, and if you can see that, 'didn't hold'. If you see the joints, there's probably some overwork in the joints this side, which was there. Right now, all the graft is almost getting resorbed. What about the right side? Maybe there is some fusion already setting up here, but still patient is deteriorating. This was the pre-op, and this was, see, all that graft, which was the local bone which was put, has already disappeared now. To complicate things more, we have a large pseudomeningeal seal also there. So, in a matter of time, the rods came out of the screws, and the only thing which was done, I again offered, was that this, you can see the rod which has come out. This is only the only one case after this. So the operating surgeon does again just reconnects the rod and hopes that it will fuse over a period of time with collar. It doesn't. Patient comes to us after 1 year roughly with progressively worsening of BI. And now with these joints, you see all that big amount of graft which was there has gone now. You see this picture here. I don't know whether there's fuse, but there's definitely erosion at the C2 facet. On this side, maybe again this has fused, but we don't know. In fact, what has further worsened is that the cord changes, which are very small, have now extended almost whole of the cervical spine now. And do we need to do foramen magnum decompression more, or maybe duroplasty more? We can all think in our minds. Well, patient continues to deteriorate and comes to us. We don't know. These are the fusion. This is the joints now. This looks, in fact, quite looks to be a solid fusion already on one side. So again, as I told you, I take this decision after a trial of traction. You can call me old school, but the traction has really helped me and helped me in very difficult situations. And so I put this patient on traction, and interestingly, patient has both radiological and clinical improvement. As you can see, the BI has come down here, but most importantly, you now know that this was a pseudo fusion. The moment you put the patient on traction, this joint opens up, cracks open up. This means this patient has persistent instability, and this joint is begging for fusion here. So post-op traction, patient had significant clinical and radiological improvement, and hence we offered for surgery. This was the third surgery which we did. We removed the laminar screws. We inserted pedicle screws on one side. Other side, we went ahead with C3 and C4 lateral mass. Got the spacers in bilaterally, and also always put a midline rib stud graft. This is the immediate post-op. And these are the both side spacers in the joints. This is a 3-month follow-up of this patient. And if you see, interestingly, even those all the pre-syrinx, the syrinx stages have now disappeared without doing any kind of foramen magnum decompression or a duroplasty. So, in my opinion, bilateral laminar screws is not a good option, especially in patients who have a basilar invagination. The importance of bony fusion and bone graft in the right place has to be highlighted. So just quickly.
Sir, you have crossed the time more.
What? Over.
More than 2 minutes, 3 minutes you have crossed the time.
Yes, over now.
Yes,
this is the third case. I'm just showing you this slide only. What I want to show you is this patient came to us again after 2 surgeries, both a long segment posterior fixation as well as a transoral decompression, but still this patient is continuing to have a persistent BI with AD. And what I want to show is that again we put this patient on traction, and this B image is the image on traction. So you can see the amount of reduction which has already come down with the traction, and this further gives me confirmation that this patient will definitely benefit from surgery. And rest images are after our surgery and is also showing a good bone fusion. Patient has stabilized after this. These are our 20 cases. I'll quickly rush through them. These are the few literature reports. Of course, Dr. Goel has the largest series of 30 cases. This is an interesting paper from a very good paper from SGPGI. So for a right outcome, we need to assess the degree of instability, the right choice of implant, the right choice of graft. I think rib and iliac is any day better than local occipital bone. Right place of fusion, you need to enter the joints, and you need to give the right respect to vertebral artery, and traction as a tool is very helpful to take the decision for surgery. Thank you very much.
Thank you. Since you are running short of time, 1 or 2 quick comments if possible. Very quick comments, please.
So we go to in adults we would go around to 1/5 of body weight. but 1/5 of body. But usually by 5 or 6 kgs, we come to know that this patient is going to respond or not.
Good, very good. Very nice cases, Nupur.
Thank you, sir.
I think the most important lesson for youngsters is that this kind of fixations where you don't involve the index fixation was like Harrington in the past, where you fixed in Agra and then in Kanyakumari, in between the instability persisted. So there is no doubt about this is all rubbish, focus, that you're fixing the occiput and then going and fixing C3 and 4. You cannot do that for a C1, C2 instability. This is one. The second important thing which I feel is that most of the time, these MRIs and CT scans are done in lying down positions. They do not reflect the exact extent of instability. The exact instability can only be assessed with the patient in standing position. So the clinical symptomatology and what changes occur in the MRI in the post-op period itself tell you that there is instability. If the patient is not improving, progressively worsening, so this fixation itself was not worth it. The third point is very important. Neil Wright, who described the technique of doing laminar screws, that is like trying to call, I always show the slide, man sitting on the horse and trying to control the horse by holding its tail. The weight transmission is only through the bodies and through the lateral masses, trying to fix the lamina and trying to fix screws in the lamina where the center, many times the lamina is thin or there's a lot of cancellous bone. It is just against the principles of fixation. So everywhere, I think we all need to learn some things from orthopedic surgeons.
Absolutely.
And what happens is that we don't take those lessons from orthopedics and therefore we end up with these kind of disasters. That's all. Thank you.
Absolutely.
I want to highlight something which my teacher, Professor Khosla, used to do. He used to do X-ray tomography in dynamic position. I think the radiographers nowadays have forgotten how to do it. X-ray tomography, one of the very important investigations in dynamic position to show how the joints behave. The beautiful X-rays he would show. He was one of the persons who introduced CV junction surgery in PGI, starting with transoral and everything. So that was so nice to see how the joint behaves. I mean, this is the pre-CT and the pre-MRI era I'm talking about. But those are beautiful investigations.
Yeah, thank you, Dr.
Thank you, sir.
Nupur. We are running out of time now. I would like to call upon Dr. Rupesh Kumar from Chennai. The last talk, Bow-Hunter syndrome.
Chairpersons, teachers, colleagues, and friends. Thank Dr. Manas and Dr. Savit for this opportunity and the wonderful conference. Moving away slightly from the topics of CV junction of under-realized, under-discussed topic of this called Bow-Hunter syndrome. Bow-Hunter syndrome is basically a rotational vertebrobasilar insufficiency. We do commonly hear the symptom of vertigo, dizziness, but we never give importance in our clinical practice. And this has been described very much because of unilateral vertebral artery dominance and the opposite being hypoplastic. Many times patients feel this symptom. And this was described first by Professor Sorensen in 1978 during an archery practice when a patient collapsed and had a stroke. So that's how this entity came into picture and it was described, and subsequently not much explained or published in the literature. Hardly, there are less than 100 cases now, 150 the last 2-3 years. So what is actually Bow-Hunter syndrome? So there are some not much literature available. So there are only 2-3 review articles on this because there are only individual case reports. So there are age-wise, whether it can be in a pediatric, in a middle juvenile, or an adult, and depending on the age of intensity, and also whether it is a primary or secondary. Primary is the most common, where a lot of pathologies are there, especially in CV junctions and also subaxial cervical spine. It's also then occurred, supposing post-trauma dissection of vertebral artery, or we sacrifice a vertebral artery independently, iatrogenically. So these are also some of the acquired causes of Bow-Hunter's syndrome. Just quickly, an anatomy of the why this is particularly unique is that this is the only artery where this supplies a posterior fossa, important brainstem structures, goes through the tunnel within the foramen of the subaxial cervical spine, and then it has to go through again a bony tunnel in the C1, C2. So it has to go through really a bony curvatures, and any degeneration can cause kinking, especially if the vertebral artery is unilateral. So this symptom is quite very much commonly described by patients. Only thing we undermine it, and so there are various segments. The most common described compression happens at either at the V2 or a V3 segments of cervical or vertebral artery. The pathogenesis is simple. If there's a dominant vertebral artery and the other is hypoplastic, and if that goes into neck tilting, and it can cause compression at various levels, it can be at the ligamentous level or at the bony level or at the joint level, and patient can produce severe vertebrobasilar insufficiency, especially if the contralateral one is hypoplastic or very thin. So this is the common pathology, and the left vertebral artery is dominant in 50% and the right in 25%. So if there's a more symptoms are more commonly described in the left side territory. The symptoms can be varied very widely. Syncope or dizziness is one of the commonest symptoms we hear from our patients in our practice, and we take it to consideration. We send them to ENT, we send look for ears, but especially in elderly people when they already there's a degeneration, I think this syncope and we have to give more importance and evaluate them. Many times this can be corrected or curable. Vertical or stroke is a much later or advanced type of pathology. Now, how to investigate these patients? I think simple CT and MRI, good quality MRI, good thin cut sections with a bony reconstruction can tell you the pathology in most of the cases, but then the gold standard will be to clinch the diagnosis, the dynamic DSA to just document that whether the vertebral artery is getting kinked. I just recently added to this that TCD is a good bedside tool to diagnose that Bow-Hunter syndrome, where rotation of vertebral artery can cause a 50% increase in the velocity. So we just realized that and we started doing this, and this could be, we started doing this maybe in a year, I can come with more data on this. So when you rotate the neck and then you measure the TCD of vertebral and PCA, and if you can document more than 50%, that you can investigate those patients in much more detailed way, and this is something which is unique. So coming to the management, majority of the time they can be managed conservatively, especially if it is a subaxial spine, put them on ortho basis and then identify which position they get vertigo and ask them to avoid and then do some exercises. But then majority of the patients do need surgery, either a decompression if it is subaxial spine without degeneration, or fusion if there is additional degeneration. In more in C1, C2 pathology, you need more often stabilization and fusion, because with conservative management, this doesn't improve. So this is one of the patient, young man who presented with a stroke, the posterior circulation stroke, and was just started on ecosprin, and symptoms were ignored. And then this patient came to us, and we could find that the vertebral artery on the left side is dominant. And then on further evaluation, we noticed that this CV junction anomaly and flexion extension dynamic X-rays was done to dominant. There was an instability at this level. We went through in detail to identify what is really happening in the stroke, and this is the pathology. We can see that the C1 was slightly moved forward, and the C2, there was a subluxation at the C1, C2 level, and we can see slightly moved forward. And then we did also a DSA vertebral artery angiogram, the CTA, and we found that at the extension, when there was like a nutcracker phenomena, the vertebral artery was kinked, especially on the right, the left vertebral artery, the right was hypoplastic, and that gave rise to the symptoms. And so this is the pathology, and we can see closer view, and we can see a lot of other anomalies in him, but then the left vertebral artery was the pathology here, and it was causing. So we decided to go ahead with stabilization and fusion, and then this patient stabilized off. It's now 3 years follow up, and he's doing well without any symptoms. And we stopped antisprin. Ecosprin was started by somebody else, and then we had to stop it because the pathology is not a thromboemboli, it's because of this vertebrobasilar insufficiency. Similar other cases like a 30-year-old female, severe vertigo on rotate to the left, and we can see this is an occipitalized atlas. We can see again the dominant vertebral artery on the left side, and the right was hypoplastic, and other associated anomalies already occipitalization, the bony groove, and then we had to go ahead and stabilize the C1, C2 on patients. Many times this vertigo or syncope is commonly described in CV junction pathology. We always think it is because of the cord compression. It is also vascular. So we need to go into the detail and just analyze the cause. We'll be able to pick up many more cases. It is not that it is uncommon. It is common. Only thing we don't give importance to that. And many other examples I can show you again. Here it's interesting. Again, the left vertebral artery was making like a U, almost like a hairpin bend at the level of just at the foramen, and the other was stretched. So whenever this patient turned the neck, there was severe vertigo and instability, and then we can see that it's not just due to the bony compression of CV junction, it is also because of the vascular insult. So the drop attacks can be because of this vascular impairment. It's a part of the Bow-Hunter syndrome. And here we can, vertebral artery was actually abnormally placed. It was instead of going above, it was going through the C1, C2 spacer where we are going to put the bone graft. So we had to displace the vertebral artery and put the cage and then stabilized it. And then the patient did quite well. And this is the postoperative X-ray. Many other cases you can see that here the right vertebral artery is ending up at the pica, and then the left vertebral artery, you can hear that it was penetrated. And again, that was a dominant vertebral artery, and here you can see much more closer view, the right vertebral artery was ending at the pica. So these type of anomalies are quite common in CV junction, and we need to give importance to that. And this part of the Bow-Hunter's phenomena which is happening in these patients, and key stabilization is the main stay of treatment in these patients. Here we can see very interesting, there are no posterior elements, and we can see that there is a significant instability. Again, the vertebral artery on the left was dominant, right was hypoplastic, and we can see here that all the posterior force element, in addition, there was a clipal field anomaly also, and we can see that so again, no, the symptoms of this patient not just because of the compression of CV junction, it is also because of the vascular insult. So just to summarize, not much data are available, only individual anecdotal case reports are there. There's two papers which collected all the data, and this last one was the recent one on 153 patients. 50% of the problem was in the CV junction and 50% in the subaxial spine. I didn't include the subaxial spine pathology. In this talk, mainly I concentrate on the CV junction, and adults are more commonly reported. But if it comes to CV junction, even children and juvenile patients, the pathology is quite common. So just to conclude, patients with vertebral artery insufficiency with neck rotation more than 30 degrees, we call that as a Bow-Hunter syndrome. Evaluate these patients more carefully and clearly, and do investigate them with CT angiography, MR angiography. We can do a dynamic CT angiography itself. We need not always do a dynamic DSA. The patient is in the console, you can always document. But if the patient had a recent stroke, better not to do that because we can produce a new stroke. However, the confirmatory diagnosis is dynamic DSA, but I could realize that the bedside simple TCD can give a more solution, more answers in this type of group of patients. The mainstay of surgery is surgery, decompression, or fusion. Management conservatively is in a very small subgroup, especially if it is in subaxial spine. So thank you very much. I also take this opportunity to welcome you all for the neuroendoscopy and M&A conference next year at Chennai. Thank you very much.
Good, Ramesh. You have finished well ahead of your time. So, few discussions.
Me first. Me first.
If you start getting, I think yes, if it's, I think the answer is one day when cardiologist asked what age I start getting MI, risk of MI, then a cardiologist told whenever your middle portion of the body protrudes out, that is the age. So I think whenever it is subjective, whenever we have symptoms, especially many times, many people, elderly people, if you ask, the moment they look up, they get severe vertigo and giddiness. So I think majority of the time it is because of the VBA.
Sir, please. Please, sir.
There's one other pathology which can cause this, which is called an arcuate canal. The thing is, I had to read it up when the radiologist mentioned this. This is yes, it is arcuate canal, which is a very rare phenomenon where the vertebral artery goes on top of the atlas through a bony canal, and that's a cause of Bow-Hunter syndrome. Again, this adolescent was being treated as epilepsy because he was having these syncopal attacks and falling down till somebody thought they should image the CV junction. Thanks. Atlas, and the vertebral artery goes through it.
Yeah.
You have to drill out the bone, and if necessary, you'll have to fuse, depending on other.
No. Is there any particular clinic? Would you investigate every drop attack and every postural head position related one for this one?
I think we should start working on these drop attacks. As far as I just learned this DCD is a simple technique to screen those patients.
Okay.
So more than 50% elevation of TC, those patients, I think we should do analysis in
So
detail.
there's no particular clinical set of things like, I mean, in these characteristics in this, I mean.
Yeah, because drop attacks are very common with non-specific symptom. We think it's a cardiac syncope, it is because of neurogenic, VBI or tinnitus. So I think depends on what symptom the patient, especially if the rotation history to the rotation of the neck, I think then we should do.
My friend Atul is not there, but this latest paper or the latest thing that he is posing is instability on rotation. He has shown on CT scans on rotation, patient gets comes and you should fix. But his videos are very, very dramatic, where patient is walking like this, and he fixes it, and patient starts walking straight. But the idea is there is a rotational instability. He feels that rotational instability has been overlooked. I am a little inclined towards accepting his argument, but not for all patients. So rotational instability can be because of and can give rise to cord compression, or it can give rise to vascular insufficiency. Both can be responsible. There are no norms of what is how much rotation then take. They say up to 35% is acceptable, but some people can have more.
I think just we have to be slightly cautious because as we all grow old, we will have some rotational and other problems. So there has to be a sort of proper recommendation where to sort of draw the line between normal and abnormal. So that might be an important thing to consider because with age, with all these spondylitic changes, you'll have some rotation, some subluxation. That's bound to happen for every human being. So is there any proper sort of line drawn where we call it abnormal, normal, and all those things?
Really don't have a literature
Yes.
and evidence on that, but I think this is a subject which is open. We should work more on this because the symptoms are very, very common. Only thing we don't give much importance to those symptoms.
Grossly for any ischemic symptoms, this all depends on adaptability also of the patients. How they get adapted over the due course of time, and also which even cardiologists or neurologists we misses the development of the collaterals. Collaterals we don't study at all. Actually, the collaterals is the main thing which takes care of us, which we are not addressing subjectively and objectively also, which is very difficult. And if no more questions, we'll conclude the session. Thank you.
Thank you.
Thank you, chairpersons and all the speakers. Now we break the session for 5 minutes. I request all the participants to quickly grab the hot beverages which are placed outside and join back in 5 minutes, please.
The copy will be available in the adjacent hall and in Mystic Hall, not in this place. So that you can visit the stalls also. Please. Coffee, you can use this door or outside Mystic where you had dinner also yesterday.
Wife's command.
So we all join back in 5 minutes, please.
Thanks, a much wanted break. Very good, very nice.
आ गया
Welcome back to the next session. Now we are beginning with session 3, that is Twin Talk. May I request today respected Dr. KVRS Shastri sir, Dr. RTS Naik sir, Dr. JKBC Patriban sir. Please come on to the stage for chairing the sessions.
To start the next session, I request Dr. Ramakrishna to come and present his paper on instrumented fixation for degenerative lumbar spine disease. I request all the speakers to keep to time.
Respected chairpersons, senior colleagues, teachers, and my dear friends. At the outset, I would like to thank the organizing team, Dr. Manas and Dr. Shastri and their team, for giving me this opportunity to talk on degenerative lumbar spine, whether instrumentation is needed or not. So, about 15, maybe 18 to 20 years back, when probably we were residents, in cases of cervical laminectomy, what we were taught and what we used to do was to remove the lamina and spinous process and decompress the spinal cord. But later on, as lateral mass fixation, especially in the posterior approach, became more and more prominent, now it has almost come to the stage where 80 to 85% of the cervical spine where we operate, we do a lateral mass fixation in those cases. Even it had come to the extent that there are many papers which show that even where we feel that the spine is very rigid, especially in OPLL, there also they feel that doing a fixation will prevent the progression of the OPLL. So that actually prompted me to just look into the literature of what is the status of degenerative disease in the lumbar spine and how the residents should know from that. So the degenerative lumbar spine, the main problems which we come across in degenerative lumbar spine is lumbar canal stenosis. In lumbar canal stenosis, mainly the stenosis is because of three factors, whether it is the hypertrophied facets or whether it is the thickened ligamentum flavum and bulging intervertebral discs at multiple levels. And the second is lumbar disc prolapse, degenerative spondylolisthesis with a listhesis of less than 3 millimeters slip, chronic low back pain, and special situations. Actually, I would like to divide my talk into three aspects. One is what does the literature say about fixation in degenerative lumbar spine? Second is in special situations what we should be doing, and third is what we have evolved and what we are doing. And regarding the third aspect, I am open to criticism. So what exactly is the rationale for lumbar fusion? The presence of degenerative spondylolisthesis has often been considered as a sign of instability, and some studies have suggested that there may be a risk of iatrogenic slip or an increased degree of spondylolisthesis after decompression. So the exclusions from this are mainly high-grade ischemic or traumatic spondylolisthesis. I will not be talking on them. And see, these actually three scenarios where I would like to describe. One is this, where we do a flexion extension views of the lumbar spine, especially in lumbar canal stenosis. It is especially for the residents, I would like to tell that flexion extension is always useful when it is done only in standing position. A lying down flexion extension is of not much use. And here in this, we don't find much of instability on flexion extension. Here, if you see carefully, we can see that there are multiple small levels of instability which are seen in probably all the levels from L1, L2, L3, and L4 levels. And sorry about the quality of the X-ray, but here we can see that there is a spondylolisthesis which is more than maybe 3 millimeters, and we'll not be talking on this. These patients definitely will need some sort of a fusion. So coming to the literature review, actually the literature starts from about 27 years back. That was the first article I could get in 1997. There was an article by Fishgrund et al. And in their results, they found that fusion remained popular even for lumbar stenosis. And it was actually, sorry, Fishgrund et al., they felt that fixation should be done in lumbar fusion. This is the second article by Dio et al. This has come in JAMA 2010. And this is actually a retrospective cohort analysis of 32,152 Medicare patients. It is just an observational study, and they found that in lumbar canal stenosis, almost about 21% of the surgeons preferred to do a fixation. And then the sport trial had come in 2007 by Weinstein et al. And here this was actually a randomized study. And the outcomes of this was, especially for a lumbar disc management, surgery is always superior to conservative treatment. And they really did not comment on whether it was with or without fusion. Then there were again two studies in 2016. One is spinal laminectomy versus instrumented pedicle screw fusion. And these had come in the New England Journal of Medicine. These two studies had come almost in the same issue. One was in favor of the SLIP study. The inclusion criteria in SLIP study was grade 1 lumbar spondylolisthesis with lumbar stenosis and neurogenic claudication with or without lumbar radiculopathy. And the exclusion criteria is more than 3 millimeters of SLIP. And they actually found that there was substantially higher reoperation rate in the decompression group, and most of them received fusion. Another study in the same issue had come, the Swedish spinal stenosis study, in which they had seen about 247 patients randomized, and their conclusion was that in this randomized trial of Swedish patients with lumbar spinal stenosis involving 1 or 2 adjacent vertebral levels with or without degenerative spondylolisthesis, decompression with fusion did not result in a clinical outcome that was superior to decompression alone. There were some limitations, we will not go into that. And then came the study of Nordsten studies. And this is actually 16 surgical departments, and they had included stenosis and listhesis. And in 20% of the patients, this listhesis was more than 3 millimeters. And they found that the reoperation rate in these patients was almost similar, whether it was the decompression alone group or the fusion. So in this multicenter single country randomized trial involving patients with degenerative single level lumbar spondylolisthesis, decompression alone was non-inferior to decompression with instrumented fusion at 2 years of follow-up. And reoperation occurred somewhat more often in the decompression alone group. These next 3 slides, I want all of you to please concentrate. This has come in the neurosurgical focus of 2019, and where they had studied, the first one is studies of fusion for low back pain. And they have actually analyzed 2 studies. And in the first study, it was the conclusion was that surgery was better in back pain and return to work. And the second study, there was no significant difference for surgery versus conservative treatment. And this studies of fusion for a herniated lumbar disc. They had again analyzed 2 studies. And the first study did not give any added benefit with fusion, and the second also corroborated with the findings that there was no extra advantage which anybody gets by fusion, is only for a lumbar disc patient. And this third one is studies of fusion for stenosis with spondylolisthesis. Again, there were studies with conflicting results. The first study says that surgery was better for spondylolisthesis. And second study says that decompression and fusion was better. The third study, they did not find any difference between decompression and decompression versus fusion. And the fourth study actually surprisingly says that surgery is equal to almost some intense rehabilitation program. So that was about the literature. there are some special situations which we have to also go in before we frame our own guidelines for our practice. One is what is the type of fixation surgery which is recommended in degenerative instability. So there have been multiple articles comparing posterolateral fusion, just a normal pedicle screw fixation, with a PLIF study. And this study and most of the studies have come to the conclusion that for a degenerative spondylolisthesis with a slip of less than 3 millimeters, comparing PLF, posterolateral fusion, and PLIF in patients with spondylolisthesis or lumbar spinal stenosis, or studies from which data could be extracted independently, and the meta-analysis provided a comparison between PLF and PLIF based on RCTs, and they found that even though PLIF had higher fusion rates, in both the fusion methods, but they achieve similar clinical outcomes with equal complication rate, revision rate, operation time, and blood loss at 1 year follow-up. What to do in failed back surgery syndrome? So this is actually a picture of failed back surgery syndrome, and when we see the flexion extension views, there is no significant listhesis after in the postoperative flexion extension view. But most of the studies say that in failed back surgery syndrome, it is always better to do a fusion so as to restrict the mobility, and in case, the disc has a tendency to move, if you restrict the mobility at that level, probably the chances that it will move again in future are lesser. There is one very interesting study this has come in neurospine, where they say are lumbar fusion guidelines followed by most of the surgeons, and the outcome is that only 60% of the surgeons actually follow the lumbar fusion guidelines. And the another thing is that what should be done when we do a long level decompression in lumbar canal stenosis, more than maybe 3 levels. So there have been some studies on this, and the result of this study was that facet-preserving multi-level decompressive laminectomy provides good pain relief and functional outcomes for wide range of patients with degenerative spinal stenosis and no instability. And indications for fusion should be restricted to patients with lumbar stenosis accompanied by spinal instability or deformity. Then has come Professor Goel's paper in Neurosurgical Focus in the year 2019, and they say that, as all of us know very well, that on the basis of our present and earlier experience, we conclude that vertical spinal instability and listhesis, that is telescoping or overriding of the facets that exaggerates on physical activity, has a defining role in the generation of symptoms of claudication pain and the pathogenesis of lumbar canal stenosis. Only fixation at the site of the fulcrum of spinal movement is a rational and effective form of surgical treatment. Any kind of surgery that aims at decompression of neural structures is not necessary. So coming to what we normally do in our practice is that we always get a flexion extension and standing of the lumbar spine. In chronic low back pain, we rarely go for any surgical procedure. Lumbar disc prolapse, if the flexion extension views do not show any significant movement, we don't do any fusion. We just do a microdiscectomy or an endoscopic discectomy. And in our practice, what we follow, what are the indications for leaning towards fusion? Age, elderly age, probably I think we lean more towards doing a fusion so as to avoid a second procedure in case the first the patient develops any problem in the postoperative period. High BMI, again, probably going for fusion might be a better alternative. Facet joint orientation. Now, there are a lot of studies on facet joint orientation which say that a vertical facet joint orientation, even in the lumbar spine, like we have studies in the cervical spine, is less likely to cause any listhesis compared to an oblique or a horizontal facet joint orientation. Facet effusions, presence of rheumatoid arthritis, and weak paraspinal muscles probably should prompt us to go in more in favor of a fusion. And failed back surgery syndrome, definitely we opt for a fusion in these cases. And a long segment laminectomy, which is more than 3 levels. Scoliosis, I don't do degenerative scoliosis, so I don't think I'll be able to talk on that.
Please conclude.
Thank you.
Thank you. We will move on. I now request Dr. Vamshi to come and present his paper on multi-level fusions.
Yeah, thank you, Dr. Manas and Dr. Savati, for the opportunity to present. So my talk is kind of 80% has already been covered by Dr. Murthy. So it's on the fusions for severe lumbar canal stenosis, the long-term results and the optimal management strategies. So we had a patient like 3 cases in the last 1 month who have come back for us for a resurgery within 1 year of lumbar spine surgery that has been done. One of the cases is a laminectomy, which was done, laminectomy and decompression, which was done for foraminal stenosis, and 2 cases where a single level fusion has been performed, and patient has come back within a year with an adjacent level segment symptoms. So that prompted us to look at, like, I mean, are we having any higher rates of complications, or are we being too aggressive? And there's always a debate that goes on in the department when we say lumbar sternal care. Should we fix? Should we not fix? And there are all school of thoughts, and there are quite opposite views on this. So the problem statement is we have an aging population, and there are more and more patients that are being operated 60 plus. Like in the past 10 years, the number of fusions have really not doubled, but probably tripled compared to just the laminectomies that we are doing. So the laminectomy and disc removals, once the endoscopy has come in, even bitubular retractor has remained only an option for a simple disc case, a soft disc. So there is always these options of decompression alone versus single level versus multi-level fusions for lumbar canal stenosis. And this is one index case, like where she's a 50-year lady who has come with multiple disc bulges. There's more of axial back pain, and she has a radicular pain, failed conservative management. So the question that comes here is, if you see the axials, the 3 levels are fixed. So should we fix all the 3 levels at 50 years of age and end up with an adjacent segment degeneration? Maybe patient coming back within 3 to 4 years is the question that comes into the mind. Or should we just do a 2-level fixations or a single level fixation and do some foraminal decompressions at the levels above? These are the dilemmas which the spine surgeon goes back. And the biggest embarrassment the pain that the spine surgeon goes through is the patient comes back with the pain within a year of that he having undergone surgery. So this is another 70-year-old guy. So these are 2 different scenarios. Someone in the middle age coming with the multiple level degeneration, and 70-year-old coming with a multiple level degenerations. So what is the optimal treatment? So we as well examined the literature review. Dr. Murthy has already done it. So the sports trial 1 has definitely settled the question whether conservative versus surgery, and the surgery is the option. So a sub-analysis of the sports trial, which was done way back in 2013, they looked at where, I mean, almost 50% of their patients has multiple segment degeneration. They looked at a single level fixation with a multi-level decompression versus a multi-level decompression with a multi-level fixation. So fuse all the 3 levels, or just fix 1 level and do decompression at the 2 levels. So they said, like, I mean, they have by and large similar outcomes. So it's a very it's difficult. There are a lot of shortcomings in this study. So an analysis of 10 up to 8 years of these sports trial patients have been done, and what has been proven is up till 4 years the fusion procedures have definitely given much more pain relief, and after 4 years, 4 to 8 years, the benefit of having done a fusion and decompression starts diminishing. So should we start discussing with each of our patients that whatever fixation that I am going to do is probably going to last only 4 to 5 years, and you may be requiring a second surgery for probably after 5 years. That is one thing. So that is partially we started doing in our practice. And the other studies, like the SLIP study and the Swedish stenosis study, they have quite conflicting opposite results, and the meta-analysis that has been done on this subject of fusing versus laminectomy has shown that the fusion is always better than the laminectomy alone. And what are the resurgery rates? So we started, see, we most of the studies have looked at just 2 years and 3 years of outcomes, and everyone have been very happy, like, I mean, saying that the results are excellent, so we should start doing these things. So when people started looking at, some of the studies have started following up these up till 10 years. So this is one study from Washington, where the workers' compensation subjects have been analyzed. Then 27% of the reoperations happened in 2 years, but this was way back in 2006. So since then, a lot of things have changed. The techniques and the implants and other things have changed. So the latest one that I could pick up was from 2002 from Korea. So where a 10-year outcomes have been looked at. So they, in their cases, it's 6,300 patients have been analyzed, and in 10 years, 831 patients have been reoperated. That comes down to almost around 10 to 12% of the cases got redo surgeries done. And interesting fact out here is the PELDs, the foraminal and endoscopic discectomies had 22% reoperation rates. I tried to look at what are the factors, I mean, which cause the reoperation in PELDs. Somehow, I mean, I could not find in the paper. So when we look at the year-wise, like, reoperation rates of most of these patients, in the first year it's 3.2%, and by fourth year, almost fifth to sixth year it goes to 10%, and by 10 years, 13% of the patients got redo surgeries done in most of these multi-level fusions. So there is a study where this is one study where only multi-level fixations have been analyzed, and the outcomes are 30 when the multi-level fusions have been done. Almost 38% of the patients have got surgeries done in almost 3 to 5 years. So what are the biggest factors once we do all these fixations? See, it's about the adjacent segment degeneration. So the adjacent segment degeneration has been observed in 30% of the cases. So the 30% could be a radiological thing, but when the reoperation rates after the adjacent segmentation degeneration has been looked at in the cases, around 5 to 10% of them are going for surgery. So most of our patients by 3 to 5 years with adjacent segment, either they are becoming symptomatic or probably some of them are definitely going for surgery. So there are different factors described for it, that age, obesity, pre-existing degeneration, menopause, sacral incline, and multi-level fusions. So there are different studies which looked at it for the adjacent segment degeneration. So one study has quoted at 5.8% at 5 years, based on not the radiological or the symptomatic, but the patients who underwent reoperations. So these are some of the realities of operating and fixing aggressively on our patients of lumbar spine. So what is optimal? So the optimal, probably this is a bigger question that we don't have. We don't have the perfect solutions for the lumbar spine. So we don't know the optimal way of treating these things. But we are looking at patients coming back in 3 to 5 years. A lot of patients coming back with failed back and refixations required. So the conclusion is the older patients have more chances of resurgeries and probably requiring multi-level fusions. And it's better that we avoid proximal laminectomies after multiple fusions, because that causes a lot of instability there, and ends up the patient ends up with more resurgeries in those cases. And maintaining posterior column stability after surgery is one thing which is very important. And adding optimal levels of fusion is to be individualized for each patient. Thank you.
Thank you, Dr. Vamsi, for concluding in time. Any question? Yeah.
Wonderful talk, Dr. Vamsi. My question is that what is your recommendation for including a junctional segment? By junctional segment, I mean, suppose the pathology extends to till L1. Do you include D12 also in fusion and S5 on the other side? S1 on the other side?
Yeah, I mean, S1 is always the proximal segment L45 and L5. Once we are fixing it anywhere L45 and L5S1, we are going there. So L5S1 is being a very mobile segment. It has it obviously takes more degeneration than any other level. And when we are going at the thoracolumbar junctions, we are always going up till D10 because there's always junctional things are very, very painful. So even radiologically, we may not manifest, but the patient is coming back with pain. So it's very troublesome to go to the junctions. Like so. S1 has the highest failure rate of the implant where the screws
That
gets
would
pulled out.
mean that if your pathology is extended to L2, you will go right till E10.
I try to fix up till yeah we definitely like I mean we tend to go for L1 including and stopping at L1 is a difficult thing always. We are trying to limit it, but we don't have perfect answers for this.
Just as you have shown 22% risk of resurgery in endoscopic PLD. Now, I think the reason behind this is the identification of blind spots in endoscopy is little less with the monoportal. Now, with the recent UBE techniques, we're able to understand these blind spots, which is exactly present at the exiting route, which is always been not taken care, which can be taken care by UBE, and the results are very optimizing
Yeah,
and good.
yeah, I absolutely. I don't know. I mean, I tried to look at the reasons why the 22% was there, which is way higher than any other forms of surgery. Like, but the biggest factor in this is we need to zoom out of endoscopy, tubular retractors, robots, and see that this is the reality that's happening. And we need to acknowledge that whatever forms of fixation you do, you probably can minimize it maybe 0.5%, 1%, but it's not going off. So it's the reality of it.
Mike.
Maintained the spinal stability. At the same time, you had good decompression where the patients went on for ages. So, however, because of this instrumentation and the company-driven commercial this thing now, the instrumentation coming to vogue. So, multi-level stenosis without any instability, that was a very good surgery, interlaminar decompression at different levels.
Sir, at a severe stenosis, like
yes,
just doing decompressions have failed.
You have
I mean,
to
it has
use.
been-
You have to
we
use
landed with the biggest
you-
embarrassments of
you have to use the
patients coming
microscope.
back.
You have to use the microscope and go underneath the facets and undercut it.
Sir,
You have to spend time.
There's a huge endoscopic brigade, I mean, who are just doing it and failing and coming back. We are seeing more and more patients coming back where, I mean, fusions are not done, just decompressions are done.
You're talking endoscope. I'm talking pre-endoscopic era.
Yeah, exactly.
So that's the experience.
It's the same. It's the same thing. Right?
I must take you back to the paper of Dr. Balparameshwar Rao from Hyderabad, who presented his work on more than 1,000 lumbar laminectomies. Please don't forget.
Yeah, this is a very big topic about discussion. One is progression of stenosis. The after progression of stenosis at the level of surgery, then came the adjacent segment disease disorders. Like Ashish was bringing out the preserving the tension band is very important. That like many times what we do is we straight away cut the spinous process, interspinous ligaments, which is not necessary. With the advance in the development, I think we can always do the so-called the sublaminar, subspinous laminectomies or IDSS, that is internal decompression of spinous stenosis. This will certainly reduce the progression because by biomechanically what we are doing is we are removing absolutely the posterior tension band. And this is not going to be good for the biomechanical weight load. Weight sharing is going to be terrible, and that is going to imply over the facet joints, and facet joints will further degenerate, dystrophy further degenerate, and small stenosis, small listhesis become further listhetic. This is what that 5 years period is coming. If you carefully look at that 5-year period is coming only at this time, where I think Professor Ramani is not there. But 5 years is the adding of the instrumentation was developed over a period of time, but then certainly it helped in not all cases, in minimum number of cases. But we are using more. We're tremendously using more instrumentation, and we forget to address the one level above. You said you should not decompress one level above. Don't do a laminectomy. Now imagine you fix up the spine, but still if you have the tension band, I'm talking about subspinous lobster technique. I hope that you know about the subspinous lobster technique. You cut this interspinous ligament lowermost down and then cut the base of the spinous process and take that as a lobster, rotate it, do the work. One, you put the pedicle screws or whatever you want, and then pull back and suture it to the spinous. Because many times we are forgetting to do that. The two ways. One is that we are tired or we are not interested, but if you start doing it regularly, it becomes much easier. So this is ASD can be reduced, and at the same time, the further stenosis can be reduced. Because this is a never-ending story about this particular discussion. Never-ending story about it. I call the next speaker, Dr. Sridhar. Yeah, Sridhar is going to talk on anterior approach to the thoracic and lumbar spine. I forgot or not? Yeah, true. Yeah, please.
Chairpersons, friends, at the outset, I thank Manas and Savit for having me here. I thought I will talk on a topic which is not really spoken about, but I think is something which every person doing spine should know how to do. Before I start, my pranams to Professor Ramurthy, who allowed me to take on spine and develop it in VHS when we were really not doing anything much. Parthiban knows we started doing spine almost the same time. And somebody whom we looked, up to, who was doing spine in a big way at that time, Professor Ramani. So pranams to both of them. Also thanks to my orthopedic colleagues, like Sushil Patkar said, I learned spine from them. I learned everything about screws, rods, wires from them. To my cardiothoracic and general surgery colleagues for the work done here. Now the anterior approaches, which means the retroperitoneal transthoracic approaches, were all done for tuberculosis mainly in the 1950s, and then it developed into the 60s, and then came the VATS procedures also, which were done. Now, why anterior anterolateral? That's the question now. Everything is being done posterior. Why? Because this is one procedure which gives you a look right across the spinal cord when you want to decompress the spinal cord. And that's the idea of this procedure. Because all other techniques do not give you this surgical point of view. Everything does not allow you to look across this way and across the anterior surface of the spinal cord. And that is why the anterior or anterolateral approach. Now, what are the different approaches in the thoracic and lumbar spine? Starting from the apothoracic, you can do the transclavicular or the anterolateral intracavitary. The mid-thoracic, anterolateral, intracavitary, thoracolumbar, you do the transdiaphragmatic, and the lumbar, of course, the retroperitoneal approach. Now, what are the results of these approaches? Let's look at some literature. 145 patients. Actually, there is not much in literature if you actually go through literature. Very surprising. 145 patients, good results, rate of surgical complications very low, direct access, optimal neural decompression, stability is achieved, resolution of symptoms. Another article, 93 patients, it's an effective procedure. You are able to achieve vertebral body height. And these people who used it for kyphotic deformities then extended this to oncology and infectious diseases as well. This paper from India looked at 16 patients and a 1-year follow-up. And it was only this particular patient where the implant failed. All others did reasonably well. And this was what I think even I felt, even though anterior approaches have many benefits in selected patients, very, very little attention in literature. There are papers on vascular injury. Now, actually, the rate is very low, but the maximum risk of vascular injury is when you do the retroperitoneal and you're going to the iliac vessels, and when you are actually having tissue which is growing over the vessels and you really don't know where the vessels are, dissection can be a problem. So you have to be careful there. This is a paper from Ashwini Sharan's department, which is one paper which had a huge percentage of complications. This surpassed all other papers, and they felt that this was because they had a very broad definition of perioperative complications, and also the case complexity of their referral practice was such that perhaps their complication rate was very, very high. There is also a debate on whether you should approach this right side or left side. This paper said that they preferred to do it right side and they had better results from the right side, but I personally always prefer the left side. Why? Very simple. An artery is easier to handle than a vein. You can repair an artery if you have an arterial problem. The liver is more difficult to get out of the way. And it's only when there is a significant lesion on the right side will I do a right-sided approach. Otherwise, for me, it's always a left-sided approach. The thoracoscopic transpleural approach has been described. We have tried doing this. We have not been very happy about it. Maybe it's the learning curve. We have tried also a laparoscopic assisted approach for the retroperitoneal. Again, maybe it's the learning curve, but I think that may be the way forwards. I presented this work in 2008, I think in the NSSA meeting on the anterior stabilization in tuberculosis in 40 patients, of which we did 11 anterior transclavicular thoracotomy in 8 and retroperitoneal 5 with a large follow-up. And the advantages that we found was that anterior stabilization directly addresses the unstable column, prevents it enhances fusion rates. And there is no requirement for an additional posterior procedure where you don't disturb the posterior elements, the muscles, everything is kept intact. The gains at surgery, early mobilization, reduced hospital stay, better healing, better psychology, and prevention of deformities. And if you see this, this is the angle at which you work. And that is where you get your stabilization. Now, certain things is very important when you start to do this. You look at the bone structure, whether you can actually do that short segment stabilization that you want to do, which is the actual advantage of this surgery. But the problems at surgery, when there is a partly treated patient, you get granulation tissue covering things, your anatomy is not very good, you can get edematous porotic bodies where your screws will not go in, and you can have multi-levels, so what do you do? Now, coming to the upper thoracic approach, Narayan Sundaresan and his team from Chicago were the first people who actually brought this into focus and talked about a transternal approach. We modified this into a transclavicular approach by doing this. This was our incision. The T-shaped incision was their incision. We modified it to this, and then we used to do this. Now, this you will recognize as the old stainless steel plate, and we use the clavicle as the graft. And those of you who have never seen stainless steel plates, that's how it looked like. So this was at 2 years post-op. You can see the scar, and that's fusion there with the plate in. This is a 16-year-old lady, and this is the lowest that we have gone with this approach to T4. This was a patient which we used in trauma. This was a complete dislocation. We used a posterior anterior approach, and we did this, and it was published in Surgical Neurology. We started when the implants, actually titanium implants and pedicle screws came, we started using that with a single rod, 2 screws construct. We were not very happy with it, and therefore by 2010 we started doing a double rod fixation with the same transthoracic approach because there were coming plates with 2 rods, but we found that for Indian patients it was too broad. In children, it can be used. This is a child, 5-year-old child. You can see the granulation tissue there and the cord compression, and we use this for children in a very good results, and sometimes even for the lumbar spine, the retroperitoneal. Dorsolumbar tuberculosis is something which you can deal with. Some lesions like this with cord compression here. You can deal with this, remove the, you do actually the retroperitoneal. How I do it is do the retroperitoneal part first and then do the thoracic part, and then you cut the diaphragm, do your work, and then suture the diaphragm back again. Patients do very well. Sometimes you have got uncommon presentations like this, a 10-year-old girl where the vertebral body itself prolapsed back into the spinal canal, and this had to be dealt with. We dealt with this again through the retroperitoneal approach, and this was fixed, and this was published in Neurology India. We have used this even for vertebral hemangiomas like this. This was a very, very long time back, I think in 1998. This patient, we first tried a posterolateral approach here, and it didn't really work out. We removed just a bit. We tried to fix it in some way. It didn't work. So we then went transclavicular, and then we were able to do this approach. We now have a follow-up of more than 20 years of this girl, who's now a young lady doing very well. We are still using this when we have patients like this. When you have small children with a bad kyphotic curve, post-tubercle like this, we have done this approach, and we are able to remove the gibbous, do a short segment fixation, and so that we don't affect the growth of the child. I think, therefore, in conclusion, the next time you see a case something like this, remember the anterior and anterolateral approaches. It's a good option. Don't get scared about it. It's a very simple operation. Don't get worried about it. I think you should try and use it. Thank you very much, and welcome to the Asian Australasian International Neurosurgery Update in February next year. Thank you.
Thank you very much, Dr. Sridhar. Any comments? Dr. Sampath, do you like to comment? You have got a lot of experience on thoracic spine.
Sorry,
Okay.
sir. I've been doing a lot of thoracotomies and lumbotomies, and I do extrapleural thoracotomies, endothoracic fascia along with the rib periosteum. If you move it, so the morbidity will be much lesser because I don't even put a ICD. We don't require it. Second thing is when you're, I've been using the cage as well as the screws, but with the this one staples. With the staples, the screw won't wobble. So you don't require two screws. You require one usual pedicle screw of 6.5 with the staples. I've been doing it.
See, the implants now are much more developed than when we actually started. So a lot of my work has been with stainless steel and the first generation titanium implants. Yes, I totally agree with you. Now technology is fantastic.
It's 1989 when I was asked to do a laminectomy in a patient of tuberculosis, 16 years old boy. I still remember his face. Kyphotic deformity with some weakness of the legs. Go and do a laminectomy. I'm not going to name the senior who told me. I did the laminectomy. Post-op patient stopped moving ligaments. That was my learning lesson. From that day, I decided that I'll go transthoracic. Requested my thoracic surgeon, cardiothoracic surgeon who came to my help. And since then, all these patients with infection, trauma, with anterior deformity, I go transthoracic. I didn't face any problems going through the pleura. Absolutely fine. They do very well. Tuberculosis, in tuberculosis, you can't strip off the pleura.
Peritoneum.
Not so easy. Not so easy. Yes. We tried that. Landed in problems. So, and we used to fuse with bones, iliac or the rib graft. So the instead of the rod, the rib and two stainless steel screws. That was what was available, and they fused so well, and they did so well. I tell you.
There's just one comment I would like to make. I think as neurosurgeons, our tissue handling is much better than both the general surgeons and the cardiothoracic surgeons.
And orthosurgeons.
Of course. Of course. I'm not even including them in this. So I think we should not get. No. Excuse me, let me finish. Please let me finish. I have not made my point yet, Dr. Sampath. Let me finish. Our tissue handling is better. Full stop. So there is no need to be worried to learn the thoracotomy or the retroperitoneal approach and do it ourselves. Please learn it.
The anterior approach thoracolumbar area is extremely good. Lumbar is difficult for a neurosurgeon also. If you have help of cardiothoracic surgeon, even without his help, to approach anteriorly, anterolateral is extremely good. As a matter of fact, we had been fortunate to have titanium cage and plates from 99 onwards. We have started up to 2008. We have done. And it's very good, particularly for fractures. After the injuries, when they came fractures, lot of compressional fracture, cord compression, you go anteriorly, do it is extremely good. And so far as the intrapleural is concerned, not necessary if it's trauma, you can go extraplurally unless the pleura itself is torn. You can go do the anterior, and you have the Z plates, titanium Z plates and titanium cages. You put that, then subsequently, of course, plate was not used. You have to have the rods and cages that has been used. Almost we have done 150 to 160 cases. The results are extremely good. The care is good also, therefore the results are also equally good. I agree that it should be practiced. Yeah. Certain cases must be done. Tuberculosis, these days, since other things are available, one can go posteriorly. There is no requirement of going anteriorly. But trauma, tumor, other situation, it can be done and should be practiced by our young surgeons.
Thank you very much. I think it's for further discussion over the lunch. Next.
Next, we will call upon Dr. Umesh from Bangalore to talk on role of sagittal balance in spondylolisthesis. Dr. Umesh.
Good morning, everyone. At the outset, I would like to thank the organizing committee, Dr. Manas, Dr. Savit, for having me here and giving me this honor of presenting this topic in front of my teachers, Professor Shastri, Professor Sampath, others. So sagittal balance, as we know, is taken a very big role in this decision management in deformities, whether it is focal or whether it is diffuse. And though the importance is more in the last 1 or 2 decades, the concept has been realized much earlier in the 1970s by Debussy's cone of economy, where he realized that the balance resides within a cone that has its apex at the feet and then at its base at the head. And the smaller the cone, the lesser the muscle balance or the muscle strength that is required to maintain the balance. And in pathological conditions, or the cone becomes wider, the muscular strain to maintain the balance is higher. But in the modern era, we use these parameters to compare. So just to refresh your memories before I dive into the topic about how these sagittal parameters influence our decision making in spondylolisthesis, I'll just refresh what we are looking at. What are the parameters that we are looking at? So usually it looks complex, but if we start measuring it, it's very simple. The easiest to measure is the sacral slope, which is the slope that the superior end plate of S1 makes with the horizontal plane. The next is the pelvic incidence, which is the important parameter, which is a constant for any given individual in an adult age once skeletal maturity happens. And this is measured with a perpendicular line from the upper end plate of say, S1 to the line joining the midpoint of the sacrum to the midpoint of the femoral heads. And then there is the pelvic tilt, which represents the version of the pelvis, the anteversion or the retroversion of the pelvis, which is measured with a vertical and the line joining the midpoint of the sacrum and the midpoint of the femoral heads. Now, these three are very important parameters which are linked together by this equation that is PI equals PT plus SS. And so any PI, because PI is a constant, so any change in sacral slope or PT is going to result in a corresponding change in the other parameter as well. Obviously, lumbar lordosis is something that we always consider, but what has gained more importance in recent times is the lordosis distribution index. That is the contribution of L4 to S1 to this overall lumbar lordosis, which has got a very important role in the upcoming or the recently prescribed gap stores, which ideally should be 50 to 80%. Anything that is less than that is considered moderately or severely disproportionate. We also have to understand that the PI varies from person to person. In patients with low PI, obviously the sacral slope and the PT is also going to be less. The lumbar lordosis is less in order to match the PI, whereas in a patients with high PI, again, the lumbar lordosis or the sacral slope is going to be elevated. The sacrum becomes horizontal in order to match with the PI with an anteverted pelvis, of course. Now, The only global parameter that I'm going to consider in this talk is the SVA, that is the sagittal vertical axis, which is basically the distance of a C7 plumb line that is dropped down from the midpoint of the vertebral body of C7, the distance between this to the posterior end of the S1 end plate. And it should normally be within 5 centimeters, where it is considered as balance. Now, why are we discussing this topic? Why is lordosis or sagittal balance important in spondylolisthesis? Now, as we know, if there is a alordotic or a non-lordotic lumbar fusion, the upper segments usually compensate. So this change is very important that happens. So whenever there is a non-lordotic lumbar fusion, the upper segments usually compensate by either retrolisthesis or by segmental hyperlordosis, but the overall spinal balance is still maintained. When the lumbar lordosis, loss of lumbar lordosis extends across multiple levels, then usually what happens is the pelvis retroverts, the pelvis tilts in order to maintain our overall spinal balance. And at this stage also it is compensated. Now, even when the hip locks in full extension when the pelvis retroverts, but if the lumbar lordosis loss continues or if the kyphosis continues, in those cases, the knees flex and the ankle also flexes in order to again maintain our straight gaze and to compensate the overall spinal balance. But if with further progression, again, there is a significant progression and the spine becomes decompensated. That is when the SVA starts falling forward. Now, this is illustrated by the example that is given here. So, as you can see now, it typically represents what I was shown, non-lordotic lumbar fusion at 2 levels done 3 years before the patient comes with a superior adjacent segment disease at 2 levels. And of course, what we did was we did a retroperitoneal approach and we did 2-level O lifts. Now, as you can see, looks good, right? But the SVA is not corrected. And in these patients, again, the SVA, because the SVA is not balanced, the overall spinal balance is not maintained. They come back with some, subsidence and all those things, and then it has to be redone. So what are the goals of spinal realignment or fusion surgery that we have to consider in listhesis? We know that these SRS swap criteria that are there represents that SVA should be less than 5 millimeters, the pelvic tilt should be less than 20 degree, and there should be a spinopelvic harmony. That is, there should be a PI-LL mismatch, or the lumbar lordosis should always be within 10 degrees of the pelvic incidence. That is when we say that the spine is balanced. Now, let us consider two different categories, degenerative spondylolisthesis and dysplastic or ischemic spondylolisthesis, where the management completely differs and how the importance of sagittal parameters play in management of these conditions. Now, as we know, interbody fusion and lumbar lordosis are determined by several factors, which includes reduction of deformity, adequate posterior anterior release, size and the position of the interbody cage, curvature of the rod and posterior compression that we do, but also mainly dependent on the surgical approach and the type of interbody fusion that we do. Whenever we do an MIS TLIF or even in an open TLIF, it's always better to do bilateral facetectomy when our aim is to restore the lordosis in order to do that posterior compression, put the cage very anteriorly and do the compression from posteriorly in order to maintain or restore that lumbar lordosis whenever is required. And you can also use an expandable hyperlordotic cage in order to restore this lordosis. Retroperitoneal approaches also are a very good method of restoring these or maintaining these lumbar lordosis, as has been shown in this particular case. Now, we all depend on certain classifications. How do we choose? In particular case, how do we choose what is the method that has to be followed? How much lordosis to be restored? Whether regional correction, segmental correction is enough or a global correction is required. So for a degenerative spondylolisthesis, the French classification serves a very good role. We don't have to go into the details. In a balanced spine, if you can see, the SVA is normal, PILL mismatch is not there, segmental lordosis is also maintained. So these are called type 1A, and these are the examples where you can just maintain the lordosis while doing your fusion. We should make sure that we don't take away the existing lordosis while trying to achieve a fusion. And this gives a very good results. As you can see, LDI, pre-op and post-op, they are all very favorable. Now, this is another example. Even in hyperlordotic segments, using expandable cages will help. You can always achieve a good lordosis in these cases. Now, there are certain types of type 1A cases which we have to be very careful. For example, a hyperlordotic L5S1 segment that is 18 degrees here. Now, we know that a posterior method may not be effective always in restoring lordosis in these cases. When we put it may be difficult to put a big cage through a posteriorly wedged vertebra, through a posteriorly wedged disc space. And in these cases, it's always better to choose an anterior approach where hyperlordotic cages are available and you can easily restore or maintain the lordosis in this case. As you can see, the LDI is maintained and the PLL mismatch can be corrected. Now, when spine is balanced, that is, there is no PLL mismatched, but the segmental lordosis is lost in a particular case. So these are classified as type 1B. These are the examples. Again, in these cases, the primary aim should be to restore the disc height or to restore the lordosis, where, as you can see there, it can be done with a retroperitoneal approach or even with a posterior approach, as I shown in an example before. Now, the main things or predominant type of cases where it requires certain decision making is one where PILL mismatch is lost, either with a normal PT or with an abnormal PT. And these are the type of cases where we have to be very careful in order to restore lordosis. We have to probably do a bilateral fascectomy, put a large anterior cage or an expandable 15-degree cage. And in those cases, as you can see, a disproportionate lordotic index, PLL mismatch, it can be restored to normal dimensions. And again, this is again one more case where anterior approach can be used to achieve the same. The type 3 cases are where there is a kyphosis where you need a much more or a much regional correction where you will have to do multi-level fixation in order to achieve. So this is something that was done using a retroperitoneal multi-level OLIF approach, an SV of 8.5, which was corrected to 5.5. Dysplastic and ischemic listhesis are completely a different matter because we are dealing with much more severe pathology. The translation is more than 50. You also have a sacral dome rounding and L5 wedging in these cases. And many cases, usually there is not just a translational abnormality, but also an angular or a kyphotic deformity that develops, which has been measured using several angles. And I'll not go into the details because of lack of time. The Debussy lumbosacral angle is the best one to measure these kyphotic angle in these particular cases. Now, SDSC classification has given a very good criteria to determine what type of cases that are to be done. If it is a low-grade slip, if the PI is less than 45, it is type 1. The PI is in the normal range. Type 2, PI is more than 60, it is type 3. I'll just take a minute extra if you don't mind. So in a high-grade slip, again, we have to see whether the spine and the pelvis is balanced or unbalanced. In a balanced pelvis and a balanced spine, it is type 4. Unbalanced pelvis and a balanced spine, it's type 5. When both the pelvis, the regional as well as the global parameters are unbalanced, it becomes a type 6 deformity, as has been shown here. The management will accordingly change in these cases. Now you know the principles of management. It is to restore the lumbar lordosis or to restore the global or regional spinal alignment. What we have to note here is even in a high-grade listhesis, the controversy always surrounds in high-grade listhesis whether to reduce or not. So if it is an SDSG type 4, you can just maintain the segmental lordosis without achieving a reduction because the spine is already balanced. Whereas in a type 5 and a type 6 SDSG, it's always better to reduce the listhesis in order to correct the spinal parameters. Just a few examples here: SDSG type 2, again SDSG type 4, where lumbar lordosis is just maintained. You're not restoring lordosis, you're not correcting the spine completely. Again, but in SDSG 5 up to SDSG 4 is something we recommend can be done with MIS techniques. Once it becomes SDSG 5 or SDSG 6, it always requires an open surgery with bilateral fascectomy, osteotomy of the sacral dome, as well as probably an anchor screw at L3 or L4 in order to reduce the listhesis. So just to take home message, we know that non-lombotic lumbar fusions lead to a higher risk of ASDs and poor outcomes. The recent classification system emphasized the need or the role of sagittal balance and the importance of including them in our surgical planning. Evaluating spinopelvic parameters should become a routine, and maintaining and restoring lordosis is utmost paramount. Even if we are not doing till now, it is high time that we start doing them, even in a single level or a 2-level lumbar fusion. Thank you so much.
Thank you, Dr. Ramesh. We'll move on to the next paper, When and How Much to Reduce Spondylolisthesis by Dr. Krishna Sharma. We invite Dr. Krishna Sharma.
During lunchtime, you can discuss with Umesh and can enjoy learning a lot of things, whatever he spoke. It's a huge subject. Umesh, are you hearing me? I have told everyone to meet you in the lunchtime or the dinner time, and I request you to stay 1 or 2 days because a lot of people have a lot of questions and answers, right? Stay for 2 days.
Uh,
Sharma.
yes, sir. Good noon. My topic is on lumbar spondylolisthesis. I thank Chairperson and the organizers. I bring greetings from Nepal. I'm talking about in spondylolisthesis. The term spondylolisthesis was used by Newman and Stone in 1963, and it was defined by North American Spine Society as acquired anterior lateral or posterior seepage of the superior vertebral disc over the adjacent inferior disc. It is unique to humans and related to the assumption of an upright posture and lumbar lordosis. The incidence in adult is 3 to 8%, and the prevalence is 11.5%. There are different types of listhesis, and ischemic listhesis is a defect in the pars. The others will be talking, and it is found in the growing children who are involved in hyperextension games associated with other bone and connective tissues, and more seen in the females when the slippage angle is more than 25 to 30 degrees. Degenerative spondylolisthesis is a part of arthritis, and where the morphology of LS spine is disturbed, like degeneration, sagittal oriented facet joints, increase pelvic incidence, L4-5 body inclination, and altered pelvic morphology. It is the low-grade spondylolisthesis is almost 75% of the total one, and is common in short height, high body mass index people, and obese one, and of course with a low bone mineral density one. However, narrowing of the intervertebral disc, spur formation, subcartilage sclerosis, or ossification ligaments are protective against these slips. These are the different investigations where the X-ray is the simplest but the best, especially standing, flexion extension, and oblique views. With the other investigation, we get the diagnostic, instability state, grade and classification, and follow-up prognosis, and associated pathologies. We just heard about the different parameters which are so important. Almost 100 years back, Medding gave us this classification which we are still using and still useful. And broadly, this divided into low grade and high grade. However, we have to bear in mind that the slip severity and progression correlate poorly with clinical symptoms and response to treatment. There are other classifications which are also been described earlier by our speakers. The aim of the treatment is to relieve pain, neuronal compression, and other associated symptoms, and to restore the back mechanical stability and sagittal alignment, address the underlying causes and issues, and improve the function and quality of life. There are many influencing factors in the treatment, like age, obesity, smoking, pain, and the overall quality of life, presence of deficit, degree of sleep, quality of bone, as well as osteoporosis, response to conservative management, overall health and level of function, and personal goals and the expectations. Each patient's treatment algorithm should be individualized to achieve optimal and practical outcomes. Broadly, the treatment is conservative or surgical. The conservative management aims at symptom relief and prevent progression. It is the first line in low-grade, younger patient with minimal deficit and mechanical back alone, and successful in 85 to 90%, with 70 to 90% returning back to the activities. It consists of bed rest, medical therapy, heat and brace. Whereas in chronic case, you add physical therapy, brace, lifestyle modification, evaluation of the and correction of social and psychological factors. Epidural steroid injection and nerve blocks have been also tried. Surgical treatment is a more definitive procedure with benefit of operative intervention have been well established by several large-scale randomized controlled trials, indications being failure of conservative management, high-grade slips, symptomatic patient, and also in traumatic and iatrogenic slips. We should not do in poor health operative risks outweighing the potential benefits in osteoporosis and those with smoking, which are associated with more than 50% of non-union. Cessation of smoking is an essential part of the patient commitment to success of the operation. These are different surgical techniques. The decompression only is practiced in minimal symptoms and low-grade listhesis who have low back pain rather than the extremity pain. Stable with the facet angle more than 50 degrees and disc space more than 6.5 millimeter. The procedures could be decompression alone with preservation of the midline structure, laminectomy plus minus medial fascectomy, decompressing the centrally and laterally the dura and the nerve roots, and nowadays minimal invasive micro decompression. The complication associated are atropine glystasis, progression of the sleep, recurrence of symptoms, or incomplete relief of symptoms, and are less favorable in almost 40% of cases. But when we add fusion to the decompression, especially in hypermobile glystasis, the fusion gives better clinical outcome than decompression alone. Lack of consensus on fusion in situ or fusion after reduction glystasis, especially in low grade, is there. There's greater risk of decompensation and pseudoarthrosis versus reduction and fusion put together due to uncorrected sagittal balance. However, we have a better results with decompression followed by placement of allograft supported by spinous process, plating or wiring. Now, when we add reduction is recommended with sagittal imbalance and those with high sleep angles, and they improve the segmental lordosis, standing posture, and overall sagittal alignment and spinal biomechanics. It places less strain on the posterior fusion mass and spinal hardware, decreasing the incidence of non-fusion and spondylolisthesis progression or recurrence. There's a greater surface area of contact for arthrodesis. Even partial reduction of sleep angle is advantageous. So it also causes indirect neuroformal decompression and relieves tension and pain. Posterolateral fusion is one of the most commonly performed procedures in spondylolisthesis. A meta-analysis of its study shows there's an increase in the rate of fusion and correlated with less pain and greater rate of returning to work. Stabilization of 3-column helps. An addition of interbody fusion provided no statistical difference in clinical satisfaction, disability index, fusion rates, reoperation rate, and cost value when followed up to 3 years. Interbody fusion is indicated where there is a high degree of sleep with loss of disc height. Biomechanically provides immediate support to the anterior column and better rate of fusion and increase in stability. It corrects deformity and prevents deformity progression. There is a significant spontaneous reduction of spondylolisthesis also, increases the intervariable height and relieves the compression. Some surgeons prefer 2-level fusion. For enhancing fusion, nowadays they add intertransverse or transverse process secretella, bone morphogenic protein, artificial disc, and lordotic taping case devices, bone growth stimulators, osteoinductive plates and other semi-solid mixtures. Use of a direct electrical current for stimulation of fusion for treating pseudoarthrosis, and bioactive glass as bone substitute or bone expanders. Kulkarni sir has given us a scoring system of fusion where these are the parameters, and fusion is recommended if the cumulative score exceeds 5.5. The key point in surgical treatment is wide lateral exposure and decompression of the nerve roots. Remove the potentially compressive disc material or bony sacral edges. Use of small interbody cages. Avoid excessive distraction. Adequate correction of the sacral retroversion to relieve tension on the nerve root. Addition of posterior instrumentation and interbody fusion when indicated. The complications associated are neurological deficits in almost 5 to 30%, pseudoarthrosis from 1.8 to 24%, transitional syndrome from 13.8 to 19%, CSF leak, and failure of fixation. Minimal invasive surgery is the process going on now, and it's effective and safe. We have to consider other pathologies like osteoporosis, trauma, tumors, and congenital anomalies and genetic factors. Sports trial has given us some treatment effect predictors. Anticipating a high likelihood of being pain-free with surgery is a significant independent predictor, which could be very difficult to fulfill. The outcomes are worse who had symptoms more than 12 months. Surgical therapy overall improves health and provides better value over 4 years as compared to the non-operative cases. I'd like to summarize by spondylolisthesis greatly affects the quality of life. Appropriate selection of patient and individualized investigation and mode of treatment determines the outcome. Conservative treatment in the is the first choice of treatment in minimally symptomatic and low-grade spondylolisthesis. In symptomatic patient, wide neural element decompression along with adequate reduction and rigid instrumented orthodesis is safe, effective, and durable with low rate of neurological injury, favorable clinical results, and high fusion rates. The future demands minimal invasiveness, enhanced fusion, and dynamic fixation. These are my references. Thank you very much.
Thank you, Dr. Sharma. We'll move on to the next paper, How to Manage Pain in Post-Lumbar Surgery by Dr. Ashish Pathak. May I invite Dr. Ashish?
Thank you, Manas, for the kind invitation. I deliberately chose this topic because this is the one which is least talked about. This is a problem for everybody. Now we know that in US, the statistics which goes back about 20 years behind, the 1 million spine surgeries then has increased. There were 2 lakhs spinal fusion procedures. 16 billion was the expenses. And of course, we know that there is a risk of 10 to 46% failure risk as per the different literature quoted. And there are meta-analysis on this, which says that in 70,000 patients, the failed back syndrome amounts between 5 to 27%. So this is a big problem which every surgeon faces. When a patient comes to you, there's so many questions, and I'm not going to go through all of them. Am I going to be all right? Am I going to be walking? Is there any risk of becoming paralyzed? All these questions you have to very patiently answer, and you have to take each question at a time. The question is, who are the patients who have failed back syndrome? Are there criteria? Yes. Older the age, smoking, poor mental health, inappropriate surgical choices, very important. So you have to be really very, very careful in choosing a surgery. And then there are other factors like socioeconomic status, obesity, as we know, is always a spoiler in many of the situations. So all these things have to be kept in mind. But of course, misdiagnosis, the wrong level, the first line, leads to failed back syndrome. Very important. So there are some cases in which there will delayed relief of pain after surgery, and epidural hematoma, infection, pseudomeningocele, nerve injuries, these can delay, but these are not failed back syndrome. But then long-term pain, when change the biomechanics, as was very nicely described earlier, load distribution changes, deterioration of the spinal segment anatomy, all these are important spoilers and give long-term pain. So these have to be understood very carefully. There must be a good pain control immediate post-op, very important. The functional outcome, early ambulation, early discharge, getting onto physiotherapy are all dependent on good pain control. So that has to be always kept in focus. So what are the things that we tamper with? The vertebrae, discs, ligaments, dura, facet joints, capsules, nerve sheaths, fascia muscles, host of things we tamper with when doing a spinal surgery. And all these are supplied by the dorsal rami of the spinal nerve, and they have got sympathetic and parasympathetic connections as well. So there's a mechanism. The nociceptive receptors, the structures which are supplied with the posterior rami, there's irritation, compression, inflammation, and the patient who have got chronicity of the pain, they also develop something called referred pain, and they're very much used to that referred pain. So very difficult to get rid of that. You must remember that. So what would be defined as a genuine post-op pain? Pain more localized, transitory, gets improved with time, amenable to medical therapy. And incidence of post-op pain, of course, depends on the level of surgery, but doesn't depend on the region of surgery you do. Cervical, thoracic, lumbar doesn't matter. Now, what would be, so the line is drawn, what would be then the post-surgical pain syndrome, which is the chronic problem that we face? Nerve root injury, compression, arachnoiditis, epidural fibrosis, adjacent level degeneration, as we discussed, saw the discussion, and of course, spinal instability and of course, alignment changes. These are very important. So this patient had a fixation. We know after 4 or 5 years, there can be problem adjacent level degeneration. So you have to be cautious about it. And the common causes of persistent pain would be spinal instability and abnormal motion. So you have to be very watchful about lack of spinal fusion, poor posture, prognosis, progression of the nerve injury, and of course, painful spinal fusion hardware. It's very important. We don't recognize those things. We have to understand even a simple discectomy, more than one level or two levels, can give rise to instability in the long run because we are tampering with what nature has given us. Rigid spine, flexible spine, we have removed some bones. So this can give rise to instability. The lack of spinal fusion might need a repeat surgery. Very important. Post-op, we are not aligned the spine properly, not maintain the biomechanics, poor posture, what is called a flat back syndrome. This would also need a correction if needed, if things really go out of hand. If you have not really decompressed the nerve properly and the progression of spondylitis, then again things can go wrong. You might need to have go for a redo surgery. Might be very soon after the first procedure. And what is not really understood that the hardware that we use itself can be painful. And once fusion is achieved, the hardware is no longer required actually. And in many of the cases, you might remove the hardware to get the relief of the pain. This is not recognized. So that people talk about minimally invasive, why do all these things? Is minimally invasive that safe? Minimally invasive surgery yields a long-term recurrence and reoperation rate of 10%. This is for simple discectomy again. So it is equivalent to the conventional discectomy, not really different from in both the type of patients. So post-operative persistent pain, the patient comes with a lot of hope, and then the post-op there is persistent pain, increasing pain, new pain. The patient gets into fear of getting worse, loss of hope, worries that, oh, why did I take a decision like this, and goes into depression. So all these things happen. So the most important thing I would emphasize here, and that should be the carry-home message, preoperative counseling is very, very, and I'll emphasize the word very, very important. Be realistic. Explain in details about the problem. Discuss what you can be solved, what cannot be sorted out. Segment the factors. Associated neuropathy, like things like compression because of compression or diabetes even, can be a spoiler. So don't have a good realistic goal. Need for long-term medications in those patients, the patients the long-term medication will continue with medications. So there can be withdrawal response. We certainly stop those medications. And then of course associated arthritis or rheumatoid arthritis and things like that can be a spoiler. So you discuss and document this, which we never do. That's something which must be followed, which is very important. So be realistic. This is a cardiac venous syndrome. So patient will have some pain. Patient will have bladder problems. Patient will not be the normal one. So you have to be realistic and tell the patient very frankly. Every pain is a vicious cycle. There's anxiety, apprehension, lack of sleep, worry, more pain, more spasms. It goes on round and round. You have to break this cycle. You have to break this cycle. When you meet the patient post-op, see the mood, the worry, the anxiety, the depression, sleep, expectation. You have to dig that out in course of conversation. Very important. And you compare with visit the preoperative discussion and remind the patient what was discussed. And then you got various options to improve: medicines, exercise, physiotherapy, behavioral rehabilitation, neuromodulation, and even reoperation, which is one of the things which must be thought of. So deciding the management is an issue. To assess the intensity of the pain, assess the discomfort, localize the pain, establish the cause. You might need some investigations to prove your point and then plan accordingly. And we've got various tools to see the amount of disability. The visual analog scale is the commonest one, but then you've got the McGill's pain, the brief pain inventory score, the Ostrowski scale, and all those things. But then if you have documented pre-op, that helps you to really decide what has improved, what has not improved, and that's very important. Other thing which is very important is the investigation post-op. That can be a problem. So you have to know what to do. Instability, bone fusion problems can be diagnosed on dynamic X-rays, dynamic CT scan. But look at this. The hardware, an MRI, degrades the image. So you need to have a good hardware and good quality image by reducing those artifacts to really find out what went wrong, what is right, what is still working. Infection, post-op infections. Post-op MRI, post-op infection can be very confusing and you might get confused. And sometimes you might have to resort to PET scan to really confirm the infection. So you localize the pain: diffuse, vague, progressive, regressive, radicular, relation to movement, exercise, posture, diurnal variation, response to type analysis. All will give some answers. You will understand what's happening. You have got pharmacotherapy, NSAID, narcotics, centrally acting agents, mood elevators, drugs for the rheumatoid arthritis and other things which have to continue. In the West, narcotics are very commonly used, but they have got side effects, especially in elderly. So you have to be very cautious about it. They use morphine and oxycodone, but we don't use here. NSAID is helpful if there's inflammation, fever, and things like that, but should not be used alone. It should be added, but there are side effects of that also. Platelet dysfunction, hemorrhage, ulceration, all those things. Commonly used paracetamol is not so effective, but then it helps in elderly. It's an additive thing which should be considered. Liver function should be, dysfunction should be ruled out. Sometimes we use steroids, but that should be short-lived because it has got side effects and it's not a long-term solution to the problem. And you have to understand those who are on chronic medications are the difficult ones. Simple medicines like this won't work, so you have to be careful about them. And you have to speed up the recovery by making a plan of exercise, stopping smoking, home care, caregivers, all those things have to be taken care of. Sometimes physiotherapists are overzealous, so you have to tell them to go short range movement, increase gradually to the tolerance and acceptance levels of the patient. And of course, psychological motivation is very important. Beyond conventional, I'll take one more minute. Beyond convention, we have got the excellent methods of pain control. Nerve root, transform nerve root block, very effective in root impingement, fibrosis. You've got the epidural injections with steroids and other medications. And you've got various ways of giving the epidural injection. You can give a continuous patient-controlled analgesia, or you can use other medications, but they do have side effects if you use long-term. There are intrathecal pumps available. I've used in one patient with an excellent result, but these are morphine pumps. You have to understand the side effects of morphine as well. Spinal cord stimulation, dorsal column stimulation is available again, not for all patients, mostly for spinal injury patients where you have chronic pain. That's helpful. And you've got the neuromodulation techniques, repeated transcranial magnetic stimulation. I've not used them. Deep brain stimulation, motor cortex stimulation. I've not used them again. These are quoted in the literature. Normally, physiotherapists use the peripheral nerve stimulation, TENS machine, and all those things, but really, there's no literature proving that efficacy in the long-term effects of the patient. And last of all, surgery. Yes, there's an article which says 82% of the reoperations were done within 90 days of the first surgery. Most of these requirements decreased gradually with time, but the common cause was repeated disc herniation, spondylosis, undercorrected stenosis, listhesis, and of course scoliosis. And the most common procedure was again a decompression, but sometimes they did a fusion as well. So to conclude, persistent postoperative pain is reported to be as high as more than 25%. You have to remember that. Detailed understanding of the patient's problem is the key to prevent it. Expectation of the patient needs to be trimmed to a reality for his condition. Choose the appropriate procedure, which will be the key to avoid any complications like this. Management is guided by finding the cause of the failure, and multimodal therapy is the key for success. Thank you very much.
Thank you, sir, for nice presentation. As we are running short of time, we'll move on to the next paper. But I invite Dr. S.V. Rangarao garu from Vijayawada to talk on complications of lumbar disc, tips from his 42 years of experience. Dr. Rangarao garu.
Morning, chairpersons, my colleagues. This aim of this talk is mainly to resident trainees and young neurosurgeons in service or in practice, not to seniors, colleagues and stalwarts, because it's just information. Please excuse me, because my tips of practice of what I do may not be done by you, and you may not like it also. Majority of the complications are preventable and man-made. That's what I believe. The whole talk is for my 4 decades plus experience of 8,500 spinal surgeries, most of them done by myself. The complications tend to decrease with increased surgical experience, as you all know. Your target should always be minimal or no complications in a given case which are operating. Then how do you do that? To follow proper protocols, good place selection, and when to treat conservative, when to operate is the most important. Proper pace selection. The clinical selection, the radiological evaluation with MRI positive, even though it is positive, always try to do the clinical examination thoroughly, and always I depend on digital X-ray, AP lateral, and dynamic studies only when they are mandatory. CT is also again mandatory. MRI, our days we used to do myelograms in the first 10 years of an immense residency. After that in OGH, we are doing MRI for the past 30 years and the gold standard. And fresh MRI is necessary when the new symptoms and signs appear. And single film study, please don't rely. It always confusing. When you suspect there is something fishy in the previous sign, go for the whole spine, but never jump to operate. Now, this is very important. To operate or not operate. Always decision, you should always use your brain, clinico-radiological correlation, matching or not matching. If you're not matching, please don't have to go for surgery. Go back at the end of the busy OPD, examine the patient and get localize the lesion first, get full state MRI, then decision to operate. Then what are the do not operate scenarios? Short duration symptoms, the first visit, no deficits, anxious patients. What do next? Proper counseling of patient attendance and good documentation. Never expect the patient that patient comes to back to you. It's only a bit of information and your mindset. Then when you hold on scenarios, when you don't operate, I just hold on. Chronic symptoms, multiple comorbidities, confusing symptomatology, and anxious litigant patients. What next? More spend extra time, document all. Even when you do operate, there are persistent deficits or new CNS deficits. Failure of adequate conservative treatment, the bladder dysfunction, significant disc prolapse after good control of comorbidities. You should always, when you're operating, you should know you can operate boldly. Then what are the immediate indications for operation? TV, LVA, fresh deficits like foot drop, bladder dysfunction, and make sure that the patient is having only that lesion in the lumbar spine. And unstable SSCs should be confirmed pre-op with digital dynamic studies. Then what next to do? When the patients are not willing for surgery, even though it's immediately needed, you have to document it. Please do that. Refer to nearest neurosurgery department where active work is being done. Never send the patient. Except some medication. These are all litigation issues which I faced myself in few cases and learned from my mistakes. Another important aspect of the scenario. Self-check. Operate when you have only adequate surgical skill to operate. You have the basic infrastructure like microscope, C-arm, etc. Do not operate complicated cases in your initial part of the career. The patient has every right to choose his own choice of surgeon hospital, because I got my NAP hospital is NAPH recognized, and do lot of documentation. This worrying a my concept, my patient is always not true. Because instrumentation got different views when compared to others, maybe because of the old timer. Go to instrumentation unindicated cases with the fear or the precaution or the suspicion that the patient may develop disease in future. You are having a definite disease on the table, yes, please do it. Recent diseases in per se, in my experience, is common with age, and and most of them don't need treatment unless they are symptomatic. And unnecessary instrumentation makes the back stiff and patient's life is miserable. The lifestyle much comfortable is standard conventional laminectomy. These are different spinal disc prolapse which you regular day and day to operate. The latest procedures, the transforaminal endoscopy, even though I have attended few workshops, I'm not confident to do that, I'm not doing that. And few more guidelines for the youngsters. Do the procedure and the patient needs and what you're capable of doing confidently, both will matter. Never try new methods on the patients after attending 1 or 2 workshops or doing 5 to 10 cases. A bad post-op case with a discitis, paraparesis, with inadequate disc excision, one case is enough to make you mad for few years. Never comment badly on your professional colleagues, previously treated, known or unknown to you, because even if you find a grave lapse or a wrong level operation done by the senior persons whom you know or don't know, don't handle such cases, politely refuse with gentle documentation. No personal egos, always refer this type of cases nearest to GGH. Then a question of redo laminectomies. I do have got a lot of experience, maybe 5 to 10% of my cases of the series. Always better avoid in a learning curve and refer to institutes. When your own previous operated case with, say, a foraminotomy or a discectomy or a small mini procedure comes back to you, always think twice why the things went wrong. Go for a conventional laminectomy or refer to a senior colleague. If you still wish to operate, always make a bigger incision, start from normal level, come back to and get back to anatomy. Then pre-op assessment tips. Make sure a pre-op checklist is completely checked. Have a good dialogue with the anesthesiologist, what's happening. Always check you're operating right patient, right level CM and right MRA. This won't happen in a setup like mine. It will happen in a volume loaded hospitals like tertiary care hospitals. If something happens, the surgeon is alone responsible for the punishments. At the most, you can scold your assistants, but you have to face the legal issues. A bit of a discipline in the OR. I personally switch off all the mobiles. And in complete cases, we don't get panic. When you're operating, put 100% effort on your patient because he came to full belief with you and believe that he has a family behind you. Whenever a complication occurs, proceed if you can manage or wait for the senior colleague. These are the main complications. Second part of the topic. 2 minutes. The severe hemorrhage. Be cool. When a hemorrhage happens, always check the causes of release, like adjust the pillows under the neck and abdomen and control accordingly. Extraordinary level, don't be panic. Put a bit of patties and bipolar. And don't keep on coagulating in blind field. When you restart, only restart when the bleeding is controlled. Otherwise, take the help of other colleagues. The cardiac roots damage is more disastrous. And if once happens, the senior colleague, if you refer a person, can do nothing in that case. Discectomy issues. Even if the single disc removal in one piece is tempting, do it slowly because it causes some oozing. And excise the disc with gentle nerve retraction. I always use 11 blade and get into disc space and go around it in 360 degrees. Nerve injury always I retract with parallel to the plane, gentle, intermittent myself. Regard a bit of epidural tears. 1 minute more, please. If you find dural tears, don't be panic. Close it with some surgical patty. Get back to anatomy. You're bleeding. Kindly hold on. Go to the normal side. Retract the nerves gently and remove the disc. And don't suture the anterior lateral sutures because they may constrict the nerve root. And first my leap is 20 years in government hospitals, OGH and SMC, and secondly in my own private practice. And my selection criteria, yes, a little one line. I don't do any skin interpretation, directly use the 22 knife and cut it. I don't use monopolar, always cut it knife and compress with bandage for 10 minutes with saline and proceed. I don't use drains. I retract the nerve roots myself. I only use bipolar. These are the few cases. They're all extruded discs, sequestered disc, and this one buried in the fenestration. These are the one of the cases where you can see the hostation, the constriction at the 3 levels. I check both proximal, distal, all round, median nerve roots, and the facets are shown in the blue arrows. This is the type of discs. To conclude, kindly excuse, I still call there myths about the conventional gold standard laminectomy. Age-old laminectomy still is gold standard past, present, and future. The target is totally one procedure. Please do it because it always gives results. By exchanging spines and lamina and not touching the facets will never cause lysis. If it causes maybe few percentage, you can always correct it. But as long as limit to lamina, it's just opening a window into the spinal canal. So it does not do any damage to the facets or post. It does not resist. I personally feel lot of unnecessary instruments being done in the present generation. If you don't scrape end plates, it will never cause or at least minimize discitis. Thanks for the patience.
Thank you, Rangarao sir. It's very excellent, and you brought down the complete, complete spectrum of what we should do and what we should not do.
It's a bit of a tips only, not with experience, nothing, no statistics.
That's the kind of lectures we want from you. Thank you very much, sir. Thank you. Thank you. We want to move to the next talk by Professor Dr. Batoi on instrumented decompression of degenerated lumbar canal stenosis in the elderly.
Thank you, Chairperson, sir. And many thanks to Dr. Panigrahi and his team for this wonderful opportunity to be here in Hyderabad once again. And there are no financial disclosures or conflict of interest to be disclosed. And we have permissions from all the patients to display their identity, as shown in some of the videos. So this is just a difference. This is just a picture to show the difference between a neonatal and an elderly lumbar spine, what happens as the age progresses. And back pain in the elderly, they may be, and in the elderly, they may be having comorbidities like osteoarthrosis, cardiovascular problems, peripheral vascular problems, pulmonary, diabetes, hypertension, depression, again, very often overlooked problem, that is depression, osteoporosis, renal failure, hepatic compromise. There may be previous lumbar spine surgery, again, very important segment of this particular paper, and coexistent cervical spondylotic myelopathy and diabetic neuropathy. So when such a person comes to you, and such an elderly, and who will have back pain and leg pain, and how do you evaluate such person? And what he or she wants is to get better in life so that he can get on with his in his life. And clinical evaluation, mind you, this is one situation where clinical evaluation plays the most important role in decision making. And you may come across with a picture like this, or bilaterally wasted calf muscles and foot drop. So back pain in the elderly is very ubiquitous symptom. There may be radiological or degenerative changes LCS in the elderly. It is multifactorial in origin, like some of my previous speakers have already said, that discal degeneration, asymmetric load transmission. This is a very important aspect. Coronal and sagittal plane deformity takes place, facetal hypertrophy takes place. With the result, there is ligamentous hypertrophy and enthesopathy, nerve root and dural compression. There may be altered lumbar spine kinematics and pain genesis, and this affects in your central pain modulation as well. So there may be cortical origin of painful symptoms.
So this is a small series of 72 patients. Most of the patients were females, and my cutoff age was 65 years and beyond. So most of my patients were from 65 to 70 years, and the most of the common symptoms were back pain, radiculopathy, and claudication, and restricted ambulation. So most of them came with restricted ambulation, and some of them had wasted legs, foot drop, and scoliosis. So this is the age distribution. Most of the patients had were between 65 to 70, and there were patients who were beyond 90 also who underwent surgery. This was the presentation. Most of the patients, back pain, this is just a repetition, radiculopathy, claudication, and restricted ambulation. The preoperative surgical planning involves a thorough sifting of the symptoms. What are his symptoms? What are his or her symptoms? And what we aim to achieve and what we aim to offer to the patient. So it is, as I said, it is the clinical decision making which is the most important facet of management in such patients. So we have to assess the comorbidities and an assessment of neurological status and symptomatology. What are the symptoms due to? And you sift out these neurological symptoms from non-neurological symptoms, and then put a label on them whether they are of spinal origin or not of spinal origin. So then imaging is universal. I don't have to elaborate on them. The dynamic radiographs, MRI, NCCT, and 3D CT play a very important role once the surgery has been decided upon. And of course, pedicular morphometry. Then oswestry, low back pain disability, ODI has been applied to these patients and record maintained. And these are some of the images which what I'm going to show, that these are the types of the patients which we managed, and with stenosis, with scoliosis, and with listhesis. So these are some of the patients who have been managed, who had coexisting morbidities, and many of them had scoliosis, which was generally centered on L3. So these are some of the preoperative and postoperative pictures in which there is correction of the deformity and correction of the stenosis, and the post-op ambulation. As you can see, the elderly lady is walking quite comfortably with the help of a walking stick, which she had come in a wheelchair. Similarly, here, preoperative planning, you have to consider the, as far as the spine is concerned, you have to consider the osteoporotic spine, whether it requires some amount of, say, additional bone cement or vertebroplasty or any other PMMA utilization. Patient may have an ankylosed hip or knee. There may be previous TKR or THR, poor nutritional status, and psychiatric illness. Again, I'll emphasize that one should not overlook these aspects of psychiatric illness. This is the preoperative planning, what we do. That is in the conventional pedicle morphometry by doing the CT scan, a 3D CT scan, and we measure the pedicles dimensions and our intended trajectory. And this is what we do preoperatively. And thereafter, and this is on the right side, what you see is a patient who's been operated upon probably by an MISS technique, and not a very satisfactory surgery done, but nevertheless, patient was continuously symptomatic, and we decided to revise this surgery. So positioning, again, it has already been emphasized by a previous speaker. You have to do the positioning yourself. Care of skin, pressure points have to be very. You have to be careful about them. You have to access the region and all the levels planned. I don't think one can advise MISS in this situation. Obesity or poor nutritional status, and whether there's a scar of previous surgery. Adequate exposure, you have to expose the laminae, and as far as possible, try not to overexpose the facets. Decompression, the core of surgery, that is the core of surgery. The patient is come to you for decompression, and thereafter, whatever you do is to keep the decompression intact. Stabilization, we aim to include D12 if L1 is to be included. PMMA augmented fixation may be used, and minimize or replace blood loss. What we are now doing, that if it is a long segment, we expose in short segments. Control the bleeding from that segment. You can even put screws and then go on to the next segment, then go from the skin downwards. And with that, unless of exposing the entire operative field in one go, and that can lead to much higher blood loss. But if we expose in shorter segments, I think it leads to lesser blood loss. We have documented it. So these are some of the post-op pictures in which the scoliosis has been correction. You can see some of the screw tips are facing more medially. That is because of the rotational element of the vertebra. And on the other side, you can see the point of insertion of the screws exactly in the pedicles. And this is the pre-op and post-op pictures, and the correction of not only the scoliosis but of the lordosis as well as any other deformity. So post-operative care is ICU for 24 hours. Respiratory and cardiac monitoring and DVT prophylaxis is universal. Care of pressure points. Early ambulation. We intended for early ambulation, usually within 48 to 72 hours, and wearing a lumbar support and adequate post-op analgesia. We take help from our anesthesia colleagues, and they ensure that the patient remains comfortable in the post-op period. And post-operative imaging is a must in all the patients, and these are the imaging showing the position of the screws as well as the correction of the deformity. Implant revision. Many of the patients might come to us for after the previous surgery, implant failure. And we had 7 such patients. One had implant failure, two were operated elsewhere. One osteoporotic spine, adjacent level stenosis and listhesis, persistent disability. So this was what was done. This was a pre-operative and post-operative. We had to add domino device and extend the fixation. A broken implant, possibly inadequate, probably a poor selection of the hardware, and then that is a post-op. And this is again the worsening of the scoliotic deformity post-op, and then we had to extend the level of fixation. There was a 72-year-old female with LCS and scoliosis, first surgery followed by worsening of back pain. And then this was the pre-op imaging, and then decision was to do surgery. This is post-revision in which the scoliosis has been corrected, and she was quite comfortable thereafter. And I'll just show you the picture post-op. And these were all taken after 6 months of surgery. These videos. Was another 70-year-old patient, wheelchair bone, and subsequently this was the post-op result, and this was what he was walking. So, and all these patients, they had improvement in the clinical status, they had improvement in the psychological status, and they felt that their life is certainly become better. And as was brought out by the ODI, I'll just show you the slide. Just give me a minute. And this was one patient who had a cervical problem as well because of the huge osseous mass in front of the spine. I'll just take a minute more. So, and there was instability at C3, C4, and which had to be operated. And this is the ODI pre-op and post-op score. And all the bedridden patients had improved. The crippled patient had improved to the next grade, and so on. And majority of the patient had come to minimal disability grade. So this was the post-op. That is the majority of the patient had moved to the mild and moderate grade. So it is a teamwork of physician, cardiologist, endocrinologist, orthopedician, pulmonologist, neurologist, nephrologist, and it has to be a holistic view of the patient, including his psychological status, analysis of symptomatology, the right patient, right assessment of symptoms, and which symptom do we aim to relieve, the right surgery, it is decompression and vertebral augmentation, the right implant, select the levels of fusion and deformity correction, adequate post-op analgesia, and thereafter you will be rewarded with a patient who certainly feels better and is happy once he goes home. And most of the patients, they come and say that they have better control of their comorbidities. And this was my last patient, who's about 68-year-old, and she was quite happy after the surgery. Thank you very much, ladies and gentlemen.
Thank you, sir. Thank you for nice presentation. We'll move on to the next paper. I invite Dr. Amit Thapa from Kathmandu to talk on degenerative spine diseases.
Thank you, Chairpersons. Good afternoon, everyone. A warm greetings from Nepali Society of Neurosurgeons. Well, I'm bringing a topic which I have realized is unique for this whole conference because this is the only one topic on pain injections and how to use it in the pre-operative phase. Well, I have nothing important to disclose except for the fact that the consent has been taken and few companies which I may be taking it just for the academic reason. And I truly accept that all my previous speakers have done commendable work and most of them are supplementary to my topic even. So we know that the low back pain is now a growing menace with almost a lifetime prevalence of 54 to 80%. And being a second most common reason for anybody to visit an OPD, this is fairly getting its share size of financial impact also. And in Nepal also, over the period of 30 years, it has been the #1 cause of the year's life wasted due to disability, and it is growing in proportion. So the data in 1990 was 6.2 proportion. It has gone up to 7.4 proportion in 2019, despite of all the advancements. And the most important thing is it is affecting the middle-aged adults. And that's the reason why this particular pain procedures has come up into vogue in the market. And a lot of pain physicians are doing this procedure. They are trying to elevate the pain. The main key point which I want to focus here is how to use this procedure for diagnosis the pain thing, because we as a surgeons are much more involved in surgical care, be it a UB decompression or UB fusion. So we do a lot of good things in the patient's care, and this has also picked up in Nepal in a very big manner. But what we are missing is identifying the pain generator. This is a visual match between Mike Tyson and Franco both, and look at that one shot. And that one shot has actually made the opponent fell down to the ground. And this is what the surgeons are looking at, the pain generator. Where is it? And if you read this article by Dr. Ed Benzel, and he had rightly used this word, pseudo concordance. Sometimes we do a clinical examination and do an MRI, and we are so confident, okay, we had picked up the spot. And somehow it is just like trying to find the part of the elephant in a dark room. And that's how the pseudo concordance can actually mislead you. And that's why this concept of pain generation, as we should all understand, is a pathoanatomic concept, and these are not always visible to one on just clinical or even on radiological evaluation. And we know this, that the non-innervated structures, the ligamentum flavum, internal annulus, or nucleus pulposus, by their virtue of its anatomical non-innervation, they should not give any pain. But as the degeneration process occurs, because of this injury, spasm, and all this healing cycle which occurs, these non-innervated structures start becoming a pain generator. And that's why these pain generators have to be identified by meticulous uses of this pain injection, so that we can hit upon what type of procedure would be better. Say, for example, if a patient is having a facet joint pathology together with a disc problem, then we should always go for a facet joint intervention rather than just giving a nerve root decompression surgery to these patients. And similarly, fixation would be far better in these patients who are unstable at the same point. Now, this is a paper which was published in 1998. I would just like to draw your attention to the low back pain analysis of 104 patients. The researchers then had found that almost 39% patients did not have any diagnosis of the pain generator, despite of using a good clinical exam, MRI and CT scan in these patients, and even neurophysiological examinations was done. And in these patients, when they tried a pain injections, they found that almost 24% patients had a facet joint pathology over top of the 20 or the 24 patients who had a combined pathology at the same time. So these studies do show that, of course, we may be misled by our clinical exams as well as of our radiological examination for confirmation. So pain mapping actually helps us not only to identify the pain source, but also can help us to guide what all the surgical planning one can help. And depending upon your intervention, you can predict what outcome the patient is going to get. And of course, it improves your patient selection, reduces the surgical risk, including the failed back spine surgery syndromes. Now, we all know, we all do this. We do good history taking, we do physical exam and imaging. We use this maps to identify the pain. And in this case, the patient's pointing test is very, very localizing thing. Then pain spine examinations, we do provocative exams to find out whether the SIJ joint is also involved in these types of pain problems. And of course, we complement with the imaging. And there are a lot of spine injections these days which can be used for various pathologies. But I'm not going into detail because that's not my perspective of the talk. What I'm going to talk to you about is how we use this pain mapping for our patients. So we use basically a very standardized diagnostic block evaluation sheet. And the principle is to have a patient for this testing only if the patient's visual analog scale is more than 5 out of 10. Anything below this, patient will not be able to tell you whether he got a benefit out of your intervention or not. And we always start with a selective nerve block, and not more than 2 levels at one given point of time should be checked. And we always inject the most probable source of pain. And once the procedure is over, we like to check the patients on the table itself, whether the patient has the problem on flexion, extension, side bending, sitting or standing. And then we keep on evaluating these patients times and again, first and 30 minutes later, 2 hours later. And even once the patient goes back home, he goes with a pain diary and comes back again in the OPD, whether to tell us whether the patient had a 50% relief in the pain or not. If the relief has been more than 70%, this is super convincing that okay, that we have found the pain generator in this patient. So how we do it is a list of these simple tests: selective nerve blocks followed by facet injections if in case it is necessary. If in case we are embarking on a diagnostic medial branch block, so by the virtue of the medial branch, we have to always give infiltration a level above also. And then diagnostic SI block can be tried. Lumbar discogram has actually gone into very much less use these days. I have not been giving lumbar discogram for the very long time. So in the selective nerve block, as we all know, we always use the needle and then always use a contrast to identify a location. And then this is a case of a medial branch block and sacroiliac joint injections. And then the discography. Now, if we come to the effectiveness, of course, the effectiveness depends upon how much, what is the pathology involved in it. If in case this is just a case of a synovial inflammation, patient with a combination of a bupivacaine and a steroid have a very good relief, even to a tune of around 3 to 6 months. However, if the patient problem is because of mechanical or neuropathic nature, then corticosteroids will not give a long-term effect. It will just give you a small effect of a few weeks duration. However, this particular method itself can make your patients able to adapt to the physiotherapeutic maneuvers which you will involve relieve the patient over a long period of time. Now, World Neurosurgery has also come up with one of the recommendations by the spine group of WFNS, and they also have found that the epidural injections have been better. But for the pain mapping, they're using transforaminal, not the interlaminar one, because interlaminar injections actually spreads the drug all over the levels, where the transforaminal you can be much more localized in your infiltration. So just to share our experience, we have done almost 140 patients in this study, which is still in process. We had actually presented our paper in 2003 in one of our meetings in Nason. And in this paper, what we did was we actually subjected these patients for pain mapping, and we could do away with the surgery in almost 70% patients. We are still following these patients whether they come back for the intervention procedure, and we have found that all those remaining 30% whose the intervention had been performed, patients are still doing good. So we are still following both the categories of patients who are doing only without instrumentations or the definitive surgeries, and who have been managed with the interventions only. So we always like to rule out the red flag signs. If the patient has a red flag sign and definitely there's a concordant signs in the imagings, then we go for the surgery directly. Or those patients who have just not have a red flag signs and have a dubiosity or multi-location of the pain, then we always go for the pain procedure, particularly the pain mapping. And we all know about the red flag signs, so I don't have to repeat it. What I also want to highlight here is that yellow flags are also very important, particularly in cases of chronic pain because of the psychosocial impact of this pain over a very long time. And whenever the patient presents to you with a negative attitude towards the back pain, it is always very, very important to expose these patients to psychological intervention, which has been presented in one of the article in JAMA Psychiatry, where they have exposed these instrumented patients for the pain reprocessing therapy. It's basically a set of psychological interventions which is provided to the patients in the preoperative phase, and involves almost 4 or 5 settings over a period of 4 to 5 weeks of psychiatric counseling, where the patients have had been actually been tuned to remove that particular negative attitude to their pain, and this has been shown to have excellent results, almost 3 times more beneficial impact with the surgery after this particular impacts. However, pain injections have to be done only after proper training. So nowadays there are a lot of intervention courses which are going on. So this can be done. This is not as easy as it is shown in one of these websites, where the patient is just asked to point on a body where the patient's pain is, and subsequently you can be given a list of intervention which is to be done. But surprisingly, the websites are full of these types of articles also, where they are claiming that the personalized pain mapping can be provided to the patients. And of course, as a surgeon, we should be aware of this particular modality to actually enhance our procedure. So pain procedure, the both diagnostic and therapeutic, my dear friends, we always want to do a diagnostic tab, particularly from our side, so that we do not mix on the patients, and the pain generator can be identified together with the triad of a good history taking, clinical examination, radiological investigations. And if in case we don't have to do this pain procedure for all the patients, but if in case you have a doubt, it's always better to use these pain mapping techniques to identify your pain generator and then decide on the surgical interventions. And beside the red flag signs, the yellow flag signs should also be considered to have a very good results. And of course, we should remember that the pain management is a multidisciplinary approach. So do not be shying away by not using your other colleagues into the wholesome treatment to the patients. Thank you for your patience listening and open to questions. And I invite all of you for the 11th National Congress in the beautiful city of Itari and Biratnagar. For those of you who are not aware of it, it is near to the city of Ilam. The tea gardens they are beautiful to stay. And it's a month of November 14 to 16, always a pleasant time to come to Nepal that time. Thank you.
They have the questions in the lunchtime, sir.
Thank you, sir.
During the lunchtime. The last paper is by Komal Prasad. Now he will talk about the latest thing, artificial intelligence in decision making. A very important topic.
Good afternoon. Thank the organizers, Dr. Manas, Dr. Savitra, for organizing this feast of academic knowledge in spinal surgery. I have had information overload since yesterday. Now we are seeing an important topic which is about artificial intelligence and how it impacts spinal surgery. So this image is again artificial intelligence generated using the black and white images of Cushing. So this is in the ANS website, an advertisement for their Boston conference next year. So this is how it's percolating into our lives, and we can see how the logarithmic growth of AI-related publications is happening in the field of spinal surgery. So this only up to 2021, and it's much more steeper in the last 2-3 years post-COVID. And we are bombarded with literature of using AI in spinal surgery. So we know, and by now we have a fair idea of the hype cycle. So like how new technology comes and it grows tremendously, and then there will be a fall. And then over a time, it comes to a level, a plateau of productivity, we say. Like we saw that even transoral approaches we saw, it just doesn't come back to the lowest level when it started, but it reaches a mature level where we keep it for a longer time to come. But we are right now in most of this. These small dots what we see will take more than 10 minutes to even read. But these are all subspecialties of AI which are going to bombard on us. Like we know generative AI, we are seeing which is at the almost the peak, and it's going to get plateaued soon. So, but we have to be aware of this cycle when we see any new technology, like what we are seeing, whether it's robotics, AI, generative AI, chat GPT. Because of the speed and the velocity in which it is impacting us, we should be aware of how it impacts our practice. This is Google's new expert level medical LLM called MedPalm 2, which is supposed to pass USMLE examinations with a score of 87%. So that's like the expert level scores of anybody can get. So this software has passed that one. And these are the kind of software which is being available to our patients on their mobiles today, whichever part of the world. And people will come to us, to our OPDs, wherever you practice, with this kind of information in their hands. We should be updated. And this is about the maximum knowledge anywhere anybody in the world can gather is assimilated and brought to the palm tops in the hands of our patients who will come with pain, not just with pain, not just with MRI, but they come with the assimilated knowledge and what the software is suggesting us. We should know. So this is about what is there for medical professionals and patients. It's quite easy. This is about what limited knowledge in our day-to-day practice, like using it for documentation, EMR, preparing discharge summary, insurance, like that. And for the patients to analyze their lab reports, rehabilitation guidance, chat box for mental health chatbot, like that. But these are we're just scraping the surface. Much more is yet to come. So in the next, this is a very short talk. So I will be touching about what we need to know, where we are headed, and then about how simple examples of how we can incorporate our practice. So AI is the computer capability to simulate human knowledge and cognitive processing. Principally three types, three levels: artificial narrow intelligence, artificial general intelligence, and artificial super intelligence. So that green dot, what we are seeing is where we are now. And this is what is progressing in the last 10, 12 years. Right from there, we are reaching towards here. And each one of us have to dread the day when we reach here. We don't know, it looks like scientific fiction, but it's not far away. The rapidity in which we have reached from there to here is so fast. So we can't have a guess when we are going to reach there. So why we need to dread there? Artificial general intelligence builds on unrelated learnings to perform new tasks in different contexts and be able to understand human emotion and relationships. That's artificial general intelligence. We are not yet reached there. It's still far away, but companies and people are in a rush to reach there. So it's like an amalgamation of entire human knowledge in one software. We are not very far away from it. The next one is artificial superintelligence, where computer cognitive abilities exceeds those of its human creators, and it will have self-awareness and its own beliefs and desires. So this is that scientific fiction kind of thing which we have to dread. It was scientific fiction we used to see in movies, but it's not really far away. Maybe 20 years. People say general intelligence will reach by 2030. So that's the time what they say about the general intelligence. So coming back to what is available now, artificial narrow intelligence. These are limited memory AI tools. The whole plethora of things what we are seeing and what we are about to see for next few years still falls under this artificial narrow intelligence, limited memory AI tools, machine learning, natural language processing, large language models, the ChatGPT, the generative AI, virtual assistants, computer vision, self-driving vehicles, robotics, everything falls under this AI, artificial narrow intelligence. And this is about machine learning. This is the start and how we are using machine learning, the way in it is used. It needs data, it's data hungry. Whatever data we have, whatever Excel sheets we can generate, whatever our case records, we feed. And then there are various different models which can be used to analyze this one. Then based on that, it predicts and learns out of the prediction. And then once we say you are right or wrong, then it learns from it and then corrects itself. And it's a cycle. By doing it on hundreds, thousands, and millions of cases, it refines itself and the model becomes very robust. That's the machine learning. So that's about, like they say, ChatGPT is like Telegram of communication. And where we are heading up to is to kind of having video calls. So we are still scratching the surface. Whereas when we have this kind of multimodal generative AI, where we can use multimodal things to give to feed the machine so that the output will be much more better. Like Amit said about the yellow flags, we can even capture the yellow flags. We can even capture the proteomics data, genomics data with a simple blood test, laboratory data, histological data, which the machine reads by itself. It's not read by a pathologist. And imaging data, which again, you are not reporting, the machine itself reads and takes a decision what needs to be done. And all this put together, it learns, and that's where we call deep learning. So machine learning is the keyword. Statistical learning and optimization through algorithms. So what are the categories? So these are 4 categories. These are the basic minimum we need to keep in mind when we go further. So the supervised learning is like having a resident sitting in our OPD. So and teaching him like how we teach undergraduates about flow charts, kind of like we saw many flow charts. So if this is this, that is that, you do this surgery. So it learns through supervision, supervised learning. Unsupervised learning is having another resident who just observes what you are doing and what you decide and recommend to the patient. You won't be telling him why you arrived at but he will make his own analysis of, in such a case he told surgery, in such a case he didn't say surgery, and this is how it happened. So that's unsupervised learning. Semi-supervised learning is in between. You will be prompting the resident like, so this case I want to operate, this case I don't want to operate, this case I want to fix for some subtle reasons which is not clearly apparent to him. That is semi-supervised learning. Reinforced learning is like laying on the patient's feedback. So the flow happens, and then eventually if the patient is happy, you take it as yes. If a patient is not happy, you take it as no. And the machine learns over a period of time, like the decisions what we had taken were appropriate to the eventual result of the outcome of the which is reflected from the patient's side. That's reinforcement. So the advantage here is we are not talking about 20 years, 40 years of experience, but millions and millions of data, rapid processing of large data sets. So that's what is happening. So key machine learning algorithms. So these are the key terms which we need not remember, just to know: linear regression, logistic regression, decision trees, random forests, again a decision tree, neural networks is simulated. Neural networks here is very important for neurosurgeons because it is simulated based on the functioning of human occipital cortex, the lamellations. So this is my patient, Mr. Sanjay, who is a software engineer in a managerial level, who came with a failed back, operated elsewhere, 3-level fixation done. And he was curious to know about his problem, what has happened to him and how the decision could have been made better, or his experience as a patient could have been better. So I operated on him like the previous case where I didn't take out any implants, did a foraminotomy. He got a little better, not fully better, but this kiddo got into him and he wanted to work with me. He joined as an intern, brought his school-going cousin who is also interested in this, and he created a study which was a formal study. We got through ethical clearance and then through our institution, where he joined for this particular reason as an intern, and he used to come regularly. So to develop a comprehensive machine learning model on radiological and clinical data. So this is next few slides I will run through about what we did. So we got the ethical approval, data collection, and then we created a model. So these are the 3 models which were tested: random forest, SVM, and KNN models. So these are the details about the models. We need not go through that in detail. So these were 92 retrospective patients. Data were collected. So you should be kind of, with unbiased observer, collect all the data from L1 to S1. All the, what is the canal diameter, what is the disc protrusion, what's the stenosis extent, what's the condition of the disc. So everything, the data points are collected. Like this are qualitative, quantitative. These are called variables: nominal, ordinal, discrete, and continuous data. Age, smoker or not, tobacco use. So all these were just entered, and then feed it to the computer, and then tell the system what you did in that case. And then it predicts, it creates a model. And then that's the training model. Next is the testing model. Is when you give a new number, new set of variables, it will suggest what is the possible next step taken by the cell. So this is the accuracy of those 3 models. And in this, so based on these 3 types of software used, it was found that random forest and SVM model, the support vector machine model, provided an accuracy of 87.7%, which that much of correspondence with what surgeon would have done. Okay, and then it further improves and improves when you feed, when the surgeon corrects it, that no, your data was wrong, no, you were right. You give a thumbs up. So those things in ChatGPT or in some of the software, you give a thumbs up. So then that learns that, okay, that's the correct way. And then that number increases further. So what is further is using DICOM data, using MRI directly, not reading of the MRI. The DICOM data in itself will be read by the machine. We don't know what all MRI says. We only know what our eyes tell us, what our radiology report tells us, which we don't believe anyway. So we believe only on our eyes. But when the machine reads it using DICOM data, it will gather much more useful information, which will be even useful only when it analyzes. What are the challenges? Challenges is the dependency on data. We need huge amount of data. With electronic medical records, it's becoming possible over time. And bias and variance is underfitting versus overfitting. So we, with our experience, with our learning, we try to underfit. So if it is like this, we make to simplify that algorithm in our minds. So that the same thing applies to the machine also. So we have to strike a balance between underfitting or overfitting or taking thousands and thousands of data because machine is available. Then also we will lose the forest for the trees. And data privacy is another issue when we bring this external agencies like this software engineer who entered our system.
I think
So we have to be, more. So we have to be concerned about the patient's data. And this is very soon to come is that multimodality input where we use histology, imaging, lab data, and blood samples, which will give a much more meaningful, much more newer ways of analysis and coming to a conclusion. So for spinal surgeons, AI has a potential to transform spinal surgery. We need to understand the fundamentals of AI. In our busy practice, it's mandatory because, as I said, people will come with their mobile phones with those softwares. Just the previous speaker, we saw that where is your pain? You touch there, and then it will give a data about, sir, give me an injection to the right medial facet, medial branch, like that. So they will come with that kind of requests now. So we need to understand the fundamentals. We need to collaborate and engage in AI model refinements. We need to explore novel applications in spinal surgery. Otherwise, we'll be dictated by our patients, by the end users, and by the companies and the technological people who would dictate us what to do. Particularly, the insurance people might dictate us. No, our algorithm says this is not a fit case for fixation. So we need to know. So with that, conclude. Thank you.
We thank you all for a very patient hearing. Lunch is being served in two places to my left here and in the Mystique Hall on the way outside. Everybody's welcome to go have lunch and please come back by 2 o'clock. We're starting our afternoon sessions. I would like everybody who has been associated with NIMHANS to stay back so we'll get a quick group photograph before we disperse for lunch.
कहाँ बात करता है
I'll change from here otherwise. I'll keep it here. Huh? There's one glass of.
సార్ మరి కూర్చోరా ఇక్కడ అక్కడ ఆర్గనైజింగ్ సార్ సరే సార్ మీరు స్టార్ట్ చేయండి మళ్ళీ especially for you and you. Sure.
Morning this way. What's diagonal way? Up cars on opposite side. Side is free. Evening when I come, this side is full, that side is. Side is free. Good. Yesterday I'm missing. Hi. Peter maybe syndrome, sir. Or cane. Exactly. The teaching you say the cane is full of teaching. Just pregnant.
But you get come home and then you get it again because you got it there.
Aslan. Here. 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 Question. But I've been in. Why? I am not so. Thank you. Only enjoying vacation for them. No,
Both side, both side.
Problem. You will give advantage of time also. Just joking, whatever. Hey, Shivraju.
A very good afternoon, everyone. Welcome back. We're just heading on to the session 4, that is spinal tumors 1. May I request Dr. Malleshwar Rao, Dr. Jagdish Reddy, Dr. Mastan Reddy, sir, please come on to the stage for chairing the session.
This is also not working. Yeah, yeah, yeah. If the chairpersons are ready, I can start. I'm waiting for your command. Yeah, yeah. But you know,
For the fourth session, I just invite Dr. Suresh Nair garu to talk on pitfalls of intramedullary tumors.
yeah. Thank you, chairperson, dear friends. Hope you all had very good lunch. This is old wine in old bottle. Many of you would have listened to this talk. No disclosures. And these things, some of these things I will address in the coming 10 minutes. This is 12-minute talk, not 10 minutes. Okay, I starts with a clinical vignette. This happens to be a case which was operated unnecessarily. A patient presenting with muscle aches, cramps, urinary incontinence, and patient had a sensory level and increased tone in the lower limbs. And this was the picture which was suggestive of intramedullary lesion. Surprisingly, you see the picture on this side. You know, the subarachnoid space is well seen. And obviously, the diagnosis was not a tumor. It was looking like a demyelination because it was a subacute presentation. And neurologists wanted to rule out the first episode of multiple sclerosis. They did CSF study, oligoclonal bands were negative, back to square one. Now again, nobody knew what it was. So it was decided one should go for a pathological diagnosis. Midnight myelotomy. It was a firm tan tissue, not looking like a tumor. Came as an inflammatory infiltrate, and it turned out to be a demyelinating lesion. So what the lesson we learned is determining whether an abnormality definitely indicates the presence of a tumor is not very easy. And there have been many presentations where people have fumbled whether it is an inflammation or a neoplasm. And so many reports of non-neoplastic intramedullary spinal cord lesions mimicking like tumor and vice versa. Spinal cord astrocytomas mimicking like myelitis. It is extremely difficult sometimes from a imaging, and symptoms can be non-specific. These things all of us know. What are the manifestations, and some clue to MR localization can come from these cross-sectional images. MR, whatever is marked in white is all demyelinating, but you can see sectorial involvement can occur in astrocytoma. But most of these things are all medical problems. But you can see long segment lesions or a swelling in the cord could be suggestive of a tumor also. And what are the differential diagnoses one should consider other than tumor? These things which are all written there, which all of you know well. But what are the cardinal signs on MR imaging? Cord expansion always tells it could be a tumor. Enhancement. All tumors, most of the tumors will show at least a uniform and patchy enhancement. And that pattern of enhancement, you know, it is uniform usually for ependymoma, patchy for astro, and you get enhancing nodules in hemangio and even in pilocytic astrocytoma. Location also, you know, central ependymoma, eccentric, and then associated cysts are always, most of the things are common. Intratumoral cysts are more common for astro, while polar cysts are more common for ependymoma. But these are something which is written, the significant cord enlargement is rare with non-neoplastic lesion. And ring enhancement is not often seen in intramedullary tumors unless it is infarction or a radiation myelopathy. I don't have to teach all of you about the characteristics of ependymoma, astrocytoma, and its various ways to localize that, and also about hemangioblastoma. But what I do is I never treat an image if patient is asymptomatic, and never you take a biopsy. Radiation, we send a patient for radiation without biopsy. Can be extremely difficult. One is a astro, one is a ependymoma. So never predict histology from MR imaging. And here, you know, this to the right is a astro. You can see small small vertebra, you can see the other is ependymoma. So always on the day you prepare for intramedullary tumor, you plan for a long surgery thinking that I can take it out. So histological prediction on MRI is often incorrect. These are some of the steps all of us know. This also I've taken from net only, beautiful steps. And I will tell, and also so many guidelines have come for monitoring. All of you should know that poor monitoring is worse than no monitoring. So now you have SCP, MEP, you have various alarm criteria, guidelines. At least we all go by muscle evoked potential and D wave. As even if MEP disappears, as long as D wave is above 50%, you know that patient is having a temporary deficit, they will improve. I always used to do my approach through posterior midline. Ependymoma always midline. Astrocytoma, unless it is to the root entry area, midline prediction is difficult. The cord may be distorted, but you can approximate from root entry zone. You can open the spinal cord like a book. Again, from a net, beautiful picture. If you are in the correct midline. And this is again pictorial depiction. You open it like a book, put file traction sutures, take a biopsy. Go depth and take a biopsy. Otherwise, you take from peritumoral tissue, it will mimic a pathologist will tell it is gliosis, glioma, you stop. Sometimes it may be ependymoma. So this is how you decode. And then the tumor cord interface you develop and lastly tackle the vessels coming from front. Astrocytoma, many a time you get into a good plane, you can resect it. This is just to show some example of a lady. This is a nurse who came to me. You can see it like a whole upper cervical cord is full of tumor. Oh, I'm sorry. Let me see. Yeah. I hope this video plays. This is just to make it. I'll run it very fast. This lady, it's a large tumor. You can see I have removed tumor from the cervical cord totally. It was a good dissection plane. Now I am cutting through the medulla. And this is, ultimately, there was a very good dissection plate. I could take out the tumor totally. In spite of this being you can see this is the cervical cord totally devoid of tumor. I took the tumor out from the middle as well. And this is the patient next day or the very next day in the ward. If you don't damage the patient much, the girth of the cord was very small, but you take it out, decode it without. This is again happened to be a staff nurse from Delhi was referred to me. You can see this is the pond, this is the medulla, this is the upper cervical area. The whole girth of medulla is full of this tumor, very reluctant to operate. But my juniors tell sir, you do, they have come to you, please take it. So again, God was with me this time also. So ependymoma is easy. You get into the dissection plane quite easily. Okay, and I could take the tumor out without much problem post-op CT. And this is the patient after surgery. This patient had a tracheostomy. So this is again a large ependymoma. This is just to show that, because of this, after surgery, if you do a laminectomy, a cord can tether to the dura and create problems later. So we do a laminoplasty, again skip laminectomy. Again, you get into the dissection plane and I don't have to, steps are same. You can get into the dissection plane sharp and then ultimately you got close the arachnoid. I'll skip the next video for want of time. So this the patient after surgery. This video I'll skip. This is one girl with engineering student came to me. You can see the girth of the tumor is this small black one, refuse surgery. He came back with respiratory paralysis. I took it. I took the tumor out. Patient was on ventilator for 3 months, home ventilation. And this patient came to my room 3 months after surgery. They say, I love doing acoustic surgery, but this girl, when she came back walking, it was one of the most happiest days of my life. Hemangioblastoma, another tumor. My friend Matthew Abraham removed the colleague that time, removed the posterior fossa thing. I was given the charge of removing this one. And the hemangioblastoma, tricky tumor, embolized by our radiologist very well. And so it is just circumferential. You cannot decompress. It's again sharp dissection. I will run. So you get into the dissection plate. Hemangioblastoma, always there is a polar cyst. So you can get into that dissection interface very quickly. And this tumor was removed like any other case. And this is the patient after surgery. Frail patient, flaccid upper limbs, but patient made it. Just to, so I told you IONM is an excellent adjunct for technically good surgeon, and it is not a substitute for poor surgical technique. And what you should see is look for demyelinating disease, like what mistake we had. These are the things you should look for. Multiple sclerosis, neuromyelitis optica, acute disseminated encephalomyelitis, idiopathic transverse myelitis. So when history is not clear, if it is subacute in onset, you are not sure about the diagnosis, wait for things to evolve. In the meantime, get a brain scan. So many a time brain scans will show some other features of inflammation like you see in multiple sclerosis like this. You see a lesion, but this Dawson's finger, neuromyelitis optica, chiasm area lesion extending up to the fourth ventricle. For this fundus, you see pallor. They have other symptoms as well. Looks like a neuromyelitis optica, looks like a tumor, and extend up to the brainstem and other periventricular area. I'll skip all. This fundus examination helps many a time. ADM is acute disseminated encephalomyelitis. These patients, they have a viral illness or a vaccination, and they come with cord lesion, paraplegia, or this type of lesion. And this I just want to tell you, these are some of the things you should look for. When in doubt, wait. Get always a brain MRI. Your neurologist, if they will tell you, look, it doesn't look like a tumor, but still we want a biopsy from you. Please help them also, because if you take a proper biopsy, they can at least start treatment for sarcoid, fungal, or tuberculosis. I think I will end here. It is quality of life depends upon accurate diagnosis and meticulous surgery. Thank you very much. I can answer some questions.
Thank you, Dr. Suresh Nair garu. Then I invite the
Okay.
next speaker,
Thank you.
Dr. Vijay Sarathi. He will speak on an unusual case cause of cervical radiculopathy.
Respected chairpersons, Professor Mastan and Dr. Jagadish. Very nice to see Jagadish. He is my student now. He's a chairperson of my talk. I'm very happy, Jagadish. And this after completing 23 years of institutional service, I joined private practice. In fact, when the abstract was open, I was little looking here and there what case to be sent. I operated just then a very unusual case of cervical radiculopathy. I thought I sent it for the presentation. I thought they'll accept for the poster. So they made it a platform. So I have to struggle a little hard to make it a little more. So this patient, she came to me after almost 6 years. When I was in exams in the OPD, I was sitting. This lady had come. She came for a back pain. She had a long segment MRI. Got a small lesion there. I told her that, look, this lesion is there. Sir, why don't you operate? I said, once lesion grows and you develop a arm pain, you come to me, I'll operate. Then after years, decades passed, and she developed the radicular pain. And by the time she went back to NIMS, I left, and she Googled and she found me in the hospital and she came. So her presentation is left upper limb pain of 6 month duration and aggravated by extension of the neck and relieved by rest. So what are the possibilities? Any resident want to take our? Yes, sir, Yashoda. Right? So you have 3 possibilities. One is intramedullary, IDEM, and extradural. Which one is possibility here? Yes? So obviously it's extradural because its pain is getting aggravated by movement. So what are the investigations we do? We do X-rays, MRI, and CT scan. We got an X-ray, and of course I opted for MRI. So MRI shows a lesion here. Right here is a lesion here. There is some lesion. Is a disc? I don't think it's a disc because discs are intact here. So there is some lesion which is pressing on the C6 nerve root. Can anybody guess what it is? Right, sir. Right, sir. Right, sir.
chondra.
Right.
It is enhancing this cellular reef.
Right. So the possibilities are, I thought of a tumor arising from the bone, as most of the benign lesions in the cervical spine arise from the posterior elements. Contrary to all malignant lesions, they come from the front of the spine. So is it osteoid osteoma? No, because most of the osteoid osteomas are very small lesions. They present with a painful scoliosis, not with the radicular pain. Second one, osteoblastoma. Yes, it is possible. It's a big brother of osteoid osteoma because it's more than 2 centimeters of osteoid osteoma is osteoblastoma. Osteochondroma, possible. ABC, yes. ABC typically it destroys the entire posterior element. Suppose if you have X-ray with absent spines process, you think of ABC. Hemangioma, definitely not, because hemangiomas usually occur in the anterior portion of the spine. Now the answer lies in the CT scan. Look at the CT scan. You have a lesion here. Can you guess? Typical osteochondroma. There's an osteochondroma which I excised and I did laminotomy, lateral laminotomy, little foraminotomy, and entire lesion could be excised. Of course, this is typical case which happens once. The usual incidence is around 1% of all intraspinal tumors. And if you look at the this one, the most of the lesions like osteoid osteoma, osteoblastoma, osteochondroma, ABC, they occur in the posterior elements. And there are certain lesions which are malignant, which do occur in the posterior element. There's a chondrosarcoma, Ewing sarcoma, and osteosarcoma. You can remember it by a mnemonic called CEO, right? Then the most of the lesions, malignant lesions, occur in the anterior to the spine. There, metastasis, myeloma, plasmacytoma, lymphoma, and carcinoma. What are the benign lesions which occur in the anterior portion of the spine? Yes, sir. Residents. Hemangioma and eosinophilic granuloma. Typically, they present with the, which deformity is that? Vertebra plana deformity and GCT, right? So this is what about my case. I would like to enumerate some of the indications of surgery. Which patients generally discs? For example, most common pathology we operate laminoforaminectomy is the discs, right? So what are the discs? Which ideal disc where you do laminoforaminectomy? That is, you remember the 1, 2, 3, 4, 5, 6 S. One is a single disc, sided disc, that is a far lateral disc, and segregated disc, that's extruded one. You don't want to go in and poke knife into the disc from the back, and it's always should be a symptomatic disc. It should better, it's a soft disc, and patient should be a slender neck. Understand? So that you can have a little less dissection while doing exposing the laminoforaminectomy. What are the contraindications? One, calcified disc. Second one is the patient is obese, when there are cord changes, and when there is a poor quality CM is there. And if the disc is confined to the disc space, don't attempt the posterior surgery because you have to retract the roots cord to reach the disc. And of course, canal stenosis is a prohibited. Once canal stenosis is there, you can't go from the back. Advantage of laminoforaminectomy is you don't require any fusion. You preserve the motion. There is no adjacent segment disease, and you have only offending portion. That extruded portion is removed, and there is no question of putting any graft over there as long as you are strictly limited yourself to laminoforaminectomy. Of course, disadvantage, most common problem you encounter in the while doing the posterior laminoforaminectomy is the excessive venous ooze. So if you want to avoid that, you have to have a good bipolar. Otherwise, you can operate the patient in the sitting posture, right? Then these are two cases. This first case, you operate by posterior anterior. Manoj? Anterior, obviously, right? So what about this case? These are the same disc. You operate from back. You know what is the simple trick you have to? So you just draw a line which is perpendicular to the cord, and if entire disc lies lateral to that one, that's the ideal case to go for laminoforaminectomy, right? So first laminoforaminectomy was introduced or promulgated by Scobili way back in 1950. Was antagonist to Cloward. Cloward, once he started doing antecervical surgeries, Scoville said no, anti-cervical surgeries are not good. They lead to adjacent segment disease. In fact, even before Hillebrand in 1992, this gentleman has predicted that probably anterior surgery is going to give rise to adjacent segment disease. So this is one case which I operated where anterior surgery was done elsewhere. Of course, I have myself had done see 4-5 days, and patient came with a a radicular pain later after 6 months. When you find this, you can find the arrows shows that there is a risk there. Sorry, I'm ending now. So this is an ideal case. Suppose if you draw a line or you put a plaster on the side of the cord and look at the disc fragment, if entirely on the either side of the plaster, you go for laminoforaminotomy. Thank you very much.
Thank you, Dr. Vijay Sarathi. Now I would like to invite Dr. Amit Roy. He will talk on biology of spine tumors. How are they different from brain?
Thank you, Chairpersons. Good afternoon, all. And thank you for the opportunity to present something that we don't really think about that much. So I start my talk with a very rhetorical question, and I don't expect anybody to give an answer. So have we actually thought why certain things happen? Why do tumors of the anterior pons in children turn malignant, while those of the brainstem or the posterior pons usually are benign? Why are glioblastomas so common in the brain but not so common in the spine? Why are certain tumors actually located in certain specific locations, like the myxopapillary ependymoma confined to the conus, or is it? No. And obviously, meningiomas is something that is getting a lot of attention now in the literature, and they are overwhelmingly benign in the spine, but not so in the brain. So, brain, I'll talk about it, but there seems to be a dichotomy as to where the tumor grows, and even if it is classified as being the same tumor, there seems to be a difference in their behavior. So, what is the central tenet of this talk? The central tenet of this talk is, does location influence the biology of tumors within the central nervous system? So if the same tumor is growing in the brain and if the same tumor grows in the spine, is the biology different? And I will start with tumors within the brain. And I'll start with one of the most common tumors within the brain, which is the glioblastoma. And what I say in my slides, nothing is new, everything is known. It is just that I shed another light to. So let us talk about glioblastomas in children, or high-grade gliomas in children. And we have two separate, distinct sets. One that happens in the midline, which is identified and defined by this mutation H3K27M. It is located in the anterior pons. It has a characteristic ground glass appearance on MRI. TFR mutations are not really seen, and it presents with a characteristic triad. It also happens in children, which means there is a switch that gets turned off after a certain age, which actually prevents these tumors from happening in adults. And then we go to, again, high-grade gliomas or glioblastomas in children that occur in the hemisphere. Yes, H3G34 is one of them. These are usually MGMT methylated, which means they have a better outcome. Also deal with infantile hemispheric gliomas, and these are marked with multiple fusions, NTRK, ROS, ALK, MET, etc. And these are often druggable and targetable, and that is why there's a lot of interest in this field. And obviously, other bit, which is the H3 wild type, IDH wild type tumor, they are supposed to be closest to their adult counterparts, but if we look at their biology, they are not. They are completely. MYC and PDGFR are two of the most common alterations that you see in tumors, and EGFR is a minority, which is different from what you see in adults. And now, if you look at the H3K27M midline tumors in the central axis of the CNS, and we look at the brain and the spine, there is a difference. I already talked about the H3K27M in the brain. But in the spine, when you get an H3K27M mutation, it is seen in adult spinal intramedullary spinal tumors. The median age is 35. They are not differentiated by the things that differentiate H3K27M, and it is not the driver mutation. There are several other chromosomal losses, ATRX mutations, retinoblastoma mutations, that play an integral part in forming these tumors. They are not as aggressive as their cranial counterparts. And if you do not get a TP53 mutations, you don't basically get a tumor. But if you look at the H3K27M cranial mutations, they say that these are independent of TP53 mutations. So what we find is that even our most common tumors, there is a huge difference in what we find in the spine and what we find in the brain. Now, the poster boy for the difference is actually ependymomas. Now, WHO has told us that depending on where the ependymoma is, the biology changes. The supratentorial ependymomas have the ZFTA fusions. Previously it was called the RELA fusion. It is now changed to the ZFTA fusions, which have a poor prognosis. GAP1 fusions have a better prognosis. Similarly, infratentorially, the PFA and the PFB, each one is associated with a different molecular signature. And similarly, spinal ependymomas seem to be in two groups, one that gets an NF2 mutation, fairly benign, and one that gets a MYC amplification, and these are very aggressive tumors. We were also taught that myxopapillary ependymomas only happen in the conus. But if you read the latest literature and you look at methylation studies, they seem to suggest that this tumor happens everywhere in the cord and is not only confined to the conus. The myxopapillary ependymoma subtype, as defined by a methylation class, can actually be seen in the lumbar, thoracic, or even the cervical spine. This is new. So this is not something that we think about every day. And obviously, the most common is meningiomas. And meningiomas is getting a lot of an interest of late. You will find that there was a paper in Nature that was out last month. And they seem to, and the molecular biology for meningiomas is more complex than meningiomas themselves. They seem to divide them into 3 or 4 methylation groups, depending on what paper you read. There is the NF2 intact, the NF2 mutated, but all other mutation negative. And obviously, there is a very aggressive hypermetabolic operative group. It is associated with a number of chromosomal losses. 1p loss with NF2 mutation makes it grade 2. Similarly, TERT mutation, again, TERT mutation, as we see in the gliomas, even in meningiomas, if you get a TERT promoter mutation, it makes it grade 3, as with the CDKN2A and 2B loss. So these things we see are translating directly from what we know in gliomas into meningiomas. Okay. H3K27M, our friend, okay, if methylation is lost, that is actually a suppressor gene. So when you get an H3K27M mutation, it means the suppressor gene is no longer working. And similarly, there are multiple ways that the genes can be suppressed. If you get something that is not mutated, but something downstream, then it is actually associated with a higher grade. But if we compare all of this to meningiomas in the spine, we find we know practically nothing. Okay, they seem to be overwhelmingly benign. Okay, they are NF2 wild type and NF2 mutant, but it seems to be that the NF2 mutant category is more than 55 to 60%, which is again in contrast to the cranial things. Grade 2 and grade 3 meningiomas are extremely rare. And that actually comes out even in the latest C impact guidelines that say that, it is very, very rare to find something that is grade 2 or grade 3 in the spinal cord. The same gene mutations seem to have different effects in the spine and in the brain. But we actually know very little about the biology of spinal meningiomas. So in conclusion, all the evidence to date points that, the spine and the brain have very different tumor biologies, though they actually might look the same. The current research points at multiple factors that may play a role in tumorigenesis, and in that, neuronal activity is the factor that at least affects intracranial, intraaxial tumors. Organs in continuity do not necessarily form the same kind of tumors, and that is being seen in the upper GI and the lower GI tumors, or in the upper urinary tract and the lower urinary tract. So we do not see why it should actually play out in the cranial or the spinal systems. The incidence of spinal tumors is very low, and we now require studies that particularly target spinal tumors as a separate subgroup of tumors. Thank you.
Thank you, Dr. Ray. Now I invite Dr. Lakshmi Nath Sivaraj. He will talk on microsurgical excision of spinal cord tumors.
Good afternoon, everyone. Thanks, organizing committee chairman Dr. Manasa, Dr. Savita, for giving this opportunity. And respected chairpersons, senior colleagues, senior doctors, and my dear colleagues, presenting my last 5 years series of my when I started my own practice here in Hyderabad. After coming from CMC Vellore and Satsai Bangalore, this is my experience I'm just sharing with you. So there are the tumors, various tumors we come across. Extradural metastatic, extradural schwannomas. They are the tumors what I came across and I operated on. Intradural meningioma, myxopapillary ependymoma, metastatic tumors, even intradural, and intramedullary neurocystic sarcosis, cavernoma, conus teratoma, and hemangioblastoma. So most of the tumors are schwannomas. I just go through some of the videos. So microsurgical techniques, I use microscope, CUSA, and microsurgical techniques. We just careful while taking separating the cauda equina rootlets from the capsule. And this is the patient recovered well. And another one is L1 level schwannoma. Patient presented with foot drop. I use CUSA before taking out the tumor. Better to debulk the tumor. Otherwise, we compress. Basically, it will cause compression over the cauda equina roots. So better to use CUSA and debulk before taking out the tumor. What we did, and the patient improved in the next 2 days after the surgery. Foot drop. This is another conus cauda equina schwannoma. Here what I learned is, first we do decompression from caudal to cranial. So respect the conus area and respect the capsule over the conus, and should not pull or give traction injury to the conus. What I observed in private practice, the post-op bladder and bowel symptoms should not have any disturbances. And patient recovered well. Total excision was done. Patient came for 1 year follow-up. No bladder, bowel disturbances. Walking nicely. No any complications. So another one, I came across this extradural schwannoma. Pre-op study is very important to see the extradural, intradural. Sometimes even extradural tuberculosis also simulate with same kind of schwannoma. And radiology study is important because we should not, or we are not going to open the dura when dura meaning extremely intact, only when we are taking out, when we know that only the tumor is purely extradural, no need to open the dura, and complete excision was done and a microscope free of the meaning entire thecal sac is free. And this is another one multilobulated, and this patient, because of this tumor is extending along the foraminal region, patient has severe radicular pain. In these cases, what meaning along with that interdural compartment, we have to remove the foraminal compartment also. Otherwise, patient main symptom is radicular pain. We after the surgery, that patient radicular pain should improve. So is the various pictures. This after opening, meaning after dural opening, separating the after opening the dura, cauda equina roots are separated, and the tumor was seen very well within the cauda equina. You can see this is the extradural component of the tumor. After retracting the thecal sac and the root, I'm taking out this extradural compartment tumor, and this I use a QSA here in the foraminal region. We have to take out whatever the bone overlying and decompress the tumor in the complete decompression of the tumor along with the root, so that patient will be pain free after the surgery. So entire tumor was removed. After the tumor removal, you can see the extradural compartment, interdural compartment, all the cauda equina roots, cranial to caudal, they are very much intact after removal of the tumor. And the patient came for 6 months follow-up. She is doing well, and she is independently, she is climbing stairs, she is doing all her household works. This is a small L4 level schwannoma. Again, QSI is used. This is a microsurgery, meaning we use keyholes, meaning whatever the keyhole surgery, I use microscope and QSI. They are most two important equipment for spine tumors. 6 years back, I came across this tumor, giant invasive schwannoma, operated 2018. Now she lost the follow-up. She couldn't come. Now she came with small component of recurrence. And this another lumbosacral myxopapillary ependymoma. These tumors I use neuromonitoring because it's extensive tumor, and mainly to see the bladder and bowel functions to monitor sphincters. So this is a tumor, almost near total excision was done. Patient is better now. For last 5 years follow-up, he is doing good. And this another intramedullary cervical hemangioblastoma. It's a second trimester pregnancy. Patient doesn't want meaning terminate of pregnancy, so I have to operate, and it went well. After that, after 3 months after surgery, she delivered the healthy baby. This another one at D2 level intramedullary. It's came as a cystosarcosis with a huge syrinx. This one is presenting. You can see this is over the. You can see it is on the pile surface. It's surfacing on the pia. We have I got a very good margin from the surrounding pia. So because it's a thoracic region, we have to take care of blood pressure, because we should not give any chance of problem with perfusion of the cord is very important for post-op recovery. Patient actually is a constable working in Greyhounds. After 5 months after surgery, he could participate in 10 kilometers run, and he finished in 57 minutes. He completed 10 kilometers of run in 5 months. It's another one. It's a cavernoma operated elsewhere. Biopsy is reported as inconclusive, and the patient deteriorated after the surgery. So patient got first surgery done elsewhere, so he came to us. So I have to operate here because the clinical worsening. Here, we all know the second surgery is difficult. Mainly, it's wound healing, CSF leak, and during the surgery also, it's adhesions between the dura and the arachnoid, dura, lamina, muscle layers. We have to see clearly, and this is the I use neuromonitoring for our intramedullary tumors. And this after the surgery, you can see the clear cut underlying pile surface, and patient did well. And main thing is before the planning for surgery, we should have proper radiology to know the location, level of the tumor, and what approach we have to use, and extension of tumor. And we should have possibility of, we should have some idea about the what is the possibility of the lesion. And second thing is we should have any serings or associated complications with tumors. Patient has any serings or any scoliosis with the tumors. And there the operative nuances, blood pressure monitoring to see the perfusion of the cord, intra-op neuro monitoring. Always we should have sharp dissection of the arachnoid. No need of any, we should avoid tearing and pulling of the arachnoid. We should have retraction, we should avoid retraction injury. Thin capsule, we should always give good respect, enough respect to the corners region. That's the main important. And we should use minimal cautery and judicial use of steroids and watertight dural closure. There are some of the, when I was in Bengaluru Satsai Hospital, we come across some very maybe uncommon, interesting cases. Some extradural meningiomas, sacral epidermides, then hydrated cyst. We presented in few journals. I got a chance, and some of the osteolytic. That's what Vijay sir mentioned. Osteoblastoma, osteoclast. They are we come across in our private practice. Thank you.
Thank you. If no questions, then I call upon Dr. Bhatuk Diora from Mumbai to talk on the topic optimizing technology for intramedullary tumors.
Thank you, chairpersons. At the outset, I would like to thank Dr. Manas and Savitar. Savitar mentioned to talk about this subject, so I'm going to share experience with intramedullary tumors. Dr. Nair has nicely mentioned about the various shown various cases, as well as mention about the diagnostic difficulties in this case of this type of lesions. So we all know about these lesions consider about the 2 to 4% of CNS tumors, and they are relatively uncommon lesions. And the natural history is also very not very well known. So often we have a diagnostic dilemma, and surgically it's a technically demanding procedures, and if not performed properly, patient can have a significant neurological deficit. So actually, it's a challenging entity. Most common lesion is the intraependymoma, followed by the astrocytoma and the hemangioblastoma. Often we see epidermoid, dermoid, lipoma, metastatic lesion, tuberculoma, and the cavernoma. While ependymoma has centrally located lesions often associated with the cyst formation and brilliantly, nicely enhanced on the contrast. In compared to that, astrocytomas are often eccentrically located lesion and showing the heterogeneous enhancement. Hemangioblastomas are subpile lesions, quite vascular and often mimics like arteriovenous malformations. One needs to be differentiated from AVMs. So, how one can optimize the technology in the management of intramedullary tumors, like while diagnosing these lesions, while doing a decision making during the surgical procedures, increasing the safety of the surgery, and to improve the neurological outcome. Dr. Nair mentioned about the case of demyelinating disease in a patient that was mimicking like the intramedullary tumor. So I want to focus on the role of MR tectography. You know about the diffuser tensor imaging, that is also called the tectography, that helps us in identifying the location of the tracts, especially in the astrocytic lesions, like because it's a diffuse lesion, edematous spinal cord. It's very difficult to identify the location of the tracks. So in this case, you can see the tracks were located in the right side of the spinal cord. So it helps during the making the surgical decision while operating these patients. Also, the literature suggests that if we do the DTI in these patients, we can see the normal appearing or the streamlined spinal tracts, especially in case of the demyelinating disease. While there will be displacing these tracts in case of the ependymomas like a pilocytic astroma, sort of a low-grade tumors, while there will be complete termination of these tracts in case of the high-grade tumors. So in a sense, like this tool helps in the differentiation between this intramedullary tumors and the acute inflammatory conditions. Another paper, this technology also help us in deciding the, or one can say predicting the resectability of the lesion. This was published in Journal of Neurosurgery Spine, and they were able to, on the basis of MR technography, they were able to decide the resectability of the tumor on the basis of DTI. Second important tool is a digital subtraction angiography. As I mentioned, like hemangioblastomas are quite vascular tumors and also often mimics like arteriovenous malformation. Planning the surgery in this patient is extremely important. So, three-dimensional digital subtraction angiography plays a very crucial role. It helps in the better understanding of the arterial supply and the venous drainage of this tumor. So, it's a very good tool. Intraoperative fluorescent imaging using a various dye, especially the indocyanine green and the fluorescent angiography. These are the dyes one can use during the surgical procedure. I have also found a very important role of ICG in identifying the midline, because if we have properly done, ICG will show sudden disappearing of the vessels. Also, in a case of vascular tumors like hemangioblastoma, I often use ICG, and one can see there is a edematous spinal cord because of the here you can see the fluorescent dye in the edematous spinal cord. So often we see in the hemangioblastoma when there is a hollow cord edema. One more important tool is intraoperative neurophysiological monitoring, and one must use. I think in a case of intramedullary tumors, it minimizes the surgery-related risk of neurological deterioration. It allows the maximum tumor resection with a minimal neurological deficit. It also informs the surgeon during the intraoperative procedures, and helps surgeons to change the or alter the plan during the surgical procedure. And it provides a real-time assessment of the motor function, and alarms point is still not definitive or always reliable. So commonly used modalities are the somatosensory wave potential, transcranial. We know about MEP, but let me tell you, D wave monitoring is the best, because SSEP and MEP is not a real time, while the D wave is the real time. And this was a publication in the neurosurgery, World Neurosurgery. They were mentioned about spinal cord injury can be prevented in most of the cases by judicious use of intraoperative neurophysiological monitoring. Also, one has to remember about the change in the height of the amplitude as the increase the latency of the this waves. Very sensitive parameters. Use of intraoperative ultrasonographic aspirator is one more tool, but one need to have a judicious use of this device based on the ultrasonic principle of tissue fragmentation and aspiration. One can, with the starting, one can do the intratumoral decompression, subsequently creating a plane between the normal spinal cord parenchyma and the tumor capsule. One can safely do the intramedullary tumor surgery using a CUSA, but requires a proper training. And if you are not set CUSA settings properly, then sometimes can be detrimental for the patient. Use of a laser is one more tool, especially in a case of lipoma. Though no doubt these tumors are very rare. In my series of around 104 patients, I came across around 4 lipomas, and they were all symptomatic lipomas. And the laser plays a very crucial role in the excision of this lipoma. And in this patient, we use a diode laser. We thought like we'll be able to excise the tumor completely, but unfortunately during the procedure, because of the potential changes, we could not excise the tumor completely. One can see there was a significant thinning of the cord. This was a recurrent case of lipoma. It was previously operated 8 years back. So, surgical strategy, Dr. Nair mentioned about this, but as I mentioned about along with the ICG, dorsal column mapping is a very important tool to identifying the midline. So, if facility is available, one should use, because many times intramedullary tumor patients post-operative complain about the sensory symptoms in the limbs, and that can be prevented by exactly identifying the midline, and the dorsal column mapping is the best tool to identifying the midline. Surgical strategy, we all know about the using the microsurgical technique, using the available tools, especially the intraoperative monitoring and the QSA. One can have a successful excision of these tumors. I was just showing one case of a 28-year male who presented with the hemangioblastoma. He presented with the spasticity and the back pain along with the spasticity and the bladder involvement. He had a thoracic hemangioblastoma. We did a baseline MAP in these patients, and during this figure I showed. But this cases requires like it's like hemangioblastoma surgery is like an AVM surgery. So one has to have a precise control of the vessel and the proper identification of the plane of cleavage between the one has to create the cleavage plane between the humeral tissue and the spinal cord parenchyma, and then if you are in a proper plane, then the lesion can be successfully excised. But the preoperative understanding the vascular anatomy is crucial in these patients. And no doubt one has to use the intraoperative IC, intraoperative neuro monitoring in these patients. And this is the follow-up of this patient. It's like you can see the young male without any neurology. Actually, this patient was delayed surgery because of the fear of paraplegia. And so, because this vascular lesions can create a problem if you are not plan the surgery properly. Again, one more case of intramedullary tumor. During the positioning the patients, we found abnormal EEG, and abnormal potential, and we corrected the position, and subsequently we were able to excise the tumor safely without any neurological deficit to the patient. So out of 104 patients, I had a neurophysiological monitoring was used in almost like 25% of 24% of patients, along with other tools, and I had a significant morbidity in one patient. That is the first case I shown at the beginning of my presentation, large tumor, and in that patient, I have not used a neurophysiological monitoring. So the intramedullary tumors are challenging, very difficult to treat lesions. Various tools like MR tectography, digital subtraction angiography, fluorescent imaging, intraoperative monitoring, and the QSA are the important technological tools that helps in the not only helps in the diagnosis but helps in the decision making during the surgery, increase the safety of the surgery, improve the neurological outcome, and helps in the overall management of this patient. Thank you.
Any questions, please? If no questions, yes, sir. May I call upon Dr. Divya Jyoti Mahakul to speak on the topic Matryoshka doll phenomenon.
Good afternoon to one and all. First of all, I'd like to thank the organizers for this opportunity. As we are all aware of the fact, the burden of spinal metastasis, it's a distinct clinical entity with incidence being more than 30% amongst the cancer patients, with 10% of them actually progressing over to metastatic epidural spinal cord compression. Therapeutic options are mostly palliative, with the treatment goal being just to restore the normal functional status till whatever lifespan they have. Since the management is complex, we have various algorithms, various risk scoring systems, and prediction models. The incidence is actually ever increasing, and thanks to the increasing life expectancy because of improvement in chemotherapies, radiation, immunotherapies, targeted therapies, and hormonal therapies. The treatment protocol has evolved over the years since in 1980, when radiation was the treatment of choice for these patients, and laminectomy was the only surgical procedure that was offered to such patients. With the landmark study by Paschal, where instrumentation was added to the surgical armamentarium for these patients, and after that it has gradually evolved. And in 2014, the spine oncology study group headed by Bilski from MSKCC came up with a norms framework to decide the optimal treatment for such patients. It's basically has 4 components. The neurologic one, which depends on the clinical status of the patient, and the axial T2 MRI showing the degree of compression of the lesion over the cord. Then the oncologic one, which shows depends on what kind of a primary it is, whether it is responsive to the conventional 30 grays of conventional external beam radiation therapy. The systemic one, it depends on how the oncologist actually is able to control the primary disease and whether a patient has the enough life expectancy to reap the benefits of the surgery that we are planning on this patient. And the last one and the most important is the presence of mechanical instability that actually warrants a surgical procedure. And we have an objective parameter in the form of spinal instability neoplastic score, which was first proposed in 2010, and since then it has been validated across the globe with various studies. It's basically a 18-point scoring system with 6 clinical radiologic parameters, and scores are given to each of the parameters, and when the score is between 0 to 6, the spine is considered to be stable. But when it's at the other end of the spectrum, 13 to 18, it's considered unstable and that warrants fixation. However, the scoring system is very much silent regarding the middle third of the range from 7 to 12, considered as potentially unstable. There's a dilemma in surgical decision making, and it's upon the discretion of the surgeon to decide whether the patient needs a fixation. But this discretion has been extrapolated by the medical and the radiation oncologist, and they don't think and they rarely refer the patients for the neurosurgical consult, not discussed in tumor boards. The pain is erroneously attributed to be tumor related, and that leads to undertreatment of patients with instability, leading to risk of pain and neurological deterioration in the long run. So, does this dilemma in surgical decision making exist over the entire range of 7 to 12, or is just for a smaller range? Or to make our life simple, can we come up with a single cutoff value of sin score, above which we can straight away say that patient might require fixation? And with these queries in my mind, I delved into my own series of cases that I had specifically looked into a subset of cases like with the intermediate sin score of 7 to 12 without any neurologic deficit, but presenting with severe mechanical pain. That's a pie chart depicting all the 60 cases that I had operated. More than half of them were comprised of primaries from the breast, lungs, prostate, and multiple myeloma. That's the bar diagram depicting the instrumented and non-instrumented procedures for each of the pathologies that I came across. Hardly anything to choose between the two. That's a bar diagram again, depicting the instrumented and non-instrumented procedures that I offer to the patients from 7 to 12 on the SIMS category. Non-instrumentation included, procedures included various combinations of decompression and augmentation, while instrumentation group had fixation along with augmentation, vertebral augmentation and decompression in various combinations. And as you can see, the green pillar suggesting decompression and fixation actually getting taller and taller as we move from 7 to 12. There's an interesting line diagram actually depicting the instrumented and non-instrumented groups, the proportion of them for each of the scores from 7 to 12. As you can see, the two lines cross over between 8 to 9, and then suddenly they become almost parallel, 60-40, nothing, hardly anything to choose between the two, and then they suddenly diverge. At 11 and 12, there is 90 to 10% chance that the patient will end up with fixation, and at 7 and 8, and scores of around 7 and 8, there's 90% in favor of non-instrumented procedures. And since the lines cross between 8 and 9, if we take 9 actually as a cutoff score, the ROC curve showed a sensitivity and specificity of almost 70% and a positive predictive value of 80% for the patient undergoing instrumentation with having a score of SIMS above 9. Here are the various parameters between the two subgroups, non-instrumented and instrumented, that we compare. And as expected, overall sense had this was a decisive factor for patients to undergo instrumentation. And in the subcomponents of the sense, mechanical pain and involvement of the posterior elements of vertebral body were again much more decisive factor for the patients to undergo instrumentation. And the same again in the multivariate analysis showed the SIMS score to be another important factor. It's a 56-year male with known case of prostate, CA prostate. Patient presented with severe back pain, VAS score of 9, aggravated by movement. Sin score was 8. Semirageal spine, mechanical pain, normal spinal alignment, no collapse with more than 50% vertebral body involvement, and bilateral posterolateral involvement. Tokuhashi score was 15, which suggests patient has a life expectancy of at least 12 months. So we went ahead with a percutaneous fixation, and the patient has had significant decrease in the pain in the post-op period. There's another case, 46 male, multiple myeloma. Again, they're considered to be highly radiosensitive. Patient presented with occasional back pain, as T2 showing D11, D12 lesions, CT showing collapse at D11, D12. Sense was 9, junctional segment, occasional pain, lytic bone lesion, and less than 50% collapse. And Tokuhashi score was 12. We went ahead with percutaneous balloon kyphoplasty, and the patient had a VAS score of 3 at POD7 and was ready for the conventional radiotherapy. Similarly, one more case of RCC 53 male with severe back pain, MRI showing D10 metastatic lesion, but this time the patient had a high-grade metastatic epidural spinal cord compression, Bilski grade 3, and with the Tokuhashi score of 14, again, patient is supposed to live more than a year, and so went ahead with decompression and fixation these patients. So, as of now, SINS has actually the potential unstable category that we have ranges from 7 to 12. So with this, with the results that we have through this, is we can say that it can be actually trimmed down to 9 and 10 and include 11 and 12 in the unstable category, 7 and 8 in the stable category, so that the dilemma in surgical decision making can be cranked down to just 9 and 10. And to make our life simple, as a 9 can be a single cutoff value for the medical and additional oncologist to actually send a new surgical consult for such patients. And this like 9, 10, within this 9, 7 to 12 is like within a like phenomena is like the Matryoshka dolls, the Russian nesting dolls, which when you have a similar doll right inside one another, and who knows, with more parameters coming up, we might actually the dilemma in the surgical making will also get narrower. The results we have been able to publish this in the this month's Journal of World Neurosurgery. So in real life clinical practice, the uncertainty decision making lies just for a narrow range of sense 9 and 10. In fact, sense of 9 should be a cutoff value for the medical radiation oncologist to send the surgical consult. And mechanical pain and involvement of posterior elements of vertebral body should be are the most important parameters that decide upon which the fixation is decided. Death may be a one-time event, but living with terminal illness is a process. It's a quote from one of my favorite books, When Breath Becomes Air, authored by a neurosurgeon himself who was diagnosed with a spinal metastasis, how things changed once the diagnosis was done. And it's in fact true. Every single time I came across such patients, few minutes into the conversation, I could feel their eyes whispering, even if I'm dying, until I actually die, I'm still living. So we should not be turning our back on these patients, and all of them deserve to be pain-free for whatever life sands of time they have in their hand. Thank you.
Any questions, please? Thank you, doctor. If no questions, can I call upon Dr. Sangeeta Biradar to talk on the topic of management of IDEM with root preserving surgery? We'll call the next doctor, Dr. Sharat Chandra P, to speak on the vertebral hemangiomas with myelopathy treated with absolute ethanol embolization and single level fixation.
Good morning, everybody. Opportunity to present in this wonderful congress.
At the outset, I would like to congratulate Prof. Manas Panigrahi, Chairman of NSSA, Dr. Savit Shastri, and of course, under the leadership of Professor Ramani for this conference. Today, I will be speaking about our experience on long-term outcomes of vertebral hemangiomas presenting with myelopathy, which have been treated with absolute alcohol embolization intraoperatively with spinal cord decompression and short segment fixation. So this is a new technique which we have devised, and we have been following this for the past 15 years. And here I would like to show you the technique, the patient profile, as well as the long-term outcome. So no disclosures, that's the institution where I work. This is a neurosciences center, and these are the operating rooms. So vertebral hemangiomas are the commonest lesions of the vertebral column. They represent an estimated incidence of 10 to 12% of the entire population. However, it is very uncommon for vertebral hemangiomas to present with myelopathy. Approximately 1% of all hemangiomas become symptomatic. There have been various treatment modalities which have been suggested, including vertebrectomy, where you need to remove the entire vertebral body with or without embolization, radiotherapy, as well as cement. Each of this has certain limitation. For instance, vertebrectomy, I think as a strategy, it is as effective or as dangerous as the strategy which has been adopted in this picture here. And I have personally published some cases on vertebrectomy. I did a case where I lost about 4 liters of blood. And then I swore that I will never do this technique again because I was convinced that this was definitely not the right technique to do this procedure. Radiotherapy again has the issues of radiation as well as vertebral necrosis. It can lead to incidence of pathological fractures. Again, not very much indicated. Cement embolization again can be helpful in order to prevent pathological fractures and stabilize the vertebral body. But however, it does not kill the tumor cells and again has the higher incidence of recurrence. Now we started thinking of absolute alcohol embolization because this was already done by our radiology department. We published this small series of percutaneous embolization of absolute alcohol. But they did have two cases. One case where there was increase of neurological deficit and another case where there was a pathological fracture. And if you went back to the history, it's one of the most powerful embolizing agent. In fact, it was used for angioinfarction of kidneys. Now, the issues are that it does have a rapid systemic runoff and there are issues of toxicity, which can lead to transient asystole, transient hypotension, bradycardia, muscle and skin necrosis. And that's the reason why it has been given up as an embolizing agent. But for a pathology like vertebral hemangioma, it is quite optimal because it's a pathology where there is no rapid runoff into the systemic circulation. And when you inject some alcohol, it stays within the vertebral body. So if you look at the description, the first description of percutaneous absolute alcohol was done by Dockman in the year 1994. There was a transient deterioration in all, but however, they improved in about 11 patients. Then there was a report of Brown-Sequard syndrome following percutaneous injection. So this gave us an idea that the percutaneous injection should be combined with the spinal cord decompression simultaneously. Because when we inject absolute alcohol, there could be some swelling of the tumor, which may be causing compression of the cord. Now, in order to avoid the systemic side effects, we decided that we will do it intraoperatively, and it should be done in the small aliquots of administration under general anesthesia, which is a very well-controlled environment. And we should provide only half cc increments. So the amount which is preferred or which is recommended is about 2 to 3 cc in the body, 2 to 3 cc in the pedicular vertebral junction, and approximately maximum of 5 to 7 cc on either side. That is what has been used in the literature. Now there has been also report of pathological fracture following injection of percutaneous absolute alcohol, and in order to do that, we decided to do a single level instrumented fixation. So with this idea, we applied for ethics committee approval, and there was some difficulties initially, but we were able to get an ethics committee approval. So fundamentally, we combined 3 techniques. First is absolute alcohol injection in small aliquots with adequate saline irrigation in order to prevent any kind of skin or muscle necrosis. Then spinal cord decompression to be done in the same sitting, so we do a laminectomy. And then we perform a single level fixation so that we are able to prevent any pathological fracture. So this was the first series of patients which we published in neurosurgery almost more than 10 years ago. And then subsequently we published more papers. So this basically shows the surgical technique. So pedicle screws are placed both above and below the affected level. So that's the first thing we do. So we don't place pedicle screws at the pathological level. We of course use navigation. And using navigation, the entry point for injection injection of the Jamshidi needle is chosen. So initially we drill out the entry point using a drill. And then finally, we pass the Jamshidi needle into the affected vertebral body. So we prefer placing two Jamshidi needles, one on either side, and that's placed under navigation. So that's the Jamshidi needle being placed on the other side, and we just hammer it to ensure that it's in the middle of the vertebral body. And then once we remove the stellate, you can see that blood starts flowing freely from the hemangioma. And then we attach two 10 cc syringes on either side with absolute alcohol, and then we start injecting small aliquots of half a cc, alternating on either side. And you can see that we have covered the entire operative field with wet saline soaked gauze, and generous irrigation is performed so that if there is any reflux of absolute alcohol into the operative field, it can be very adequately washed away. Now, following injection into the vertebral body, the needle is withdrawn till the pedicular body junction, where again there will be some bleeding, and then again we inject about 2 to 3 cc into the pediculovertebral junction. It's very important to have a complete intraosseous access. So an extrapedicular approach is not indicated in this case because there could be reflux again of the absolute alcohol into the soft tissue, which is again not good. So then the Jamshidi needle is removed and the opening is plugged with the bags, and then a lot of irrigation is provided locally. Now, following this, we perform a single level laminectomy. Now, you can see that when we are drilling, there is absolutely no bleeding. That's because almost instantaneous embolization takes place. We don't try to remove any kind of soft tissue portion of the vertebral hemangioma. So, if we leave it, that kind of undergoes shrinkage over a period of time by itself. In fact, it starts almost immediately. So another short video to show the instantaneous effect of absolute alcohol injection. So we have introduced Jamshidi needle, we removed the stellate, and you can see the blood flowing from the hemangioma very freely. Sometimes it almost feels as if you have cannulated an aneurysm. So in this case, again, we have attached the syringe with absolute alcohol on both the sides, and we start injecting not more than 0.5 cc, alternating on both the sides. And you can see almost instantaneously absolute embolization takes place and it becomes bloodless, and there is no return of any blood tinged fluids. Now, this was a child who was paraplegic for almost 1 year. He was bedridden. And when we did absolute injection along with spinal decompression and single level fixation, she started walking. That is, at 1 year, of course, she still has weakness, but she started walking and she was totally paraplegic, a complete sensory level and a complete motor level. So patients start having improvement from the same day itself. So in the evening, when you ask the patient in the evening of surgery, they will start telling that they feel that their legs are, lightened and they're able to move it much more better, and they feel much more better, and improvement starts taking place within 1 week. So we have done absolute alcohol injection in about 43 patients, and all of them had presented with myelopathy. 5 of them were paraplegic. Sphincter involved in about 13 patients. The mean surgical time was approximately 2 hours. The average blood loss was about 270 cc. The mean amount of alcohol injected was about 14 cc. Now, this was a bit higher. Generally, it's about 5 to 7 cc, but this amount was higher because in 2 patients, they had multiple level hemangiomas and we had to inject 20 and 25 cc. So this is an example. You can see that there is severe compression with vertebral hemangioma single level. That's the axial section. And post-op, you can see laminectomy and fixation, and you can see there's a complete shrinkage of the vertebral hemangioma. And there is also evidence of osteogenesis. So absolute alcohol kills the tumor cells, and after some time, the empty bony lattice forms a very good matrix for development of new bone. Again, another example, severe compression here, vertebral hemangioma, severe cord compression. And when this is after 1 year of follow-up, and you can see very excellent decompression of the cord. Now, this patient had multiple level hemangiomas and also had a cutaneous angioma. And you can see that it was extending up to 4 levels, and that is the axial section compression. And post-op, you can see that there is very good decompression. That's the pre-op, and this is the post-op. Another patient, again, very severe compression. That's the pre-op. And post-op, there is a complete decompression of the cord due to shrinkage of the hemangioma. Now, this was a patient who was pregnant for 6 months and presented with paraplegia. And this is the kind of compression she had. She underwent a laminectomy outside following which she worsened. So that was a very challenging case. So we performed the surgery in lateral position. That is the pre-op. You can see very severe compression. And following surgery, there was a complete regression of the tumor. And she delivered a healthy boy and was fully ambulant at 16 months of surgery. Now she regularly takes walks and goes also for gym classes. Now her husband was a journalist, and they were quite fascinated that we could treat it with alcohol, and this also came out in papers. And she is a patient who was paraplegic, was 6 months pregnant, and now was able to walk and delivered a healthy boy, and also was doing very well. So in the follow-up, you can see that there was an improvement, uniform improvement in all the patients. The sphincters also improved. So generally, we have found excellent recovery in all the patients. And all of these patients developed bone stenosis. We had one mortality. This was a large multi-level hemangioma. This patient developed a renal failure about 1 month later. Now we don't know it's because of the embolization or because of something else, but this was a really challenging case. And patient had come with complete paraplegia. So concluding, absolute alcohol, we have found it to be safe, effective, and a very easy method to cure hemangiomas. Small aliquots prevents the systemic toxicity. So we inject a maximum of 5 to 7 cc on either side, not more than 12 to 14 cc. Approximately 2 to 3 cc in the middle of the body, 2 to 3 cc in the vertebral pedicular junction. We ensure that there is plenty of irrigation, and following removal of the Jamshidi needle, we plug the opening with foam wax. So our technique of absolute alcohol embolization with spinal decompression with single level fixation has been the key to treat symptomatic hemangiomas presenting with myelopathy. We have found that even long-standing paraplegias improve. I would say that it is a very simple, effective, and a minimally invasive strategy because you are avoiding any kind of vertebrectomy or a 360 degrees fusion. Currently, this is the only treatment followed in our whole department. We have to understand, we have seen that absolute alcohol kills the tumor cells. So as a result, the entire bony matrix and lattice becomes free. So as a result, it can be filled in again with new bone. And we're not seeing a single case of recurrence. Of course, for countries like ours, it's highly cost effective because the cost of absolute alcohol is less than $1. In fact, we don't spend any money. We just get the sample from the pathology department. So thank you very much again for giving me this opportunity.
Next lecture is also video lecture as he could not come by Dr. Pragnesh Bhatt, UK. Is intraoperative neurophysiology monitoring useful for IDEM tumors? Video session.
Good afternoon, chairpersons, ladies and gentlemen. First of all, I would like to thank Professor Panigrahi for giving me the opportunity to share my experience of intraoperative neurophysiology monitoring in surgery for intraneural extramedullary spinal tumors. I'm also grateful to Professor Savitri for allowing me to join virtually and present my slides through Zoom. As I have borrowed the material from many authors, I would like to express my gratitude to the founding fathers of neurosurgery, but more importantly, late Professor Bhagwati, who trained me in India, and Professor Guru Singh and Professor Davis, who trained me in the UK. I will take you through the following agenda in the next 8 to 10 minutes. And since the accidental discovery, this chance finding by Professor Galvani, we know that neurophysiology monitoring has been used extensively in spinal surgery. And here are the landmarks. The literature also favors the use of neurophysiology monitoring in spinal surgery, and the consideration should be what monitoring modalities are most appropriate for the case at hand, what type of neurological deficits are most likely, any adjustment for the anesthesia, what criteria would be used to alarm, what action should be taken if there is an alarm, and what are the techniques involved and how they will be implemented. We also know the basics that various modalities have strengths and weaknesses, as highlighted here by red underlines. In the beginning of my practice in Aberdeen, in a short period of 3-4 years, I had opportunity to manage most of the intradural tumors. And from that experience, we built on currently having more than 60 to 70 tumors operated by single surgeon. I'll quote a couple of examples to start with. A young gentleman with foramen magnum tumor was operated upon with extensive neurophysiology monitoring. We were privileged to have one of the best neurophysiologists in the country helping us. And you can see that here free running EMG showing motor responses in the ninth cranial nerve via needle placed in palatal muscles. Here you can see triggered EMG. Once again, while working close to the base of the tumor from palate and cricothyroid, as you can see, and motor evoked responses from first dorsal interosseous without any evidence of damage to the long motor tracts. This is postoperative imaging showing complete excision, and here free running EMG in the top right, simulated EMG bottom left, motor evoked responses bottom right, group 4, arm and leg, somatosensory evoked potential. In another example, with a tumor close to the conus region, we had monitoring of appropriate modalities with left posterior tibial sensory evoked potentials and right median sensory evoked potentials, showing stable posterior column functions. Interpretation has to be made carefully because stimulation of roots and nerves can produce discharges and mechanical responses are not linear. God ends also work and visible contractions are far more sensitive with paired needle recordings. Over a period of time, we have done significant number of intradural extramedullary tumors as compared to very few intramedullary tumors. Most of the tumors were in the thoracic region, as one would expect. And here is the spread of histopathology, with neurofibroma being the commonest and ependymoma and metastasis being the next. The literature also confirms the evidence of monitoring in spinal surgery with various strands outlined here. What are the diagnostic test characteristics of unimodal versus multimodal modalities? Which modalities are superior? Does intraoperative neuromonitoring reduce the rate of new or worsening neurological deficit? And does the reaction to a positive intraoperative neuromonitoring alert reduce the rate of a new worsening neurological deficit? And various levels of strength are shown here. This has also been studied extensively on nearly 3,000 patients with highest sensitivity with multimodal modality monitoring. And as shown here in the bold italics, the sensitivity is highest when you use combination of all the modalities, as one would expect. The key points are multimodality monitoring is valuable. Once again, repeating the same pie chart. And we recommend intraoperative neurophysiology monitoring as a routine practice. The application of technique has to be tailored to an individual need. For example, long tracks need motor evoked potential and sensory evoked potentials, while free running and stimulated EMG for the motor roots and peripheral nerve. Communication with neurophysiologists is important, as during complex monitoring, the surgeon may be aware of risk to a particular structure, but without an operative field video display, the neurophysiologist may be focusing on a less important pathway. The neurosurgeon needs to understand what the neurophysiologist can and cannot detect. Since no technique is perfect, an application in theater can give practical difficulty. In conclusion, through this retrospective study, we concur with the evidence in literature that early warning of potential permanent damage gave clear benefits in difficult cases. Over a period of time, we have moved on to minimally access surgery rather than the standard neurosurgical dictum to see the normal structures before the tumors. Here we are now able to access tumor with hemilumpectomy approach while safeguarding the neural structures through monitoring. And of course, in a teaching institute, training of all healthcare professionals, including technicians, are important. No work is complete without the team. And here I am proud to share a neurophysiology team led by Dr. Alan Foster, who is a friend of NSSA and has visited India many times. I thank you for your patience listening. Available for questions.
Any questions, please? If no more questions, we'll break for tea. Thank you for your attention. The session is closed.
I request all the participants to join back sharp 4. We'll begin the last session for the day by sharp 4 p.m. Thank you.
हाँ सर।
कनेक्ट करना है? अभी स्टार्ट होगा ना? आ जाएगा नहीं, यही ऐसी तो आएगा। पर चेक करा ले बस एक। पासवर्ड कैसे हो? ये हुआ क्या?
Nehil. Nehil. A very good evening, everyone. Welcome back. And we are just heading on to the last session for today. That is the fifth session on spinal tumors 2. I would call upon Dr. Chandrasekhar Naidu, Dr. Sandeep Manda, Dr. TV Srinivas. Sir, please come on to the stage for chairing the session.
Okay, start it.
Good evening to everybody. We'll start the next session. I request Dr. Puneet Trivedi, to come and deliver his presentation. The topic is encountering rare cystic lesions of the spine. Dr. Puneet, please.
Hello. At this outset, I thank Dr. Manas sir, who was my teacher, Dr. Naidu sir, and the whole KIMS hospital, from where I did my postgraduate neurosurgery. And whatever I am, it's because of my institute. The above is the photo of completion of my fellowship under Manas sir in skull base and epilepsy. And the below photograph is when he visited Gir Forest. So in my limited experience of 7 years, I have operated 32 cases. The number of cases are very small. Indirectly, Narendra Modi is responsible for this, starting Ayushman PM Yojana, and I don't have that scheme in my hospital. So initially, 1 or 2 years, I used to get spine patients, but 90% of the patients in my state are opting for this government scheme. So that is the reason. So I have operated 32 cases of spinal tumors, and tried to find out the number of cystic lesions in this. So there were 3 neurofibromas which are cystic, 2 meningocele, and rare cases like hydatid cyst, epidermoid cyst, cervical hemangioblastoma, and dorsal neuroenteric cyst. I will discuss a little bit about the hydatid cyst which I encountered in during the year 2020 during the COVID time. So this was the first reported case in Saurashtra, Kutch, and the patient presented with paraparesis of power 3/5. He was carried by 2 people walking, and he also had lower neck pain, and his bowel bladder habits are normal, and he was associated with animal husbandry. So this is the MRI T2 weighted images. It is showing the destruction of T2 vertebral body and some cystic lesions, and it is extending into the spinal canal and compressing the spinal cord. Besides these axial cuts, you can see the multiple cystic lesions which are present in the paravertebral spaces and also involving the D2 vertebral body, and also going into the into the spinal canal and compressing the cord. However, they were extradural only. So this typical appearance is like a bunch of grapes, if you can appreciate. These are the sagittal cuts of T2 weighted images. It is showing the large cystic lesions, loculated lesions present in the mediastinum. So, along with the cardiothoracic surgeon, Dr. Madhav, and me, we went ahead with the procedure. This is a T-shaped incision which was taken over the sternum and also exposing the lower cervical area. The second picture you can see is the pit, the sternal notch. So partial sternotomy was done, and the mediastinum was entered, and we found this kind of cystic lesions containing fluid. The cysts were removed carefully without being it ruptured, but some of the cysts got ruptured because the wall was very thin. So these were the number of cysts which are removed one by one, and expandable cage was placed into vertebral D2, and D1 and D3 fixation was done. Patient has had a very good outcome. He recovered to almost normal power, but because of COVID and later on he did not come for the follow-up. Last year, after 4.5 years, he presented again with the paraparesis, and repeat MR was done, but patient did not turn up to me, and he went ahead with the government scheme card to some other hospital. So we all know the life cycle of hydatid cyst, and the incidence of hydatid cyst of spine is very uncommon. It is only 0.5 to 1%. First case was noted in 1948. Other organs should also be scanned if you find a spinal hydatid cyst. Paraplegia is the most common symptom of 66 to 70% of cases present with this. The most common location of spinal hydatid cyst is thoracic region. The reason is the intense local vascularization and the rich blood circulation of the spongy vertebral bones. Laboratory tests should be done. Allergic reactions may also develop due to allergen content of the cyst. So it is very important that we do not rupture the cysts. Imaging, as we already discussed, in CT findings, we have ovoid space occupying lesions with the double layer arcuate calcification. In MRI, we have multiple cystic fluid filled lesions septated with thin walls and irregular branching resembling a bunch of grapes. The signal on the MRI, T1 is hypointense and T2 is hyperintense. So these are the differential diagnosis, but the hydatid cyst, as we see, if you have seen even once, we cannot miss it radiologically because it has a very typical appearance. The classification is intramedullary, intradural, extramedullary, all these spaces we can find. Mortality is also very high, 14 to 58%. And albendazole and 6 months treatment is the most preferred treatment protocol. But even with the medical treatment, 51% of the patients have at least one relapse. Spinal head cyst treatment is particularly difficult in patients with vertebral and paraspinal involvement, spinal instability, and recurrence. Cyst should be removed without rupture as far as possible, and also the cavity should be irrigated with hypertonic saline. The recommended duration of anti-helminth therapy is 4 to 6 months. This was another case, 4-year-old child who had a conus lesion. This is the MRI, T2 hyperintense lesion, cystic lesion, T1 hypointense. Epidermoid cysts also account for less than 1% of intraspinal tumors. They are both congenital and acquired. They are rarely identified in the cervical and upper thoracic region compared to the conus. Acquired epidermoid cysts usually happen due to lumbar punctures, and congenital epidermoid cysts usually arise from ectodermal inclusions that change in early fetal life and may be associated with the closure of neural tube. Approximately 40% of these cases are idiopathic. As I already said, the cranial epidermoid cysts are common compared to the spinal epidermoid cysts. This is a histopathology, which is showing the stratified keratified epithelium and also the cystic cavity. We know the clinical features, how they present. The most common symptoms are weakness, muscle cramps, numbness, paresthesias, gallbladder issues. Cysts can rupture, causing signs and symptoms to appear suddenly. So cyst rupture may be due to increased pressure due to Valsalva maneuver, such as coughing and sneezing. In such cases, patient may present in emergency also. So T1 is hypointense, T2 isointense, and there is an enhancement of the wall of the cyst on MRI. Treatment, internal decompression with cyst content aspiration is a treatment of choice. As far as possible, the capsule has to be removed, but if it is adherent, if the capsule is firmly attached to the nerve or underlying nervous tissue, trying to remove the cyst wall completely may cause neurological deficits. So en bloc resection is not possible in many cases. Even in my case, it was not possible. We tried to remove, but it was stuck with the nervous tissue. The intraoperatively, along with MRI, we can use SEP, MEP, EMG for helpful excision. So in the review of literature, I found the importance of not attempting to complete the capsule resection when the cyst wall is tightly adhered. That is the take-home message for this. And relapses have been reported even with epidermoid cysts, and resurgery is the option. There are reports people have placed Omoy reservoirs into the cavity, but there is a risk of infection. And overall, surgical treatment of epidermoid spinal cyst is difficult due to difficulty of complete removal of the cyst wall and therefore high risk of recurrence. In conclusion, asymptomatic patients can be treated conservatively, where watchful waiting is indicated. Once the patient has progressive symptoms and compression signs on imaging, surgical excision is recommended. But struggling to remove the last and the most adherent capsule will worsen post-operative neurological deficits. In these cases, electrocauterization helps to prevent regrowth. Making every precaution to avoid leakage of the cystic fluid into the subarachnoid space helps to avoid post-operative chemical meningitis, and if it occurs, short course of steroids should be given. For multiple recurrences, radiotherapy is an option. These were other cases. I welcome all. Next year, February 28, March 1st and 2nd, Rajkot, Gujarat is hosting the NSSI conference. We wholeheartedly welcome you all, and there are beautiful places to go around Rajkot. Thank you so much for your patient hearing. Thank you so much.
Thank you, Dr. Puneet, for your excellent presentation. Over to the audience.
Think it is possible to excise completely. My experience, I have three cases. One is intramedullary, two cases are the vertebral. One cases I able to remove 90% and continued albendazole for 6 months. In another patient, he is still alive, paraplegic. I operated twice. And during the COVID time, he had discontinued albendazole. After that, he landed on the paraplegia. My experience is in cases like this, it is always better to continue albendazole because we are not never able to excite is 100%.
Yes, sir. That's true. Difficult to remove, but during that surgery, we almost removed, I think, more than 95% of the
95%,
cysts.
yeah.
Some hidden cysts may not be removed. But
Because most of the patient coming from the poor social status.
Yes.
And they never afford the resurgery particularly. And it is very difficult, particularly in those kind of the cases.
Yes, sir. Yes, sir.
Then in your case, you are prepared for preoperative diagnosis of hydatitis?
I was not prepared, sir, because even the radiologists were also, they have given some differential diagnosis.
Most
So
of the
only during the surgery we got to know this is hydatitis.
This is what happens in hydatitis. We can only diagnosis on table where we are not prepared. We are not prepared with the scolicidal hypertonic saline.
Yes, yes, yes.
This is what happens. That's why the outcomes are very poor in hydatitis, and recurrence is very common.
Yes, sir.
No questions? Then we'll move on to the second. Spinal arachnoidosis, a case series with a detailed review of literature by Amit.
Good evening, everyone. I thank the organizers for giving me this opportunity to present on spinal arachnoidosis, a case series with detailed review of literature. The spinal arachnoidosis are rare. They represent around 1 to 2% of all the primary spinal lesions. They can present either with myelopathy or radiculopathy. Nabors et al. Way back in 1988 classified spinal meningeal cysts into three types: extradural, intradural, type 1, 2, 3. Our series of 12 patients, it's a retrospective data of last decade around, including 4 male patients and 4 pediatric patients of all of them. Mean age is being 34. The commonest symptom is weakness of the limbs, commonest sign myelopathy, duration of symptoms ranging up to 6 months. Of the 12 patients, 7 patients are of extradural location, whereas IDM 3 in numbers, 2 ventral and 1 dorsal. 2 are intramedullary, very rare in the literature also. Of the vertical location, thoracic is the commonest level of 5 numbers. We have tabulated the 12 patients in this manner. Of the 12 patients, 11 patients were operated, 1 was managed conservatively. In the 7 extradural cysts, 6 were operated. In the 5 patients, we could identify the intradural communication. That is more important to ligate the intradural communication. The site of the intradural communication was the junction of thecal sac and root tube in 4 patients and the posterior midline in 1 patient. Could not identify in 1 patient. Intradural cysts, complete excision could be done in 1 patient. Others partial excision and fenestration was done. Intramedullary, both the patients only partial excision was done.
These are representative images of extradural arachnoid cyst. These are the sagittal, coronal, and axial section. This is the operative picture with clear-cut, well-defined cystic lesion with daughter cysts extensions into the neural foramina, easily dissected off from the dura. These are the representative images of the intradural arachnoid cyst at the level of C1, C2, C3, and another one is intramedullary arachnoid cyst in the lower cervical spine. Outcome we classified based on Odam's criteria, or classified into excellent, good, fair, and poor. Excellent being no pain and no neurological deficit, whereas poor coming to disabling pain and unable to work at all. At discharge, 6 patients were in excellent, 2 patients were being in poor grade. One of the poor grade patients presented with hemiplegia, persisted hemiplegia even in the follow-up. Post-op scan showed the cord atrophy. The other patient has deteriorated because of severe spondylosis was also there, and that patient has improved at the 6 months follow-up. Coming to the literature of a review of the literature, there was a difference of opinions regarding other authors, whether intradural location is common or extradural location. Even our series has got more number of extradural lesions. I used to wonder why the intradural location of the arachnoid can cause so much of extradural lesions. So we wanted to clarify that doubt. We have done the detailed review of literature. All the case series, we have noted these points: age, gender, location, mean level, vertical and horizontal. And subgroup analysis was done both intradural and extradural. Prisma guidelines were followed in the PubMed search. Finally, we have finalized 33 articles with 10 or more spinal arachnoid cyst reportings only we have taken into consideration. From these 33, 741 patients along with our total of 753 patients were included in this review of literature. We have divided those into pure intradural case series, pure extradural case series, and combined intradural and extradural case series. We have tabulated and recordings were done. Finally, this is the answer we got. The intradural location is the commonest. They are 2/3 of all the patients are of intradural spinal arachnoid cysts. Only 1/3 are extradural, and intramedullary are very, very rare. Gender slide, female preponderance is there for females. Mean age is around 41 years. Age range is from 19 months to 91. Pediatric age is around 10.9% of patients. This is from the total review of literature. Common symptoms being pain and weakness. Common sign being the myelopathy. Mean number of vertebral lever extension is 3.75. Longest reported being 20 levels of extradural lesion. This is the subgroup analysis of intradural versus extradural. The age and vertical and horizontal levels. There is clear-cut difference between intradural arachnoid cyst and extradural arachnoid cyst. In the age category above 50 years, we can see extradural lesions are very less compared to intradural. We can infer that extradural lesions, they present early. So in the age group of less than 50 only. Compared to intradural, they present in all the age groups. In the horizontal level, ventral lesions, there is a clear-cut domination of intradural. Extradural lesions, ventral are very rare. Similarly, in the vertical levels, the upper spine, cervical, cervicothoracic, and thoracic, intradural lesions dominate, whereas in the lower spine, thoracolumbar, lumbar, and sacral, extradural dominate. So these are horizontal. 1/5 of all the intradural spinal arachnoid cysts, they located ventrally, compared to only 3.5% of extradural lesions. Coming to the vertical level, we can see the domination of 86% of intradural lesions in the upper spine compared to 69% in the of the extradural in the lower spine. MRI is the diagnostic imaging of choice. They delineate clearly exact location, extent, In the extradural, classical points are epidural fat capping in the superior and the caudal end. We can see the spinal cord thinning. Vertebral body scalloping can be noted here and here. Similarly, pedicle thinning will be there. Chronic compression on the bone can be seen clearly in the extradural lesions. Particularly, this point is important in the recent imaging because to identify preoperatively the communication site is difficult actually, but it can be tried, particularly in the long segment lesions, because the outcome of long segment laminectomies is poor. That's the reason why identifying the communication and operating at that level and ligating that communicating site is important. So CT myelogram, cine MRI, 3D CCMR, MRI myelography were prescribed by used by some others. Commonest being CT myelogram followed by cine MRI. Particularly extradural acnosis, complete excision with closure of dural defect was advocated earlier, but in the last decade, selective laminectomy, incision of the cyst wall and closure of dural communication has been advocated with equally good outcomes they have noted. And total excision of the cyst is advised when the communication could not be identified either preoperatively or during the surgery. Intradural arachnoidosis goals should be decompression of the cord, establishing sustained flow of CSF and preventing the post-op adhesion. Complete excision can be done whenever possible if the lesion is less than 3 vertebral levels. Otherwise, partial excision can be done with no significant difference in clinical outcome. Out of the 753 patients, 92% of the patients were operated. The outcome data was available in 402 patients. Poor outcome was noted in 11.7% patients. The factors predicting poor outcome are long duration of symptoms more than 1 year, signs of amyotrophy, cyst size more than 5 vertebral levels, and marked thinning of the spinal cord. And motor symptoms improve better than the sensory symptoms. Word about secondary arachnoidosis, they are rare, 12% being the secondary arachnoidosis, 91% of being intradural. Etiology post-traumatic, post-hemorrhagic, post-infective, post-LP. Syrinx is more common and recurrence is more common. Intramedullary spinal arachnoidosis, they are very, very rare. Only case reports are there. Thakur et al. Reviewed 25 case reports and overall 45% of them are being pediatric. That means they present the most earliest of the 3 groups. We have got some limitations like we did not include smaller series and all the detailed information of the total patients not available. So we can concluding intradural spinal arachnosis was twice as common as extradural. Ventrally located are more common intradurally. Intradural spinal arachnosis are more common in the thoracic and cervical levels, whereas extradural in the lower spine. And the surgery, preoperative imaging to be tried to find out the communication in the extradural spinal arachnosis, and then selective laminectomy can be done and closure of the dural defect. Whereas total excision should be tried when the communication could not be done. Intradurally, selective laminectomy, partial excision, and wide fenestration is advised. Thank you.
Any questions?
Cervical and thoracic region, when we do these cases, we always tell the pathologist to look for neuroenteric cyst, arachnoid cyst, hydatid cyst. We have to mention it to them to know the differential diagnosis of this because to prevent future recurrence in these lesions.
Yes, sir. Yes,
That's
sir.
very
Right.
important.
Right. That's true.
In intramedullary, What did you have done?
Just opening and taking a small fenestration.
Fenestration.
One is upile, that is easier one. We can excise part of the cyst wall, but the other one is purely intramedullary.
Next, I invite Dr. Suresh Dugani. Spinal IDEM tumors, principles of microsurgical management.
Respected Chairperson, dear colleagues, at the outset, I thank and congratulate Professor Manas, Professor Savitra, and NSSI for the excellent meeting, kind hospitality, sharing and learning from each other. As a part of this, I thought I'll share with you a few of our work and experience in the management of intradural extramedullary lesions since 1991 to 2024, 33 years. We have treated more than 1,400 cases of these. Out of them, intradural extramedullary were about nearing 1,000, and only intramedullary were about 224. This is the distribution of cases. Majority were nerve sheath tumors, meningiomas next, arachnoid cysts, lipomas, dermoids, epidermoids, subdural hematomas, and empymas. Intramedullary, I'll not touch upon it because I thought only concentrate on already Professor Nair has excellently mentioned, and even Batuk also has covered them very well. The procedures or the access chosen depend on the location of the lesion. Most common one is posterior, laminectomy, laminotomy, fenestration, depending on the size, location, spread of the lesion. Lateral approaches, retropleural, retroperitoneal, cervical lateral, transpedicular. Anterior approach, we do corpectomies, required cases, and combinations of these may be called upon to treat, practiced. The procedures, microsurgery is a gold standard, endoscopic surgery associated, assisted by endoscopy, sometimes combined are the ones. What do you need to treat these lesions better? We need a good bipolar, non-stick microscope, CUSA, image intensifier, intraoperative electrophysiological monitoring, spinal instrumentation is at most importance, post-operatively, endoscope, high-speed drill, and neuronavigations are at most importance. Along with this, we need to do some special procedures when the lesion goes in all the 360 degrees in and around the spine, anterior, anterolateral approaches, it through the neck, do a corpectomy, stabilize it anteriorly. Again, thoracic lesion, cervical region, you need to put the implants. C1, C2, when you do the decompression or excise these lesions, you need to stabilize the lesion. Thoracic, you need to excise the tumor and do a graft, and sometimes you need to stabilize depending on the pathology of the lesion and the bony destruction which occurs. We need to know all these things. We usually prefer to do a laminotomy than laminectomy in majority of the cases if the lesion is more than 1 to 2 centimeters. Two levels. This is the cutting we do through the craniotomy cutter on both sides and pick up the laminae detaching from the dura and leave it attached with the interspinous ligament and put back again at the end of surgery and fix it post-operatively. Already discussed extensively, intraoperative IONM is of great help in these cases. I'll not go into the details of it. I'll share a few of work and experience in management of these lesions. Our approach is different. This is a lumbar schwannoma. Arachnoid is opened. These schwannomas are well capsulated and they have one mother root from which they originate. And we don't believe in taking out the lesion in piecemeal. We in the arachnoid open it, the lesion starts moving and identify the mother root proximally. And there are some roots on the surface of the lesion. We need to identify, separate, and distally also, you'll have one mother root and whole tumor is excised in less than 15 minutes. That's not an important factor. Again, cervical schwannoma, similar fashion, open the arachnoid well, proximally and distally, identify the mother root, proximally and distally, open the arachnoid. The surrounding normal roots on the surface of the tumor are separated and whole tumor can be extracted from the spinal canal, preserving all the nerve roots, sometimes mother root in cases of
schwannoma, and the surrounding roots can be preserved, and whole lesion can be excised without touching the spinal cord, and no blood loss, and practically no injury to the cervical, high cervical, large schwannoma. Same procedure. Arachnoid is opened, lesion is extracted outside under microscope. A mother root proximally detached, surrounding attached roots separated gently. Distal mother root. Usually these roots are non-functional. Whole thing can be taken out in one piece, and no blood loss, nothing. Multi-compartmental trilobed schwannoma originating from the thoracolumbar region. Laminotomy again. Drill on one side where there is the tumor is extending. Go on to the lateral aspects. Identify the tumor going into the peritoneum and pleura. Don't damage or destroy, injure the peritoneum and pleura. First, the extraspinal part of the tumor is dissected from the dura and taken out. Usually, as I mentioned to you earlier, one root is always involved, that is cut and taken off, sacrificed, because usually that root is non-functional. Now, from the pleural surface laterally is excised. Again, protect the pleura under any circumstances. If you feel you have damage, you need to put intercostal drainage postoperatively. That is a tumor, extradural, extracanaliculaire, and completely removed. Now open the dura on the sides and you can excise the lesion completely. That is the part of the tumor which is inside the dura. Just now they mentioned that these lesions are extradural. Many times it's difficult to accept that because all these tumors, they may have a small component intradurally which can be excised. Again, you see the whole tumor in one piece. After opening the arachnoid, you can excise it completely from the lateral cutting of the dura and take off the lesion completely. Roots are all well preserved and the dura mater can be closed laterally as much watertight as possible. And if you think there is a significant pedicular damage and the supporting bony damage, you stabilize the same sitting, and that's the patient post-operative no deficits. High cervical schwannoma, multi-compartmental, intradural, extradural, extraspinal, and cervical, all at a time. Same thing. High cervical laminotomy. First, extradural tumor is debulked, taken out. Now you follow it up, and intradural part, again, you see that how easily it extracts if you open the arachnoid and dura, whole tumor without injuring the root or without touching the root or without damaging the roots, you can excite it completely from one mother root. The whole lesion is taken out in one piece. Dura mater is closed as a carotid anteriorly. We close, stabilize, turn the patient in the same anesthesia, approach laterally, anterolaterally, the part of the tumor going into the anterolateral part of the cervical spine, excised through the anterior approach and stabilized simultaneously. This is a comprehensive, complete excision. Now coming to meningiomas, again, we believe the same thing. We don't take out the meningiomas in piecemeal, especially when they're situated laterally, dorsally, and anterolaterally. We locate and isolate the meningioma, cut the dura proximally, cut the dura distally, open the arachnoid, separate the nerve roots which are on the surface of the meningioma in the arachnoidal plane, separate the tumor completely from the cord in the arachnoidal plane. Believe me, you'll never touch the cord in these cases, and practically no blood loss. The whole tumor is taken out. Symptoms type 1 excision. Subsequently, with the muscle and fascia, you can close the dura. C1 meningioma going up into the foramina magnum. Same approach, lateral, extreme lateral approach. Here, in these locations where the important vital structures are there, sometimes we need to debulk the tumor and reduce in size, create a space and excise it from anterior part. There are multiple lobules. The inferior part is taken off completely. Believe me, many a times the nerve roots can be saved in these cases. Now that is the posterior pica and vertebral branches. Arachnoidal cyst, just now you heard a very nice presentation. I don't think I'll go into that. This is a complete excision of the lesion. I just will take 1 minute more. This is the complete excision of the tumor, and those are the cervicomedullary junction, C1 root, and perforators to the cervical spine, and subsequently we did a posterior stabilization, occiput C1, C2. Pial AV malformation, a big one in the cervical spine. You can see the dura is opened. It's a worm. The blood vessels look like worms, a big one with the quadriparesis. Start either proximally or distally. Maintain the arachnoidal plane with a high illumination and high magnification. Keep devascularizing the feeders which come from the anterior spinal artery through the lateral aspect, and keep dissecting and excising it completely free from the cord. That is a plane of tumor arachnoidal and pial. Usually they get thickened due to the chronicity of the tumor. That is the one route which the maximum blood supply is coming, probably the C7 route, which was non-functional, along with the angioma. The whole route is also sacrificed and taken out completely without preventing the recurrence in future, along with the dentate ligament. That's a route, and that's a patient post-op angiogram, perfectly normal, no residual tumor. Dermoids and epidermoids. Again, we believe in complete total excision. They are well capsulated lesions inside the arachnoidal plane. Open the arachnoid very well, proximally and distally. Somehow we are not in favor of minimal access neurosurgery for spinal cord tumors. We always excise proximal and distal, expose them well, and take out whole thing in one piece or piecemeal and take off completely. That's the epidermoid, taken out completely without touching the spinal cord. This is the dermoid inside the spinal cord and going out laterally. Open the cord and enter it, and you can see the hair there, and dermoid, the calcium and some of the teeth, part of the calcium and teeth which were inside. Take out completely. Majority of the time, these dermoids, the medial wall, we may not be able to excise because this is inseparably fused with the spinal cord. We may cause a damage. As much as possible, when it is coming, you take it off. A large arachnoid cyst, cranospinal arachnoid cyst, parietal layer and visceral layer is excised under high illumination and magnification. Whole cyst wall is taken out. That's the anatomy we see at the end of that. Hemangioblastomas, intradural, you saw the just now presentation. They are like an arteriovenous malformation. Start from the periphery, identify the cleavage, and there may be proximally distally cystic space. Enter that. Don't coagulate any vessel away from the cord. Completely excise. This is the patient who came to us from Mozambique, and with the hemangioblastoma, complete excision. That's a tumor completely, and that's a post-operative scan. Now, neuroenteric cysts, that's what I was mentioning you just now. The anteriorly cervical cord and thoracic cord, when you see them, they are anteriorly situated. We may open the dura in a T-shaped fashion, and the cyst is attached anterior to the spinal cord, and it is inseparable. And the high illumination and magnification, dissect it slowly from the anterior part of the spinal cord and excise it completely, and always have the histology in these cases, and you can reconstruct the dura with the musculofacial fat. Another neuroenteric cyst, cervical, and excised completely with the cyst wall and the contents. That's a cure where the patient will not have any recurrence. This is a cerebellar metastasis intradural lady, girl we operated for medulloblastoma, came with weakness. You can see the complete excision and complete recovery of this in this metastasis if you recognize and intervene early. Well, friends, we have complications. Majority of the time, if you do many cases, we do have complications. We need to understand them and treat them accordingly. We had about 8 deaths in these cases, in 1,200 cases. Majority were due to infection. And apart from that, medically associated, like associated diabetes mellitus and pulmonary embolism, chest infections in high cervical regions were the most common causes. Well, friends, majority of the intradural spinal lesions are benign. We must understand that. And they can be treated completely and excised completely. Microsurgical techniques are extremely useful in these cases. All these lesions can be taken out in one piece applications of biomedical infrastructure is invaluable for the better outcome. Preoperative poor neurological status doesn't matter for the good postoperative outcome in majority of these lesions, and one must be very aggressive in treating these lesions. Excision in total, many of the people here may not agree with me, but last 15 years we have been doing it, and practically quick, fast, no damage and no blood loss. Prevents injury to surrounding neurovascular structures. Roots can be followed and preserved completely, and you can preserve the mother root in few cases. Prevents blood loss. Plane of cleavage will never be lost. Procedure becomes faster and outcome is good. Thank you very much. I'm sorry if I've taken little time.
Thank you very much, Dr. Suresh, for your excellent presentation along with video. Over to the audience, please.
Thank you, sir.
There is no posterior root, but see.
Yes. When you do on the lateral aspect, first what you do in a dumbbell neurofibromatosis of C1, you decompress outer one first. There you'll see the one of the fibers going out into the intervertebral fiber between C1 and C2. That is the mother root. Intradurally, I very much agree with you. We may not be able to identify intradurally. So,
Correct. But I ligament, it gets attached to the above the entry of vertebral artery.
True.
So unless you sacrifice that, you have no access to the first ventral root.
True.
And spinal accessory is between the first dentate ligament and vertebral artery. Vertebral artery, dentate ligament, and behind that is the spinal accessory.
True.
So you have to sacrifice the first dentate ligament to get into the first root.
I very much agree with you. No doubt about it. I mean, what you said is very true. But here what happens is, we don't open the dura in the midline. It is laterally. Open the arachnoid. What you're taking out, you don't know. But tumor comes out with the capsule, that's it. Finished.
So what is the CSF leakage rate in your?
It is
so
there.
you told that you open the dura T-shaped even anteriorly and you excise for meningiomas, duras and muscle patch you put. Are you stitching all these things or just keep it a patch and then leave it?
Many times we use a musculofacial graft. If the dural defect is larger, you stitch it. If it's a small one, you plug it. And you can use a tissue seal or tissue fabric glue, fibrin glue, just to cover it. And if the surgery is clean, quick and fast, see, the most important we must remember here, if the patient develops a postoperative CSF leak, it is not due to surgery, it is due to infection. If there is no infection, especially in many of times large intramedullary spinal cord tumors, we excise and leave the dura open because we feel that there may be some swelling and cord may swell up and may have bleeding. No CSF leak. So many a times, if there is a postoperative CSF leak, you must consider the postoperative infection. If in the small cases, you just keep a graft, big cases, suture it. And if the leak occurs, you put a lumbar drain for about 3 to 4 days, and invariably it stops. And you will, at the same time, you'll have CSF analysis. If there is an infection, you treat it accordingly.
So then we'll
Thank
go on to the next paper. Abhiram is not there. Then we'll go for Dr. T. Pratap Reddy, SBRT in spine.
Good evening, everyone. Good evening, everyone. At the outset, I thank Dr. Manas giving me this opportunity to be with you. I'm a radiation oncologist. I'm in the galaxy of the single person, in the galaxy of the surgeons. I'll be talking on stereotactic body radiation therapy, SBRT. The spinal metastasis occurs in 20% of all patients with cancer, with 5 to 10% of patients developing spinal cord compression. The treatment of spinal metastasis, even though it is a palliative, with the goals of providing pain relief, maintenance or recovery of their neurological function, local durable tumor control, and spinal stability and improved quality of life. Although the conventional EBRT palliates the pain and or the neurological symptoms, the dose delivered is not adequate for long-term control with the conventional external radiation. Over the past decade, treatments have evolved from the surgery or simple conventional radiation to complex multimodality new technologies such as stereotactic body radiation therapy. SBRT is increasingly used in the management of metastatic spine tumors due to close proximity of the spinal cord to the treated volume and the potential severity of the radiation-induced myelitis. The spinal cord is the primary dose-limiting organ at risk for delivering high radiation. The safe delivery of the SBRT requires the use of high-resolution planning CT scans and planning MRIs and IGRT image-guided radiation facility and patient repositioning technology during the treatment delivery. The dose that is given per fraction is 5 gray or more than that, and the number of fractions in SBRT is the fractional dose is 5 or more gray, and the range is 5 gray to 34 gray per fraction per treatment, and the number of fractions are 5 or less than 5, and the range is 1 to 5. When a patient comes with the spinal metastasis, how to decide whether the patient should go for the radiation or should go for the surgery? So for the decision of optimal therapy for spine mets is based on a NOMOS framework. NOMOS is the neurologic, oncologic, mechanical, and systemic decision framework, which is used at Memorial Sloan Kettering Cancer Center to determine the optimal therapy for patients with a spine metastasis. Neurologic is an assessment of the degree of epidural spinal cord compression, myelopathy, and or functional radiculopathy. The oncologic is the expected tumor response and durability of responses to treatments such as regular conventional radiotherapy, SBRT, surgery, chemotherapy, or immunotherapy. Mechanical instability is a separate consideration defined for pathologic fractures. And the fourth one is a systemic disease extent of the patient to tolerate the treatment and overall expected survival. The neurologic assessment is done by a 6-point grading system by the spine oncology study. The group uses T2 weighted images at the site of most severe compression to describe the degree of epidural spinal cord compression. 0 is the tumor confined to the bone only. 1 is a tumor extension into the epidural space without a deformation of the spinal cord. 2 is a spinal cord compression but CSF is visible. 3 is a spinal cord compression without CSF visibility. Again, grade 1 is divided into A, B, C. 1A is epidural impingement but no deformation of the thecal sac. 1B is a deformation of the thecal sac but without a spinal cord appartment. 1C is a deformation of the thecal sac with a spinal cord without deformation but without compression. Coming to the oncologic assessment, At present, radiation is the most effective and least invasive modality for local tumor control. Tumors are considered to be radiosensitive or radioresistant based on their response to conventional radiation. SBRT with image-guided radiation can deliver high doses of radiation in close proximity to the spinal cord while maintaining the radiation exposure of the spinal cord. Lymphomas, seminoma, and myeloma are radiosensitive histologies. Radiosensitive solid tumor histologies include breast, prostate, ovarian, and neuroendocrine carcinomas. Renal, thyroid, hepatocellular, colon, and non-small cell lung carcinomas, sarcomas, and melanoma represent radioresistant tumors. Depending upon the sensitivity, the treatment decisions will be taken. Patients with radiosensitive tumors may be treated with conventional external beam radiation regardless of epidural spinal cord compression and grade. Radioresistant tumors and ESCC, that is epidural spinal cord compression grades 0, 1A, 1B can be treated with SBRT and do not require surgical decompression. Radioresistant tumors and ESCC grades 2 and 3 require surgical decompression and stabilization prior to SBRT. Radioresistant tumors do not have acceptable response rates to conventional radiation, hence the need for the SBRT. The ability to deliver tumoricidal radiation doses safely and effectively with SBRT to gross residual tumor volumes has changed the goals of surgery. Durable local tumor controls with postoperative SBRT obviates the need for extensive tumor resection. Currently, in place of maximal tumor excision, surgery only needs to provide separation between the tumor and the spinal cord to optimize the delivery of SBRT. What is a separation surgery? The term separation surgery is in which only a minimal tumor resection is carried out to separate the tumor margin from the spinal cord, leaving the bulk of the mass to the treated radiation. If the cord is away from the volume, the less dose can be given to the spinal cord. Coming to the mechanical assessments, mechanical instability represents an independent indication for surgical stabilization. SINS is a spinal instability neoplastic score. It uses 6 parameters: the location, pain, alignment, osteolysis, vertebral body collapse, and posterior elements involvements. SINS scores with 0, 6 are generally stable and do not require surgical stabilization. SINS scores with 13 to 18 need a surgical stabilization and restore spinal stability. Intermediate SINS score 7 to 12 requires further assessment to determine the need for surgery. This is the spinal instability neoplastic score, how they are calculated. If advanced disease precludes any surgical intervention, radiation can be administered even in significantly advanced stage. The doses that are prescribed with the SBRT are, if it is single fraction, typically it will be 16 to 24 gram. In 2 fractions, 20 to 24 gram, and in 3 fractions, 30 to 36 gram, and in 5 fractions, 50 gram. That's the dose given. So this is a high dose. In the conventional treatment, a 300 centigrade will be given, but with the SBRT, very high dose is given. The techniques that are used for the SBRT, the intensity modulated radiation therapy or the VMAT Rapidoc, both should have a facility with the image guided radiation therapy, that's IGRT. This is the framework that is used for decision making. I'll just show 3 cases how the decision is taken. The case 1 is a 74-year female with metastatic EGFR positive non-small cell lung carcinoma presents with a worsening back pain. Imaging reveals metastasis involving T7 vertebral body with extension to the right pedicle. So this is a low-grade ESCC, no myelopathy. It's a radio-resistant tumor. And then again, we need to see the SINS scoring. This SINS scoring in this one is 0 to 6, that is stable. So this patient is a low-grade ESCC, no myelopathy, radio-resistant tumor and stable. The patient can go directly for the SBRT. So this is the dose distribution. So the spinal cord, which is in green color, is nicely spared from the high dose radiation. Coming to case 2, this 64-year male Cancer prostate patient developed solitary lesion at L3 with epidural extension. This patient is a high-grade ESCC and radio-resistant tumor, so patient can go for separation surgery and SBRT. So this is the dose distribution. Again, the spinal cord has been nicely spared with a high dose. Coming to case 3, 67-year male metastatic renal cell carcinoma with a lower back pain and 1 week of progressive lower extremity weakness. MRI shows a mass lesion with epidural extension and cord compression at T2, T3 level. So this is again a high-grade ESCC, radio-resistant and unstable situation. So the patient has to go for a stabilization followed by conventional external radiation. So this is how a debulking and a stabilization is done. And the patient receives about 30 gray in external radiation with 10 fractions. Thank you all.
Any questions?
Hi, sir. Lovely talk. Thank you. I have two questions, sir. One is, what is the minimum distance that you're comfortable irradiating spinal tumor? So basically, how much do we need to separate if we're doing separation?
3 millimeters. 3 millimeters.
3 millimeters. Second question is, do the implants interfere with radiation planning? Because I know that in some countries in the West, they've started using carbon fiber implants, which do not interfere with imaging. So is there an issue with the titanium implants that we use in terms of radiation delivery or planning?
No, it will not have an issue.
One more thing. Intramedullary, especially in conus. So single fraction, 5 fractions.
Depending upon how much dose is going to the card, it can be 1, 2, or 3, or 5. So how much volume of 0.03 cc of the spinal cord is getting? If it is more in one single fraction, then you will be choosing next 2 fractions. If still it is more, you can go for 3. Like that. How close it is to the card, how much dose is going to the card, on that one, the number of fractions will be decided.
Thank you very much, sir. Excellent information.
Thank you.
Just would like one more point I would like to add. Of late, we are using intraoperative radiation, intrabeam 600 with the linear accelerator. All these lesions on the table, we are giving the radiation, calculated dose by radiotherapist, and bringing them out. Majority of the metastasis and malignant lesions.
That's with the external radiation, or
External.
you put you have a facility in the room itself, the external radiation?
The equipment is the size of the operating microscope. It is wheeled in the OT, calculated radiotherapist.
Yes, if that facility is there, yes, you can do.
We are doing that.
Yes, definitely.
Spine,
Spine also.
spine as well as brain, both.
Yeah, anyway.
And the issue here is majority of the metastatic spines and brain metastasis, one radiation is enough. You don't have to subsequently, depending on the nature of the tumor, you can follow it up. But the literature presently available shows one radiation, even brain also, one radiation.
Yeah, it's the same. It is available some institutes. So you can push more dose because you are just concentrating. That's intraoperative radiation, because you are confining only to that local area.
That's right.
If you are using external radiation, some part of the normal spinal cord will also come into the picture. So that is definitely more helpful.
That's right.
That's a new technology that is coming up in some institute, not in every. Yes, agreed.
GBM, yes, we need to follow up with the radiation. Metastasis, more commonly metastasis. Maximum one. See, issue here is you give SRS or you give a conventional radiotherapy for 40 days, 30 days post-operatively. And you wait 1 week to 10 days post-operatively to start the radiation. But here, it's the same thing, a linear accelerator, where intraoperatively, the dose calculated by the radiotherapist, he's in the OT, gives 20 gray to 40 gray at a time in the same sitting with the whole tumor bed. So the literature wise, now still long way, another about papers, yes. 9 centers, ours is one of the center which are included in the research through the Gs, where the long-term results have to be there. But present availabilities recommendation is already come, especially in breast CA.
Yes, I'm about to say it is similar to the brachytherapy.
Thyroid CA,
It
breast
is
CA, head and neck CA. One radiation like maxillary carcinoma, tongue carcinoma.
no, for
mandible.
those areas it is still not used, but for the
What
spine, breast, those areas, yes.
breast. Breast surgeons believe that didn't work, and they stopped using it, and then they came to brain surgeons. So are we getting trapped like that? Because there are not many papers supporting that just intra one radiation will be enough, except metastasis. In GBM, though, it is not worked. So you still have to follow up with radiation.
Yes.
So that is why actually we didn't buy that,
Yeah.
because breast surgeons did not support.
No, I'll tell you.
Yeah.
Especially high-grade gliomas and GBM, I agree with you. We need to follow by another full dose of radiation, but not 30 days or complete 45 grays. We can come down to 20 grays in GBMs and malignant gliomas also. You can reduce the dose post-operatively.
No, definitely we agree with
Only
you,
thing
but still it no, it can be used if you have the equipment, you can use there like you can do a brachytherapy or that kV voltage this thing is with. But some people are using for the brain and spine, but still it is not standardized. They are not using, they don't know how to use it properly, but it can be used. Avoiding the boost. So you need to give the whole breast radiation and then the boost. If you are doing intra-operative radiation, you can avoid that boost. The cosmosis will be better. If somebody can use it properly, yes, it can be. But for the brain and the spine, it is still not standardized.
Regarding SRS for the spinal tumors, how many doses normally you can give? And like you have got a, for the cranial case, you have got a mold. Similarly, what sort of mold you make for giving that? Whether there is mold or what is the system on which you give? That's one.
I didn't.
Coming to this second
I didn't
part,
get you, sir. Can you please tell me?
spinal, how you are giving SRS for spinal tumors? What method? Like for
The primary spinal tumors.
For primary spinal tumors or diagnosed spinal tumors, how you'll give? Number one is like you have got the SRS you can give by mold or by stereotactic frame. These days, true beam when it comes, you need not put a stereotactic frame on that. You put a mold, and it is either single dose, 2 dose, up to 5 doses known as SRS. Now for spinal, how you are giving? Your topic was spine. That is why I'm asking how you are delivering SRS for spinal tumors. That's one. Second, coming to his point that why for benign tumors also the SRS cannot be given, or single dose radiotherapy, what is the equipment is coming for benign tumors where you know that you could not excise totally or decompress totally, why it cannot be given other tumors? Besides glioblastoma, of course, that is different, but other benign tumors also, when there is residual tumor, this also can be given. Just your
Initially, the SRS term is used for both for the cranial and the spinal. Now SRS is limited only for the cranial, and the SBRT is the term that is used for the spine. That's one thing. Like you need not use a stereotactic frame for the brain also. You have a fixation will be there because of the image guidance nowadays. The fixation is not required for the regular treatments. If you are doing some single treatment with the gamma knife, maybe sometimes you can use. The same way, yes, definitely the patient positioning is a very, very important part of the treatment. So you can use a vac lock. There will be some a flow, something like, I don't know exactly how it is made, but you can fill with the air and the patient can lie down on that one. It will become stiff to the patient and the same position will be maintained every day. That is one. In addition, again, you can put an immobilization on the patient and then every day before you do the treatment, you will be doing an image guidance. Without image guidance, you cannot do. So if there is any small change of the patient position compared to the planning CT that is acquired or the planning MRI that is acquired, if there is a difference of the patient position there, you adjust on the table itself so that you will be delivering the precision radiation. Coming to the benign tumors. The benign tumors, they live for a long survival. So most of the times the regular fractionation is preferred, but sometimes, yes, definitely where they are suitable, Suppose schwannoma is there. If it is much away from the spinal cord, yes, you can do the limited fractionation 1, 3, or 5. Depending upon the situation, you can take a decision.
What is the difference in means radiation planning or giving the choice of radiation ependymoma of the brain and spine? Brain and spine ependymoma. So when do you suggest radiation and in spine, and when do you suggest in brain?
Brain ependymoma grading into grade 1, 2, and 3. Grade 1, if it is a complete excision, you can avoid. Grade 2 and grade 3 are definitely required. In the spine, if it is not a complete excision, yes, you have to give the radiation. Whether it is a spinal or brain, again, you need to evaluate the completely, whether it is confined only to the spine or whether it is confined only to the cranium. You need to evaluate with the imaging of the cranium and the spine, and also with the CSF. That with that you will be knowing whether it is a solitary lesion or a metastatic lesion. That is one. And coming to that decision, once you know that it is confined only to the spinal cord, you will be giving local radiation only to the spine. And if it is supratentorial ependymoma and there is no extension, or even infratentorial also, if there is no extension anywhere, you can just do a local radiation rather than a complete CNS, the craniospinal. There is no need of doing a craniospinal. Is that correct?
We'll move on. Thank you.
Okay, thank you all.
Next, Dr. Deepak Das, preserving spine in spinal cord tumors.
A very good evening to all of you. I will be presenting my case series, how I preserve spine in short series of 24 cases of spinal cord tumors, be it intramedullary or intradural or extradural tumors. This is a timeline showing how the spinal cord tumor excision has evolved from Dr. Hersley in 1887 to up till now. When it was started on open eye surgery, it has gone into the microscopic excision, and now is with the help of endoscopic excision of spinal cord tumors. This is my past case. This patient presented to us with spastic quadriparesis, and as we can see, the tumor is in the T2 level and little bit higher up. So I exercise this case in a and we can see the tumor. It's a dumbbell tumor that gone through the T2 foramina. So I exercise it through a small hemilaminectomy on the left side, and I could completely excise the tumor, and we can see the post-op MRI pictures showing the complete excision of the tumor and the improvement in the post-op period. He was completely recovered from his paresis. And the next case, this patient presented with spastic paraparesis with bilateral lower limb power 4 minus by 5, and she was having a tumor at the D10-11 level, and it's a tumor in the right paramedian area in the spinal cord. So this patient was exercised in that hemilaminectomy approach. It is a short hemilaminectomy approach in the right paramedian. This small hemilaminectomy and excised the tumor. That was a intradural arachnoid cyst that was completely excised, and postoperatively she also recovered very well. And This is another case. She presented with again with spastic paresis, and he was not able to stand properly, and we can see the tumor in the D7, 8, sorry, D11, 12 level. It's a T2 hypointense mass, and it's also a little bit enhancing, and the tumor is lateralized on the left side. So again, I went for the left hemilaminectomy approach, and I could excise the tumor, and this is a extradural tumor. Extradural tumor completely excised, and it came out to be a solitary fibrous tumor. And the patient improved well, very well after surgery, and could able to walk without support after surgery. This is another case. He presented late to us, and he was completely quadriplegic with upper limb power in each 1/5 and lower limb power was almost 0/5. And this is the you see the tumor extended from C2 to C7 level. It's a large tumor, and with rostral and caudal syringomyelia, and the syringomyelia has gone up to the beyond the foramen magnum on the rostral side. And this tumor also little bit lateralized to the right side, we can see. So again, I went for this hemilaminectomy approach on the right side, and I could do the myelotomy, lateral myelotomy, and I could excise the tumor completely. I could find a plane between the tumor and the, it's an intramedullary tumor. I could find a plane between the tumor and the spinal cord. I could achieve the complete resection through this small hemilaminectomy approach. We can see in the post-op MRI picture, I have completely excised the tumor, and it's a 4-level hemilaminectomy, right side hemilaminectomy approach, and this came out to be anaplastic ganglioglioma, and we can see the result in the day 1. He was able to little bit move his upper limbs, gradually gained his power in both the upper limbs and lower limbs, and when he's discharged, the power is improved to grade 3. This is another case. She's a 35-year female homemaker presented to us also in a very late with both upper limb powers 0/5 and lower limb power 1/5, and we can see the extent of the tumor. It has extended from the foramen magnum, above the foramen magnum, to the C7 level, almost C5, C6 level. And this was also lateralized to the left side, little bit lateralized to the left side. But this time it was it's a very long segment tumor. So I thought of doing it's a skip hemilaminectomy approach on the left side. And I have preserved this C2 vertebra completely, C2 spine completely, and taken out skull base little bit, and C1 on the left side, and C4 and C6, part of C6. And gradually on the deep hemilaminectomy approach, we can see the intervening spines, laminas are preserved, and I could able to excise the tumor. And this is the post-op MRI picture showing the complete excision of the tumor, and the intervening laminas are preserved, and only part of the lamina on the right side was taken out. And this is the follow-up we can see at day 4 and at 1 month, 3 months, and at 6 months, was completely regained his power in both the upper limbs and lower limbs. And she has also gained some weight after 6 months. So I did a literature review. Also, the literature also supports the same idea. This can be done, and with same results and with same safety manners. as the conventional laminectomy with fixation or complete laminectomy, and it is also can be practiced in a safe manner. So to conclude, complete removal of the lesion should be our goal, and this approach is a safe approach to all kinds of tumor, be it extradural IDMs or intramedullary tumors, and it's an nice option when versus an additional procedure of fixation. Particularly in patients, they are not affording the fixation equipments, fixation additional procedure. Thank you.
Thank you, Dr. Deepak, for a very good presentation. Over to the audience, please. Sir.
Nice work, Deepak. Enjoyed the talk. But few things for intradural extramedullary lesions, we can do all fenestration, hemilaminectomy, and all those. But somehow for intramedullary lesions, doing a hemilaminectomy, I mean, I'm not very what you call convinced and not courageous to do that. Number one. Number two, in the same scenario, you want to save the bone, you can do laminotomy, extensive laminotomy, expose on both sides, be comfortable and safe to the patient, excise the intramedullary lesion. That's my perception. After doing 240 cases, I wouldn't do hemilaminectomy or hemilaminectomy for intramedullary tumors.
Sir, in intramedullary, it is very selective only.
A lateral myelotomy, which also should not be done unless patient has a, because tumor can involve the root and the glial tumors, astrocytomas, they can come out through the root and zone. So if a patient has useless hand, you can do a lateral. Otherwise, that is also not advisable. You have to do a midline myelotomy.
That has been done only in cases where it is actually it's localized and very much surfacing. Otherwise, it's always a midline myelotomy.
And one more last. In your cases, have you done any fixation?
No, no, sir. In this series, I
In
have
this
not
series,
done any fixation. Only to avoid fixation.
Thank you. I invite Dr. Sumit Raj.
So good evening to all. Namaskar. So today I'll be presenting the characteristics and treatment outcomes of intramedullary spinal cord tumors, a case series. So as you all know, intramedullary spinal cord tumors account for only 4 to 10% of all primary CNS neoplastic lesions and 20% of all spinal cord tumor in adults. So these causes disability and severely affect their quality of life. The patients suffer from weakness, sensory disturbances, sphincter abnormalities, eventually become significantly disabled and sometimes may even die. So ependymomas and astrocytomas are the most common intramedullary spinal cord tumors, followed by hemangioblastomas, and the other entities include lipomas, germ cell tumors, gangliogliomas, germinomas, lymphomas, and metastases. Multiple studies have evidence that aggressive resection increases the overall survival of the patient, and earlier the radical resection of intramedullary tumors is performed, the greater are the chances of preserving the patient's neurological function. So we did a retrospective observational study of the data who had gone under surgery from January 2019 to June 2024. So all the patients were consecutive patients were included in this duration, and the recurrent cases and the patients with incomplete records were not included in this study. So total of 26 patients were included in this study. So the patient's data, including age, gender, symptoms, tumor size and location, pathology, extent of resection, neurological function status, and follow-up outcomes were recorded. So we use modified McCormick scale and that is used for grading of the neurological status of the patient at the time of admission, immediately after surgery, post-op after 1 month and 3 months interval. So this is the modified McCormick scale. So the surgical technique, as you all know, so we put the patient prone under GN, midline posterior approach is followed, and usually we perform laminoplasty for the all long intermedullary segment tumors. Even for short segment also we usually do laminoplasty. It doesn't affect the spine. So an effort is always made to preserve the posterior tension band, that is to preserve the spinous process, interspinous ligaments, ligamentum flavum of the laminoplasty segment. And the gross total resection is attempted in all these cases, and the GTR is defined as more than 95% of the removal of the tumor. The subtotal resection is defined as 80 to 95% resection, and the partial resection is defined as less than 80% removal of the tumor. We usually do a water kite closure of the dura in each and every case. So here are the few cases. This is my first case of a 38-year female which presented with bilateral spastic paraparesis and the retention of urine. So here you can see a tumor from C6 to D1 intramedullary tumor for which a C5 to D2 laminoplasty was done and the gross total resection was achieved. So here's the intraoperative video. You can see we follow the routine steps. This is the bipolar coagulation in the midline followed by the midline myelotomy. And this is the tumor dissection. And here you can see I could get the plane. So finally excise this tumor completely. So here is the tumor resection and hemostasis is achieved, followed by the pile sutures. So this is the histopathology that came out to be a tuberculoma. So the patient was started on ATT, and this is the post-operative follow-up after 3 months. So here's the patient whose spasticity has totally gone, and the patient is doing well. So now this is my second case of a 12-year-old boy which presented to my OPD, and he was limping at the time of presentation. So MRI suggestive of D6 to D8 intramedullary SOL, for which D5 to D9 laminoplasty was done and the gross total resection was achieved. So here is again the intraoperative video, same we do follow the procedure, bipolar coagulation followed by midline myelotomy. Here you can see the pearly white tumor coming out of the cord. The complete tumor resection was done. GTR was done, followed by the pile sutures. Now this is the third case. Sorry, this is the post-operative images, and you get here you can see the complete total removal of the tumor, and the histopathology confirmed the epidermoid. And here is the follow-up after 1 month. So the boy is now not limping and moving fine. So this is the third case, which was a little rare case. A 23-year-old female presented to the OPD, and she was almost quadriplegic. The upper limb power was 1/5 and 2/5 in upper limb, and lower limb was 0/5. So MRI suggests, and she was significantly scoliotic. Hence, I cannot show the complete MRI image in one picture. So the MRI suggested of cervicomedullary junction to D11 intramedullary region, for which a foramen magnum decompression was done, followed by C1 posterior arch removal and C2 to D12 laminoplasty. And finally, gross total resection was done, and the histopathology came out to be an ependymoma. So again, this is the intraoperative video. Here you can see same bipolar coagulation midline myelotomy. Initially, I could not find a plane, but gradually, slowly, when I tried, I could find a plane. So finally, I tried to remove the tumor completely, decided to remove it completely. So here is the complete tumor removal. Here you can see the serpent coming out from the cord. So here the tumor is removed completely. Here you can see the complete spinal cord from the cervicomedullary junction to D11 level. So this is the intraoperative image which came out, which is around 44 centimeters long, probably the world's longest tumor. Because before this, Zhang et al. Reported in 2021 that the longest intramedullary tumor was of 33 centimeters in length. So this is the post-operative image where you can see the complete tumor is removed, and he is the patient. She was initially quadriplegic, but gradually increasing the power. So we are mobilizing her. So this was the case for last case, D9 to L5 intramedullary tumor. Again, complete resection was done. Intraoperative neuromonitoring we use in few cases because we are fighting with the neurophysiologist to come to our OT, which is very difficult to find out. Sometimes we get it, so we use it. So again, this was a 24 centimeter long tumor. Again, you can see the complete removal of the tumor. There's no tumor left. And this is the laminoplasty image, and which is maintaining the spine alignment. This is the post-operative video of the patient follow-up after 7 days and 3 months. So coming to the results. So in our study, 9 patients were less than 18 and 17 were more than 18 years old. 16 were male and 10 were female. And the pre-op MMS scale was less than 3 in 50% of the patient and more than 3 in 50% patient. Most common location was thoracolumbar in our study, which is comparable to the other studies. The extent of resection was 73%, which is again comparable to the other studies. And histopathologically, ependymoma was the most common tumor. And post-op MMS was less than 3 in 84% cases and more than 3 in 4% cases, which is a good improvement scale. Coming to the discussion, we conducted a retrospective observational study, including 26 patients over a 5.5-year periods of time, and to determine the correlation between the pathology of intramedullary tumor and perioperative neurological status with improvement in the neurological outcome on gross total tumor resection, and compared results with other studies conducted at different times.
Thank you, Dr. Sumit.
So
for your
sorry.
excellent presentation.
The end button, I mistake came out. So this is the comparative analysis of our study. So again, here you can see the while comparing with the other studies, I can find that ependymoma was the most common tumor in other studies also, as well as in our study. The extent of resection was again comparable to the other studies. The improvement in neurological outcome was better in our study. Maybe our study patients are less in number. Probably that is the reason. So to finally conclude, thoracolumbar is the most common location. Ependymoma is the most common pathology. Preoperative neurological status has an impact on postoperative neurological outcome. Aggressive surgical resection should be optimal strategy even in extensive tumors if possible. GTR improves the neurological outcome. Laminoplasty is a useful technique to preserve the spine curvature, sparing the facet as I already mentioned, and to preserve the posterior tension band. CUSA is a bone. So I have not shown CUSA in these cases because I could find, but there were cases of invasive intramedullary tumors where we routinely use CUSA. INM, as I already told you, sometimes we get the help of neurophysiologists, then we use it. Sometimes we don't get. So few points to remember. Always secure pressure point. That is an important thing. Maintain the body temperature during surgery. Long surgery, patient can land up with hypothermia and can cause problem after the surgery. DVT prophylaxis again is very important in long cases. Most important, if you need to take a short break in long cases, you can take a short break, start with a fresh mind. That is very important. I usually take it. Post-operative aggressive physiotherapy, but in a controlled manner. So always have a discussion with your physiotherapist. Counseling of patient SOS, even if a psychological assessment is required, because these patients who are quadriplegic, paraplegic, these are sometimes mentally sick. So not sick, I would say, but sometimes they need a assessment from the psychology or psychiatrist. So whenever needed, you can take your help of a colleagues. If you want to take a break in a long surgery, you can call your colleague that please come for a while and help me out so that I can take a break and come back and operate this patient. Ego should not come in your operative decision making, that I have to remove it completely. Sometimes you may or sometimes you may not remove, but it should not be an ego that I have committed or I have said, so I have to remove. That is an important thing. These are my references, acknowledgement. Thank you for your patience.
Thank you once again. Yeah.
Can I just congratulate him? Sumit, that was an excellent talk. I had also worked in that place for a few months, couple of years, and excellent work, Sumit.
Thank
and
you,
we have taken it forward.
Your
And
guidance,
let
you are
me
the
ask
mentor.
one question to Manas and senior people, Dugani and all. Has anyone operated on rubbery intramedullary tumor? Let's say astrocytoma, rubbery, where you go in, you cannot take out anything, like a rubber. So have you seen that? You have not. You have seen.
That biopsy report turned out to be subependymoma. It was rubbery with no clear plane of cleavage, and we did subtotal resection. They have a good prognosis. We did not give no adjuvant therapy, and the ladies on follow for almost 10 years without progression.
The point I am making, if we cannot remove, say we can leave and we cannot make a good decompression, you can leave the dura open and come.
Yes.
So that let the tumor grow.
Yes.
Understand? You have done that, leaving they leave the dura open. Yeah. Yeah.
Sir, I have done 2 cases long segment where almost from D2 to almost D12. So we just, I have opened the dura, did a duroplasty, left it. That's it. Yeah.
Other question?
Over.
Thank you so much.
Particularly in last two cases, you mentioned that intraoperative monitoring. In what way in the last, in small, limited segment intramedullary tumor, it's okay, but in those last two cases,
Again, it
how
is
will an intraoperative monitoring will
usually
help?
of no help. I would agree.
Yeah, it will not help.
And we don't even get the help. As I told you, the
Yeah.
neurophysiologist professors are there, so we have to call them, and we have a neuro monitoring device. But again, to connect it and to follow, we need a good team of a neurophysiology, which is a little difficult for us. So only in few cases I could arrange. Otherwise, for example, in the second last case, that the long segment tumor, it's of no use, I think. And the seniors may guide.
If I can rephrase the question in a different way, you are doing a small intramedullary tumor.
Okay.
You are monitoring all SSCP, MEP, D-wave also monitoring. In between, you lose MEP. After some time, you lose D-wave. What will you do?
This is a question of debate, actually.
Yeah, it's a debate.
It's
Maybe
a question of
seniors level
debatable
can
which
answer
what
what
the senior can
If the
answer.
going is good, continue. So if
So
it's
because I had a case, in fact, in this case, on the last case, I would agree that we had lost the wave and all. So it was again a question whether we should continue or we should wait to the monitoring to continue to start, or what to do. So finally, I decided to remove the tumor. In fact, even the waves were gone. So but the patient
patient
outcome was
involved also, no?
patient
False
improvement.
positives, false negatives can be there.
Yeah, it can.
Yeah,
That is why you need a good neurophysiologist.
Absolutely.
It is important. It is not the fault of the machine or the physiologist. You need a good neurophysiologist team. Pre-operative assessment and the intraoperative assessment. That is most important.
Thanks.
You asked a question about what would you do in these IONMs. See, IONM present day, there are a lot of controversies going on.
Sure.
Many people now they're not for IONM in extensive lesions, especially AV malformations and hemangioblastomas, because they lead to improper and incomplete excision of the lesion in these cases, number one. Number two, you need an extensive setup, infrastructure, and a very trained and qualified neurophysiologist. I have done many cases in this, but till today, I can never interpret the things. And you depend on somebody to do that, number three. The most important issue here is not the IONM. You are seeing the tumor there. That shows the block, complete absence of the D wave and T wave. The tumor is there. Take it off. Doesn't matter. But don't leave the tumor and come out just because your MEP is absent. Don't do that. Number one. Number four. See, the IONMs depend not only on your surgical skills, your suction, bipolar, CUSA, operating room temperature, blood pressure, oxygen saturation, and patient's age matter a lot for IONM. So that is a big controversy about IONM, but best is your own technique, technology, your own perception, and what you are seeing in front of you. If there is a tumor, don't leave it. That's it.
That's what I told. Poor monitoring is worse than no monitoring. But there is
Yeah.
no hiding the fact Sumit is a world record holder.
Oh my God.
For the,
Sorry, sir. I mean, if if the MEPs come down below 40%, definitely I will wait for about 10-15 minutes so that with the BP and everything proper. And if it comes back, then we can go ahead. Otherwise, I think we better leave it at that.
Long segment tumor in patient has total paraplegia, quadriplegia. I don't think it is useful to have a monitoring in these kind of the cases. So in our setup we are
In fact, in
never
that
using
case,
in
I
these
discussed
kind
with
of
my neurophysiologist, and she said that it is not worth it to go for neuromonitoring. You can
yeah,
continue with your
that
surgery
is
because the patient is almost quadriplegic.
total deficit is there, long segment is there, and then what is used? I don't think it is useful.
It is more important when the patient is entirely preserved.
Yeah.
Then it is more important.
Have you used the monitor?
If you are not use a monitor, you are sued. That's it. That's the only thing more important in this. Here also, now it's coming up. Yeah, that's it. That ultimately it will come to that value rather than anything else. Exactly, sir. That's
Yeah. One
again,
point.
again, this IONM, we didn't start IONM for the younger generation's benefits and knowledge. We never started IONM. IONM was started by orthopedic surgeons. First time to correct kyphoscoliotic deformities way back 30 years back, they started this. We picked up subsequently.
And especially in the intramedullary tumors, both measuring the MEPs and D waves. Generally, what we will say is for MEPs, there is no specific guidelines like how much amplitude or how much latency. What we will say is if there is an absence of M wave and presence of the D wave, just continue to do the surgery. And if both M wave and D wave is absent, so most likely your
Wait for a
power is
while
gone.
and then again.
No, your power is gone. So most likely. So M and D has a concordance. So if both M, myogenic and this D wave, then generally, I mean, if you see some cases like it's actually they come out and doing normally, maybe that is a technical issue or some parameters issue, physiological issue or anesthesia issue, something is like that. But D wave is gone means it's a direct wave, and if it is in the midline and if it is measuring correctly, I mean, because if it goes off, not in the midline, then automatically your D wave will not be measurable. And good neurophysiologist is also need to be examined that. So if D wave is gone, if tumor is in front of you, you have to remove it because anyway you compromise the motor function. So that's what. And the second thing is, so many people are saying that IONM for the legal purposes, but what I saw was like I used like last 10 years. What we are seeing is like there is a lot of difference. I mean, so many people ask, is there a any literature evidence or grade one? So one of the surgeons he used to tell us like you go to 3,000 feet high and jump from that with a parachute or without parachute. It's just an analogy of that. So with parachute, probably you might leave. Without parachute, that's what.
Again, you need to be a trained parachute.
I have to clarify. Okay.
No, but INM cannot be equated to parachute.
That is why it's a little bit
Your
different.
surgical technique can be equated.
Can I clarify a little bit?
Ramon,
Little one I will clarify. Say, if M wave is lost, your patient is definitely going to develop a deficit. But as long as D wave is above 50%, that deficit will improve. That is the thing, you know. So if D wave drops below 50 and M wave also goes means your patient is likely to develop permanent deficit. That is that it is not disappearance of D wave below 50%. That is your.
Yeah. So what I tried to tell is doing a grade one studies, randomized studies. It is very difficult. I mean, without surgical technology, all these IONM or anything, with a bad surgeon, all these are like a fool with a tool is still a fool.
The common thing.
Yes, sir. All these are adjuncts. That's it.
Thank you. With this,
Thank you
we'll
so much.
conclude this last session. I'll hand over.
Thank you, chairpersons, and all the speakers for insightful presentations. Now, we all can get relaxed and stretch your body. We are just done with the second day complete academic ambience here. Now we are just leaving this stage to KIMS alumni meet. I request all the participants, if you wish to stay back, you can stay back. Otherwise, kindly join by 6:30 p.m. now to enjoy the cultural activity by Korea KIMS alumni, followed by the ceremony of inauguration and NSSA felicitation ceremony. Thank you. I request Dr. Sweta to come forward.
All can come to the front. No, don't sit behind.
All the participants,
All. Yes.
please move forward.
Others wants to stay back. We don't have objection, but means others can want to stay means. But all Kim's people come forward. Everybody come forward.
Now I request Dr. Sweta to take over the mic. Madam, please come on.
Very good evening, all of you. Dr. Bhaskarav sir, Krishna Reddy sir, Manas sir, and Dr. Shastri sir. I thank everyone for coming here, and I welcome all of you here, the alumni. You have taken you given time for us, and you came all the way from different places. We are very happy to see all of you here. I hope everyone is coming, joining now. So first, if anyone wants to speak, please, I request Bhaskarav sir to come onto the dais and say a few words.
Very happy to see all of you here. And we started with initially a single man army, Krishna Reddy, then Manas has joined with the group. Manas has built the entire faculty, whoever is here. So I'm very happy to see all of you. I think all of you have been well settled and you have been got all the benefits of experience what Manas has and picked up all the skills. I don't know how many good habits you picked up from Manas. I don't think any bad habits are there. That's why we are happy. So if you would have been continuously picking up and attending all the conferences and building here, and you will be definitely one of the finest, best surgeon, and will be helping a lot more people in the society which are required by all the surgical modalities and all. Now, instead of me talking, I think when you people were there all those 3 years, I would have given a lot of dhyan. People used to say like that. Now I should listen what you got the benefits when we are here. That time will be all the time student life will be a toughest life. Once you go back, then you realize what are all the things that you have been undergone the treadmill has been fetched you. Those who have not undergone the treadmill and they may not be very successful people. That is the story during our students' days. So once you keep saying about your success stories, then all the your bosses and we will be very happy. Thank you for calling me here.
Thank you, sir. Actually, I want to start with me only. I want to share my experience first.
Manas was telling it is a reverse ragging, so you people can come forward and do whatever you want. Now you are.
Because when I came, actually, only few of the people were here. And when I joined KIMS, I don't know anything about neurosurgery. I just wanted to be a neurosurgeon. That's it. From my first year of MBBS, I used to write on my books, Dr. Shweta, neurosurgeon, on my anatomy books. But I don't know anything about neurosurgery. When I joined, actually, I don't know Manas sir or Krishna Reddy sir. Nothing I know. Just simply I've come here. And still, I remember the day when I got the seat. 20 boys were there, and I'm the only girl. I didn't expect that I will get the seat. Um uh, Manas sir and Krishna Reddy sir were so kind enough to take me. Um, and the department was very comfortable, actually. And I never had any problem. And they were all encouraging. They were all encouraging and supportive. It was friendly environment. I never faced any issues. And one specific thing I wanted to share. I had my DNB exam on December 8th, December 7th, and my marriage is on December 8th. And so exam is in Chennai and marriage is in Kagasnagar. It was difficult for me to go. Everybody told that you skip the exam. But only Manasa told that you should write the exam. But I wrote and I passed. I'm very happy for that. Thank you, sir, for encouraging every time. And even my colleagues and everyone, when I am pregnant or like any problem, they were always supportive. I got married during my residency only, had kid, and everything happened in KIMS only. So I'm very lucky to be here. Thank you for everything. I request Krishna Reddy sir to speak few words.
The KIMS experience has always been very good. And from 2004, I have been there with KIMS. And students, when they joined, they all have successfully done, and they have done a good name for us by passing out and doing well outside. The only thing I wanted to tell Bhaskar Rao is that he has forgotten to mention Chandrasekhar Naidu. He is the earliest. He was few months earlier than me when he joined, and I joined in when the actual opening of the institution took place. And it is a good alumni meet, and nice to see all of you here. And hope we'll meet like that. I don't know whether I'll be alive or not, but thank you very much.
Thank you, sir. Thank you very much. Satvik sir, please tell few words because you are one and only senior to me in residence.
Uh, the journey started like this. I finished my honeymoon, then came to know there is a DNB exam, which is usually planned for 1 year, intern DNB exam. So I wrote with a pulmonary tuberculosis, happened to pass. Then the scenario was that if you pass a DNB exam, then you have 2 years time to get. But came to know on 27th April, I have to take seat within 30th. Otherwise, I have to write once again exam. So got up from the bed, booked a ticket in Cochin. There were two hotels, hospital. One is Medical Trust Hospital in Amruta. Then I called up. They said there is one in Yashoda, and there is a new center called Krishna Institute. So gave interview on 29th in Cochin, two places. They said you're selected, you can consider joining. Then through flight from Cochin to Hyderabad, first time I'm coming independently. I never saw Hyderabad. So went to Yashoda in the morning. Then they said you can join, you have to produce your records and these are the fees. And happened to meet a resident there who was from Sholapur, I forgot his name. He said, don't join. I'm in the crossroad. Then he said, KIMS is starting, just go there. In the afternoon, I came. My interview was done by Krishna Reddy sir in that last floor. Then they said, you are selected. But I not having a record of working hard because my MS degree was not that busy. After coming here, it is 36 hours shift is something I cannot forget. And I cannot forget the ICU sisters who used to tell that call that ward by man. We'll shave that Satvik sister so much beer. Such was the thing. And there's no time. There was no time for anything, but we worked hard and every day, everything, we have very beautiful memories. We learned discipline from Krishna Reddy sir because at this age he was so disciplined. And Manas sir, we can write a big thing. We have so many things about him: hard work, thorough knowledge, anatomical understanding, addressing the issue at every level, complication expectations, complication handling, and hats off to each and every of my teachers. And Naidu sir, not to mention, he is a wonderful person. He has different spectrum of thing, which is very, very, very pleasing. And under Talwards, I have been guided to be what I am today. I thank for each and everyone and every person who was there during my beautiful days. You all people made me very, 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 very strong with lot of memories and experience. I thank you. Yeah. Sir, I hail from a place called Shumaga in Karnataka. Recently, around 3 years back, we started our own setup where only it's a purely neuro. We have 2 neurologists, 2 neurosurgeon, and 1 psychiatrist, and in-house CT is there. We are practicing in a smaller ways.
Thank you, sir. I remember when I joined first day itself, I had a night duty without anything. I don't know anything what to do. And there was no WhatsApp actually to send photos. So at that time, I used to call Venu sir in the nights. He used to teach me at 3 o'clock also in the night. I can't forget it. Please, sir, come and speak few words. We learnt a lot from you.
Yeah, for the few people, I'm Dr. Venugopal, like you might be knowing. So though I was not from KIMS initially, I did my neurosurgery with Dr. Manas and Dr. Krishna Reddy. I was from Nizams. When I joined, I was initially Dr. Krishna Reddy was there here and Dr. Naidu was there, and with Dr. Krishna Reddy, Dr. KVL Narsingh Rao, who is the present, he was an assistant, he was here and now he became he was into NIMHANS and recently he moved to Hyderabad now. So he was there, and when he was exiting to NIMHANS, he told me that there was an option here. So then I joined here. So at that time, when I joined here, me, Dr. Krishna Reddy, and Dr. Naidu was there. So I was there with these people. And after I joined, after 8 months, Dr. Manas came here. So at that time, then the neurosurgery department had DNB things, and it started. So initially, when Dr. Satvik was there, and after that, the DNB girl was there. So at that time, when Sweta joined here, the main issue was a girl joined. How can she survive here? And it is going to be a big burden for Satvik. So that was the main thing, and everybody is saying, how will he survive and how can he manage? How can he keep and another main problem with the Sweta is she's short and he's tall, and all the people in neurosurgery are tall. So we had a problem when we were assisting. Our elbows used to used to come to and to touch her. So that's what we had a problem. But we used to tell her that you have to be more fit enough and to handle all these things. Yes, she finally survived all these things and she could do all these things. And after the Dr. Amit has come and we both used to take the neurosurgery department as well as we used to take care of the another hospital was there. So we used to handle a lot of Aragasri cases. Mahavir Hospital was there. So we used to handle a lot of cases. And the main advantage we had at that time was we had a good mentors, Dr. Manas and Krishna Reddy, and we had at that time Dr. Aragasri was there. So we used to operate a lot of cases at that time, and we had in the morning we used to assist cases with our teachers, and yes, in the evening we used to post the cases. And at that time we had complete access of microscope, QSAR, drill, endoscope. Although at that time brain lab navigation has come, so at that time we had access to all these things, and we had a very good teaching as well as we had hands-on experience on the patients. So that way we could teach the DNB people where whom they are. We used to take classes for them and we used to teach them. At that time we never had access to so much of internet at that time. It was coming up and things were more gradually getting better. So we used to keep on taking some classes. We used to make a schedule. We used to, at the time they used to be having, we used to conduct DNB FAT exams for the other people. So people used to come from Apollo and other places. So we even used to take exams. We used to set exam papers for them. Krishna sir used to ask us set some papers for the DNB FAT exams. So we used to write down some questions. So we used to conduct the exams. So it was very good, like in the sense now few people we didn't know because the rest of the people we did not know. So I'm very happy and pleased that the family is growing a lot, and I wish each and everyone all the best. And I'd like to say what Amit, my next contender was there. Let's see what he says.
Thank you. I'm Dr. Amit Kumar. We did the same time neurosurgery, 5 years neurosurgery course at NIMS from 2003 to 7. And afterwards, around 10 months senior residency at NIMS only. I've joined KIMS for a short time of around 11 months from 2008 to 2009 only. Actually, I did only in pre-Manas era at KIMS under the able leadership of Krishna Reddy sir. My confidence levels were low at that time. Yeah. I used to manage Mahavir Hospital, Arogyasri patients individually. He has given confidence in me, and I used to attend the cases at Mahavir by myself, all by myself. And slowly my confidence levels grew up, and I got opportunity, went to NRI Medical College, Guntur, where I joined as assistant, then became associate professor, now heading the department of neurosurgery with one MCH student there. That's how my short stay at KIMS. Now I am surprised to see so much it has grown and so many students have evolved from KIMS. I'm happy and all the best for all of you. Thank you. And NRI, sir, NRI Medical College, Guntur.
I request Nadi sir to speak a few words. Sir, please. Later. The one and only Lady Tiger I used to see, Manoranjita madam. Please come and speak few words because you are always supportive and encouraging and you taught us a lot.
Thank you, sir, and thank you, Shweta, for inviting us for this alumni meet. I just came here for an alumni meet only because I'm not practicing fine anymore. Um, my association with KIMS started in the year 2013. With the help of my professor, I got to know that there is a fellowship program running at KIMS. So I applied for that and I spoke to Manas sir, and he gave me appointment to meet him here in the old block. So I had booked the ticket, but thing is that the 2 days prior to the expected date of my travel to Hyderabad, there was a bomb blast here in two places nearby. So my parents were very much reluctant to send me to Hyderabad. They were completely against of sending me to Hyderabad in 2013, but still I nagged my mother and we both came and met Manasar. Somehow I prepared to stay back in Hyderabad. And I did my second neurosurgery residency at Hyderabad. I think I was the longest stayed fellow becoming consultant in Hyderabad. I stayed here almost 4 years, 2013 March to 2017 March. So whatever I learned, whatever I'm practicing at present in my hospital, I learned everything from Kim's only, mainly from Dr. Manas. Though I studied from my MCH from MMC, we did not have much sophisticated gadgets like high-end microscope and navigation, all those things. It was very new to me when I joined KIMS, and I have to unlearn whatever I learned from MMC to relearn the new technologies which we had at KIMS. So I'm very grateful to KIMS Hospital, Dr. Krishna Reddy sir, Manas sir, and Naidu sir. And not only with my patients, I experiment with my surgical this thing. I also experimented my cooking skills with my friends, even with Manas sir also. So I had a nice time at Hyderabad. Actually, I am having very bad kind of motion sickness. I think in the world, I am the only person having a driver for a bike. So this our Dilip is my driver. Wherever we go, Dilip used to take me in bike because I had a very bad experience with Manas sir vomiting in his car. That was a new BMW, and he told me never ever get into my car. So I'll so you just once we went to sister, Sakla sister's housewarming ceremony. No, in 5 minutes I vomited inside your car. You don't, no, you don't. So it's a nice time I spent at Thames. This is very nostalgic actually. So it's good to be here. Thank you.
Thank you so much, ma'am. I request Raghavendra sir to come and speak few words. He's always encouraging, and presently he's working at Kondapur KIMS. Sorry, Gachapati KIMS.
I'm working right now at Chipmar as associate professor neurosurgeon.
Good evening, everybody. Nice to see you all. First, I met Manasar. I thank Bharat Boss. We met Manasar in 2012 NSI Con. Then I put an application, sir. After 6 months, I want to join. And KIMS, I entered Hyderabad in 2012 with 2 bags, and KIMS is always in motherhood, always protective for me. All these professional discussions, rather than I just want to tell one important discussion what we used to have, me and Anup especially. Sir, whenever when you take a new vehicle, we put mirchi and nimbu, no? So that is the way Anup used to tell. Sir, आप एक नींबू मिर्ची ओटी टेबल को बांध दो, so that रोज ये गाली गाना. So 8:40 means our pendulum is to start. Sir is to come at 8:40 and every day, I don't know. Everybody sir, you are lover boy to sir. आपको एक बार घंटी बजा के next OT 7 में घंटी बजा के फिर OT 8 में जाना पड़ता है. This was the our thing. I cannot forget this. Especially Anup and me had this discussion. तो रोज तो घंटी बजता ही था. अभी भी बज रहा है कभी कभी. And one more thing I like to say is, after positioning any patient, I have to confirm with Amit Bhaiya. Amit Bhaiya, sir, accept karte ki nahi karte. So that also we cannot forget Yadgir and Amit Bhaiya. And because always our nursing staff, no, Shakila sister is our troubleshooter. So I thank, and I'm lot of things. And we call Preeti used to be calling a KPM. I used to call because in OT we call number, sir, patient. I means koon peene wala machine. I used to call her. I used to tell her put one. KPM Preeti, I used to ask her, put on central line for us, please suck 1 ml blood from us so that we are happy. But I really learned all these things, and at the same time, I really thank sir for, I feel this 10 fingers of mine is gifted to Manas sir. I really thank you. Thank you, Krishna Reddy sir, and thank you, Naidu sir. Thank you, everybody.
Thank you very much. Anybody wants to volunteer to come to speak?
Uh, Good evening, everyone. Thank you, sir, for arranging such a good evening to be nostalgic. I am Dr. Maulik Waja. I was the fourth student after Satvik, Shweta, and our little Dilip was there. I never treated him as my senior because actually when I came and I saw him, he was tremoring while doing LP also. मैंने बोला ये senior से मैं क्या सीखने वाला हूँ. So, but the people were very nice. I came from Gujarat. I never knew the language over here. First day when I met Manas sir, he told me, तुमको आते है तेलुगु? मैंने बोला सर नहीं. मैंने बोला तो कोई पहले पूछे तो क्या बोलने का? बोला सर क्या? तो he told me नाको तेलुगु रादू ऐसा बोलने का. Anybody ask you, you tell and take any sister with you. And I was the first non-Telugu speaking person probably with sir. And when I came to know and when I met Krishna Reddy sir, who was the of BS Hospital in Ahmedabad. So पहले ही मेरा थोड़ा दिल शांत हुआ कि somebody is there who has been in Gujarat and he can know my nerves. So he was like a father figure when I came to see him, and over that the golden touch was Dr. Manas. Manas sir, we are really thankful to you. I remember when I came here, I never when I at the first day of Manoranjita, when she came, I asked her, do you know Telugu? Because I wanted someone to help me. She was, I think, 15 or a day, 1 month later. When I joined, she joined after 1 month. So she told, "Arey yaar, I also don't know Telugu, but we will learn." So she was little bit better, but over a period of time, I also started communicating with patients, and I learned a lot over staying over here. I was the assistant professor of general surgery for 3.5 years before joining into neurosurgery. So I never expected myself moving into residency again, but I literally changed myself. I saw a lot of transformation. Even after going back, I literally tell people over there they are staying in a false aura that they have become consultant. You have to go to a proper institute, then you will become a actual doctor, actual personality. So thank you, sir, for changing my personality, changing my perspective to life. And I am whatever today because of you. Whenever somebody praise me about my surgery, I just tell them it is my training, the discipline you taught us. So right now I am working at Sterling Hospital, which is one of the largest chain of hospital in Gujarat. I am in Vadodara. I am leading the department and working as a director of neurosurgery since last 8 years in city of Vadodara. And one thing I learned from Manas sir, after just 3 days of 3 months of residency, I got chicken pox. So that day Satvik called me, देखो तुम घर पे तो हो ना, सर आ रहे हैं तुमको खबर पूछने के लिए. So, he thought of I am faking my illness. तो मैंने बोला नहीं नहीं घर पे हूँ और क्या. I thought कि he is joking, he is checking with me that whether I am really sick or not. मेरा sir so door knocked and sir was there, and that day I told him, sir, you are the only professor, only teacher who have come to see me, and you are so careful about your student. वही सीखना है. And the second example, when I went back to Baroda, Krishna Reddy said there are photos playing in the background also. He came to my home, and I really proud of the teachers I got here, and they really changed my personality and whatever I am today because of them. Naidu sir also contributed a lot when there was a 6, 7, 8 thing were going on. We were trying to manage it, and we really, as Dr. Bhaskar said, it is when you are on treadmill, you don't know and you feel tired, but when you get off the treadmill, you feel you are more healthy. Thank you very much.
Thank you, Maulik. Anyone who wants to speak, or should I only call names?
You had come for the interview. Interview over. Supposed to join next day.
And I told that I will come from another day. Everybody thought I left.
SICU scenario, me and Sham sir आते हैं. क्या आपने डरा के भगा दिया क्या? आधा दिन आए, बहुत कोल्ड ड्रिंक्स, वो अभी भी याद है. लेडी आई, लेडी उस दिन नहीं आए, तो बहुत खाए हमने.
Actually, next day when I came, Sridhar sir was there, anesthetist. He told, "How come you are here? You ran away."
That thing is amazing, huh?
Yeah.
अब्बा, और शाम सर को मैं तो डांट सह सकता, मगर शाम सर का डांट सहने का सिस्टम थोड़ा कम था. थोड़ा भी डांट पड़ा तो उस दिन रात बीपी ज्यादा होता है. बाद में रात में वो बॉक्सिंग बैग को बॉक्सिंग करते थे डिस्ट्रेस होने के लिए. शाम सर है?
No, he is not here.
No.
He had some personal work.
नहीं जी, हम
Yeah, Puneet, please come.
When I came for the first time, मैं वो rounds चल रहे थे और directly went in the rounds with रामकृष्ण सर थे, मैडम थे, अनूप था. फिर राउंड्स का खत्म हुआ तो अनूप मुझे बियर पीने के लिए लेके गया. ये बियर पी के इसको जाने नहीं देना है. तो we had a beer, फिर वो बिरयानी खिलाया. बहुत अच्छा है, तुम आ जाओ, ज्वाइन कर लो, कि मजे से काम करेंगे. Then this और मैं अकेला कैसे काम करूंगा, दूसरा भी चाहिए बकरा. Then it was a great learning experience overall. Or he had named that sleeping place also the Michael's Cave. ऊपर किसी को ढूंढना तो वाला Michael's Cave में जाओ ऊपर. So we worked, we laughed, we enjoyed working together, and we learnt a lot from all the mentors, Manas sir, Krishna Reddy sir, Naidu sir, Sujit sir, and all the staff. Everybody was very supporting. And initially, I was sitting with the madam in the restaurant, Kim's restaurant, because I had done my MS, so everything was going. For initially for 2 to 3 months, I was not understanding anything. Because after finishing general surgery, we have never seen any cranial structures also. So I was very serious. I was saying, madam, I'm thinking I will leave and I cannot continue. Madam, you give some time, everything will be okay. Then gradually it got over 4 years. And I don't regret any moment spending here. So I thank all of you. I am presently, I have my private hospital at Rajkot and working there in Gujarat. Thank you all. Thank you.
Thank you, Puneet. Now I request Manas sir to say some words. Sir, today, like, I don't want to hear any neurosurgery. We want some life experiences. Because I look at him as Lord Krishna, who can manage any situation in an artistic way without any tension. That actually we should learn from him. So I want you to say a few words regarding that to deal with any emotional situation.
Hello, Shweta.
Hi, sir.
I want to say a few words, if you permit me.
Yeah, please, sir.
Thank you very much, sir. I am Dr. Bharat Gupta. I'm the first, I will introduce myself. So, we are the first team of KIMS as a fellows. Myself, Dr. Bharat Gupta, I'm from Punjab. Dr. Rajesh is there. He's from Hyderabad. Dr. Satvik Shetty, he's from Bangalore. And our first MS resident, Dr. Satvik, who is a hot favorite every time in the KIMS. I think everybody remembers him. for every kind, because he was a wonderful resident. And our first 6-year resident is here. Second candidate is Dilip. So we enjoyed a lot. I was also a resident with big people like Dr. Krishna Reddy, Manas sir, Naidu sir, he's here. So I will tell you a little bit story about how I joined. When I was doing my residency at Punjab, so I was very enthusiastic when I joined neurosurgery. But results at our centers were not that very much good. So usually thought we operate upon something and patient get deteriorated. Then what is the fun of doing neurosurgery? I went 2-3 centers there, and eventually I came Hyderabad in skull base conference when Dr. Manas organized it, and I presented some paper there. I met him, I saw his work. So after residency, I joined some private hospital, and then I approached him to join as a fellow under his guidance. So Dr. Bhaskar Rao, if you remember, I met you at Delhi MCE office for an interview, and you selected, and I came here. So during the stay here, it was absolutely marvelous. I learned so much under the mentors that I'm still practicing the same. Dr. Rajesh was a very good colleague. Dr. Shetty, very supportive, and resident Satvik, he was very helpful after the duty times. So we used to go here and there and just enjoying, because my wife was not here, his wife was not here, so we all enjoy the residency life. So this experience was so wonderful that I am here today, here to meet all of you people and say many thanks from my heart and from my side, Dr. Rajesh and Shetty also. I am very happy to see a large tree after our leaving this place. So it is a huge tree. God bless all the KIMS, teachers, students, and further future students. And thank you very much, sir. Thank you.
Thank you, sir. Yeah, please come. Chirag.
Good evening, all of you. I will just tell 2-3 things only. KIMS neurosurgery department is well decorated department. That is one sentence is enough. Once you will enter in the department, your personality, your work, your way of behavior, and your overall development will be different. Not only neurosurgery, everything. After passing, wherever you will go, you will sign, and you will be differentiated from others. That is be sure. So that is best thing what you will learn. Next thing, all three sirs, Manas sir, Ekreddy sir, and Naidu sir, Sujit sir, everybody has some different things to teach you, and you will learn from different consultant with different things. That's no matter. My the two immediate seniors from where I have done MS, they are already was there in the KIMS Hyderabad. When I was gone for DNB counseling, I have a same. Delhi was also available, and Hyderabad also. Delhi was more favorable because there was no language barrier. Still, I opted Hyderabad because of they have given good reviews also of this institute. After coming within 6 months, that language barrier was almost not much facing. So it is like life-changing experience for me that I might not have what I am today if I have somewhere else. So that is what I have learned from the KIMS. And thank you for all the life, and thank you everyone.
Thank you so much. Anyone wants to speak? Yeah, please. Is Dr. Mallappa.
So, good evening, everyone. I am Dr. Mallappa Hugip, presently working as a consultant neurosurgeon in Sri B.M. Patel Medical College, Bijapur. For everybody sitting here, be it residency or fellowship, I have not heard one person telling that I didn't get scolded. Everybody sitting here always will tell first thing that I have got scolded. But when you go and analyze it retrospectively after coming out of KIMS, what feeling I will get it, it's always divine feeling. It's just like a black stone getting detected in Mysore, and the same black stone when it sits in Ayodhya, the charm on that murti, the way the sculptor has converted that whole black stone into a murti, that divinity comes only when you work with a person who is divine. It's just like Jai Jagannath. It's Jagannath's. It's basically Jagannath's hands only, and it's not just as a neurosurgeon, Dr. Manas sir. What differs him from others, be it neurosurgeons or other surgeons, what I have seen in my life, it is his empathy and it is his willingness to take a call at 3 a.m. in the night to discuss the problem which his patient is going through and suggest a solution. It is very difficult to find in any other person. Even today, when I take night calls, my kids wake up, my wife gets disturbed, and I always tell my wife, even if I can become 5% of what Dr. Manas sir is, I feel my life is I will be happy. That's how it is. And everybody sitting here who has come under the influence of Manas sir always will tell that at least if I can become 20-30% of what Dr. Manas sir is today, then I am very happy. The say I have learned. My guide was Dr. Naidu sir. Also, I have learned good cases from him. I have assisted him. I have learned many things from him and Dr. Sujit sir also. I was unfortunate that I couldn't assist or learn from Dr. Krishna Reddy sir, but I'm sure whatever I have learned all these days, it is helping me a lot and it has changed me as a person also. That's how it is when you enter KIMS and leave KIMS. It makes a huge difference. It is divine feeling for me at least. Thank you.
Thank you so much. Those were actually the words of everyone you expressed. Anyone else wants to speak? Yeah, please, sir. That is the thing, no? When you are with Manas sir, you won't get satisfied. You want to get more, more and more.
I'm Dr. Satvik. I'm a neurosurgeon at Manipal Hospital, Bangalore. So I was one of the first few fellows here. So I am Satvik Shetty, by the way. Yeah. So I was the first few, I think, first batch of fellows here at KIMS. I think I thought I'll sit there and watch others speak, but I think this is a good opportunity to express what I feel about this institute, about Krishna Reddy sir, Manas sir, and Naidu sir as well. So I think I've never seen a person who's. I think Dr. Krishna Reddy sir was a role model when I came and met him here, and my 1 year with him, I think truly is an exceptional human being. I've never seen such a human being, such a senior neurosurgeon, and the way he conducts himself. I think everybody should try to emulate him. I think he's an exceptional person. I am truly blessed that I worked with you, sir. I'm very happy with that. So, and Naidu sir has always been like a friend. So he was so fast in surgery; it's very difficult to keep up with him. So and he never seems to age. My hair has become gray, but he is so young and handsome always. And I thank him for all the opportunities. He used to give us a lot of opportunities to operate and take that responsibility. It's not easy to give your patients to somebody to operate, and he was very encouraging for us. And thank you, sir, because it was just after residency when you come, your hands are not as fine, but he was one of the persons who was encouraging us to do. And I thank you, sir, for all the help you have done and in our career. And I don't know what to say about Manas sir, because Manas sir, I came and met him during one of the epilepsy conferences. My thesis was on epilepsy surgery. So I got drawn towards functional during my residency. And when I was reading articles, there were articles published by Manas sir. So first time I came and met him in a conference, I asked him, I want to do some fellowship under you. I want to come and work with you because epilepsy surgery was the thing which I wanted to learn from him. And I knew he was an expert in that. So, but I didn't know, what I didn't know was he's also very, I think, very soft-spoken. And I know most of you must have seen his other side, but I didn't see much of it, so, thankfully. But so the one thing is, he may shout at you, but I've never seen him get angry or ruffled in the theater.
In the operation theater, he never used to raise his voice. I think that is one thing which all of us have to learn, because once you lose your cool in the theater, then the surgery is not good anymore. So I think one thing what you will appreciate is he never loses his cool in the theater. Exceptionally fine surgeon. Watching him operate day in and day out, I think just by watching him, you learn so many tricks and techniques of handling tissue that I think it will stay with you forever. I think that is the greatest gift I've received from you, sir. Thank you so much. And apart from that, I think he used to push us really hard. I think I worked more in my fellowship than in my final year of residency, because I had a lot of juniors with me there. And here, I think there were few residents, only Satvik was here when we came. And it was, work was not a problem. But at the same time, he expected you to present papers or write papers. And I think that was a little taxing. But I think, but because he never used to forget. Every other day or every third day he sees you note, he'll ask what happened. So you have to do something at 9, 10 o'clock in the night. You're going back home and then you're sitting and then you have to work on the papers as well. So because of that, I think at that time I got an award in NSI as well. So thank you so much, sir. Thank you for taking us under your wings and helping us to become what we are today. And I think I cannot stop with just that. Dr. Bhaskar Rao sir is there. I think KIMS as an institute is, I think I worked in various institutes. I worked in Narayana, I worked in Manipal now and KIMS. I think KIMS actually is an exceptional institute and you feel part of it. I think the institute makes you feel part of it. Whether it is small things like for on duty days, you don't have to pay for food. That is great. But, but also,
That is not there now.
not there now. So we, we got free dinner and breakfast, so we enjoyed that. And also, when we won something, they used to recognize. He used to, when I won an award in NSI, I think the hospital recognized that. It doesn't happen in other hospitals. They recognize that you have represented the institute and gone and got some appreciation or award for the institute. I think I felt that the institute was, I think, it actually accepted me, and I was felt a very integral part of the institute when I was here. And thank you for that, sir. Thank you.
Thank you, sir. Mohan Rao sir, to speak few words about your God.
I think everyone knows that. It's a simple word. He is my God. I am his devotee. That's it. I joined neurosurgery just because of Dr. Manas. I even at one point of the time, I don't want to continue in NIMS and want to join in Krishna Institute as a resident, like in my second year. He said no. Maybe that is also a good thing. But after that, I came to KIMS as a fellow, and I learned so many things. Even like Satvik said, I am also not seen much bad of Dr. Manas. I'm always like very, very, very happy with him. Even I ask him like just like a friend, shall we sit for few more minutes? So he most of the time says yes, even in his busy schedule also. And thank you very much, sir. You made like my life fulfilled with joy and everything. Thank you very much.
I request Dr. Rajesh sir to come and speak few words. Come, sir. Anyone else who want to speak, please come, sir. Ramakrishna, sir. Next, be ready.
Good evening, everyone. So I finished my residency in NHL Medical College, Ahmedabad. So later I joined KIMS. I joined as a fellow with Dr. Manas sir. The only problem we had was every day morning we don't know when we're going to get the scoldings. So be ready for that one. Me and Manoranjita, we used to gossip about a lot about how to get out of the scoldings. After the OP, in between the OPs, we need to run in between there and here. And again, used to get a call from sir, okay, come back, where are you now? So these things used to happen all day. So at the end of the day, we learned a lot of things in KIMS with sir. Like it was very crude what we used to do in Ahmedabad. So we did not have fine drills, so not the skills were very fine. But once I came here, when we used to be in my residency, we do a CP angle or aneurysm, we need to sit with the patient. I don't know when the patients would die. That's what the case was. When you come over here, the complication was so minimal. And I learned few things from Mana sir, which still I practice now. One to use how to use the suction. And second one is the blue bayonet. I think only those two instruments are required to do neurosurgery, and all other gadgets are add-ons. That's what I know. Yeah, mastering suction was what I learned from Mana.
Yeah, needle is not for him to do any surgery.
And I'm thankful to Naidu sir for giving me a lot of opportunities to do a lot of cases under his guidance. And Krishnadi sir, I'm very thankful to you. I always see Krishnadi sir as a person who is very cool. Like even in school, in the operation, bleeding is happening, a lot of bleeding is happening. Then he feels okay, nothing's going to happen. Just calm down. It will be fine. It will be fine. And Naidu sir, what I learned is to be very fast when it's required. And thank Bhaskar sir for giving the opportunity to work at KIMS. That's it. Thank you. Presently, I'm working as consultant at Hospital, Skachipoli, sir.
Anyone, Paniraj sir.
Good evening, everyone. My association with Dr. Manas begins from 2005 as a resident at NIMS. He was my thesis guide also. I learned basic skills of neurosurgery and how to operate and how to evaluate the patient and what to do and what not exactly to be done. Those I learned with Professor Manas. And after finishing from NIMS, I again joined under Dr. Manas and Dr. Krishna Reddy sir. I learned a lot of things from both of them. I also thank Dr. Naidu sir for giving me the opportunities to operate. And basically, it's all about how exactly and how skillfully and how fine you operate, and how much of tissue you handle. Those very fine skills I learned from all three of them. I'm extremely grateful for the opportunities given, and I also thank Dr. Bhaskar Rao garu for having the confidence in us and letting us do all the cases. And that's it. Thank you, everyone.
Thank you, sir. Oh. Yeah. Skit. Now we are going to present a small skit. It is like any other random day in neurosurgery. You can correlate actually. It is just for the sake of fun. You can enjoy. Don't get offended. And the disclaimer is all the characters shown are real, and you can correlate. And if you find it interesting, you can encourage. Don't sit like these three people.
Chairs.
Good evening, all. Hope you all are enjoying here. This kit is dedicated to our dear Dr. Manas Panigrai sir. It shows how Manas sir tolerate us every day. He forgot all our mistake and insolvent, transforming us into good neurosurgeon. Yes, cut. ये किट पूरी तरीके से आपके मनोरंजन के लिए ही बनाई गई है। इस किट के सभी पात्र एवं घटनाएं काल्पनिक बिल्कुल भी नहीं है। If you find any similarity to your own experience, congrats, आप किम्स में काम कर चुके हैं। इस शो को देख के आप मुस्कुराइए, अपनी पुरानी यादें ताजा कीजिए। अगर स्क्रिप्ट अच्छा लगे तो प्लीज हंसिए, जैसे स्क्रिप्ट की तरह मत देखिए। Now we are starting to the skin.
समझ बच गया ये अनिश को आर्टिकल्स भेजने हैं अभी
क्या कर रहे हो?
तुम कौन हो
सो डेडिकेटेड यू फॉरगॉट मी एंड
अंतरात्मा रिफ्लेक्शन यस मुझे दिखेगा सबको ही दिखेगा
सबको नहीं दिखेगा, आपको ही दिखेगा।
ओहो मुझे डिस्टर्ब मत करना अभी अनिश का
क्या कर रहे हो?
अनिश का कॉन्फ्रेंस है ना उसको आर्टिकल्स भेजना है
तुमको बोलना है ना, आप क्यों बोल रहे हो?
they are very hard working na let me support them
Not hard working. It is morning 4 o'clock. I think you can listen to his snoring. From here also. He's sleeping in that way. And we are sitting here.
don't disturb me yaar
What did you say? They are hard working. Hardly working.
hard working yaar don't disturb me ठीक है आज जल्दी जाना है अभी मेरा बहुत केसेस है ये क्या
सर कुछ मैसेज आया होगा?
delaying taking first case due to technical reasons कुछ तो रीजन होगा ना ऐसा मत बोलो मेरी बात तब जब आएगा ना काम करते
हाँ नेटफ्लिक्स सीरीज देखते हुए तो तब है।
ये क्या किया यार सुबह सुबह क्या है मेरे पीछे पड़ा कहाँ आ रहा है मेरे पीछे
मेरे मन रिफ्लेक्शन है।
अभी क्लास जाऊंगा तो तुम भी आ जाओगे
Good morning, sir.
morning start
Sir, that 46-year male patient working as at that airport is complaining of that the left side is when he putting that baggage from the conveyor belt is not seen and half of the conveyor belt and when again put the conveyor belt to the floor then baggage is not seen anything, sir.
क्या बोल रहे?
what do you want to say man
Yeah.
what do you want to say
Yes. Sir, patient has a left side hemianopia, sir.
why can't you say in simple English man why you are confusing everyone here so what you do one thing put your English sentences in AI it will correct you
I can't understand in English. They can understand, we can also understand.
where are everyone
Sir,
yes Anish where are you
I was in ICU, sir.
ICU you think I have not done my PG and came here what are you doing in ICU
There was one emergency, sir.
what emergency
ENT people were doing one procedure and I was watching, sir.
you are standing as a standby you are ENT surgeon not fit for neurosurgeon man don't join ENT only so don't stand stand here and increase your BP man go yes what are the differential diagnoses for HCF lesions
The non-functional pituitary adenoma.
ये logical thinking actually man people don't see I'm telling you
Okay, sir.
अच्छा अच्छा ये पेशेंट का बायोप्सी पर 10 दिन हो गया है अभी अब तक अपलोड नहीं हुआ है
हाँ पे सर
क्या 2 दिन पहले अपलोड कर चुका है अच्छा है ग्लायोमा वेरी मेटास्टेसिस वेरी लिम्फोमा तीनों
क्या होता है?
पेपर लाइन पेपर
पता नहीं कैसे काम कर रहे हैं
ठीक है।
डॉक्टर चंद्रशेखर इस बात है So,
Good morning, sir.
Vidyarani,
Post after 7 APD completion. She is doing fine, sir. Today shifting.
okay. Sudha,
Sir, the TSH patient, no DI, no leak, sir. Sodium is 136, doing fine, sir.
A. Harish.
Sir, the temporal lesion excision, POD 10, he is doing fine, sir.
इसका बायोप्सी रिपोर्ट
नहीं सर, नहीं अभी तक आया नहीं सर, अपडेटेड नहीं।
सर मॉर्निंग biopsy report, man.
Yes.
How can you be so cool when they are just lying simply?
Let them. ठीक है. I have to go to OT ना.
ठीक है.
There is a lesion in where have you done it? What happened?
Not applying your brain. Brain research also you haven't done correct now. Not even once. Simply increase my work. I'm coming.
Yes. Take out your eyes.
ये क्या पोजीशन है चिंपांजी तरह डांस कर रहे क्या है ना
Bipolar.
अभी क्या पूछो कैट पर पूछो
Sister cat's paw. Yes. Hold it here. Hold it here. Here.
Yes, sir.
Okay.
Holding, sir.
Yes. Now. Bipolar sister.
ये क्या कर रही है
Yes, sir.
This patient will develop weakness because of you. Don't you hold it properly here? Here. Here. Yes. And here is having and here is sleeping. And yes, right arm. Chandrasekhar. What is the structure? So, what is the structure? This.
Optic no, sir. Optic now. Sir. Where am I operating? Optic now comes at thalamus. People don't open the books here. Well, Salva. Close करता है?
Yes.
अच्छा. Edit this video. Send it to me by night. हाँ. आप प्रीति कहाँ पे थे सर?
सर गुड इवनिंग सर
इवनिंग. टोपड़ी देखिए. वो कहाँ पे थे?
यस सर देख रहे सर
5 मिनट में आ रहा हूँ.
ठीक है सर थैंक यू सर
मैं तो सो रहा था सर, मुझे कुछ दिखाई नहीं देता। मैं तो कल नाइट की ड्यूटी पे बहुत थक गया था सर।
या तो मैं डांट खाता हूँ या तू डांट।
सर लगता है ना,
करना पड़ेगा।
लगता है नींबू और मिर्ची लाके टेबल को लगाना है, नहीं तो हवन करना है।
नींबू मिर्ची लगाते हैं ये पब्लिक की वजह से क्या सोच रहे हैं लोग।
Take the phone.
Good evening, sir.
Mhm.
Sir, tomorrow is OT list, sir. CP angle is there, sir. FTS.
See, how can we give 70 patients? मतलब you don't have common sense also. Nowadays I have to teach management also.
Sorry, sir.
But can't you manage even for 50, 60 patients also?
Sorry, sir. Take care.
So, start.
Thank you, sir.
Morning, sir. Yes, sir. This is a patient, sir. Namaste, sir.
Namaste, Amma.
52-year-old male, sir. I'd come before for backache. He's come for follow-up, sir. He's fine, sir.
నమస్తే సార్.
నమస్తే అండి.
సార్ నాకు లాస్ట్ టైం వచ్చినప్పుడు నడుము నొప్పితో వచ్చాను, చాలా తగ్గింది సార్, ఇప్పుడు చాలా బెటర్ గా ఉన్నాను నేను.
ఓకే.
ఓకే సార్. ఒక్కొక్కసారి రేడియేటింగ్ పెయిన్స్ వస్తున్నాయి సార్, తిమ్మిర్లు కూడా వస్తున్నాయి.
ఎక్సర్సైజ్ చేస్తున్నారా?
చేస్తున్నాను సార్.
नमस्ते सर।
नमस्ते अम्मा।
अटेंडेंट वाइफ हूँ सर।
हाँ।
इनका पेन है ना सर, डेली डेली बढ़ते जा रहा है। कुछ मेडिसिन दिया तो भी नहीं कम होने हो रहे सर।
अरे आराम ये बोल रहा ना।
नहीं सर, हाथ पर मेरे को तंग करता है।
తగ్గింది సార్
तो तुमको नहीं मालूम, हाथ पर मेरे को तंग करता है। इनका कुछ करो ना इलाज इसका।
बोल रहा हूँ ना आराम हो गया
4 कदम चलो तो ही उनका गर्द पेन हो रहा है सर पूरा नीस में।
अच्छा दवाई चेंज करते हैं आराम हो जाएगा एक्सरसाइज करना मैं
सर सर ज्यादा सोचे तो भी सिर में दर्द होता है
उनकी जैसे वाइफ है तो सोचना ही पड़ेगा।
हेडसेट लिखो ना
सर हेडसेट, ये वाला हेडसेट सर।
उससे कम होता है सर
आई विल एक्सप्लेन
सर वेट 1 मिनट से
सर्जरी గురించి सर्जरी గురించి
तुम चुप बैठो, तुमको कुछ भी नहीं मालूम, रुको। सर सब जने बोला है सर्जरी सर्जरी बता रहे हैं, अभी आप मेडिसिन दे रहे, कम हो जाएंगे।
నేను చెప్పాను సర్జరీ చెప్పానా లేదు కదా
लेकिन इनको सर्जरी करना चाह रहे कहते सर।
सर्जरी मैं नहीं बोला ना बाहर लोग बोला ना
इनका दिमाग का करना है, अच्छा हो जाएगा।
తగ్గింది అన్నాను కదా
सर तुम चुप बैठो ना जी, तुमको नहीं मालूम। सब बोलिए ना प्लीज।
माँ ये मेडिसिन से ठीक हो जाएगा उसको आराम है तो मेडिसिन और एक्सरसाइज करो
अगर ज्यादा हुए तो सर
फिर से हाँ ना
इमरजेंसी को आ सकते हैं क्या?
आ सकते हैं माँ
सर 3 महीने का अपॉइंटमेंट लेने
एक्सप्लेन यू विल एक्सप्लेन
तुम बैठिए ना सर प्लीज, लेट स्पीक इट।
3 महीने का अपॉइंटमेंट लेने का बहुत मुश्किल हो रहा है सर
पहला వచ్చారు now you came
यस
तो मतलब मिला ना अपॉइंटमेंट
बट 3 महीने के पहले बुक करने का मुश्किल हो रहा है
you can come anytime if you have any problem okay
अभी दवाई से कम होता है ना सर
हो जाएगा ठीक हो जाएगा
ओके थैंक
नमस्ते सर।
नमस्ते
क्या पेशेंट दमक खाते रहते हैं आपका। थोड़ा चाय पी लेंगे ठंडा हो जाएगा। थोड़ा चाय लो।
आ गया तुम
इतना क्या सोच रहे हो?
अभी कॉन्फ्रेंस जाना है और एक केस करके जाना है कैसे जाना है वो सोच रहा हूँ
केस करने के बाद कॉन्फ्रेंस, ये लोग तो बहुत लेट करेगा, कैसे करते हैं?
क्यों लेट करेगा हो जाएगा जल्दी
क्या होते हैं आपका एक्सपेक्टेशन एक तरफ रहते हैं, रियलिटी अलग रहते हैं। हाँ एक्सपेक्टेशन इधर और रियलिटी इधर, देखिए आपका एक्सपेक्टेशन।
एक्सपोजर हो गया, सर को इन्फॉर्म करो आने के लिए।
नहीं था और थोड़ा करते हैं बोन वर्क अच्छे से नहीं हुआ तो सारा के डांटेंगे, अच्छे से करेंगे डूरा ओपन करेंगे, सर का थोड़ा काम कम करना चाहिए।
हम ट्यूमर थोड़ा निकालेंगे भी सर आने के पहले। गिव मी नीडल।
आपका एक्सपेक्टेशन ऐसे रहता है, रियलिटी क्या होगा इधर देखिए।
अरे सर को फोन करना है रे, 1 मिनट। हेलो सर, सर वन पेशेंट विथ हाइड्रोकेफलस, आई सेंट यू स्कैन सर। हाँ ओके सर, ईवीडी ओके सर, थैंक यू। ईवीडी डालना है, रेडी करो।
राइट साइड की लेफ्ट साइड
देखे कैसे है।
कॉल करता हूँ। हेलो सर, सर यस दैट ईवीडी पेशेंट टू पुट राइट साइड और लेफ्ट साइड सर, टू पुट फ्रंट और बैक सर।
उनके पीठ में रखने दो, फ्रंट बैक है।
ओके सर, राइट साइड फ्रंट, रेडी करो।
सर अभी तो पेशेंट स्टेबल है, वी वांट टू डू इट, शैल वी डू नाउ और शुड वी पोस्ट फॉर टुमारो?
अरे पहले पूछना था ना। हेलो सर, हाँ दैट ईवीडी केस ओनली सर, नाउ ओनली सर और टुमारो सर?
Better you only go and do instead of answering these many calls.
ओके सर, थैंक यू सर। नाउ ओनली आज ही पूछ।
सर पर वो ईवीडी के टाइम पे सीएसएफ भेजना कि नहीं?
एक काम करते हैं, हम ईवीडी डालने के टाइम पर सर को फिर से फोन करेंगे।
ठीक है सर,
तब पूछेंगे।
तुम फोन करते ही रहो, कुछ करो मत। देखिए रियलिटी, तो आप कॉन्फ्रेंस को कब जाते, वैसे भी कॉन्फ्रेंस में जाने के बाद क्या करते हैं ये लोग, आपका एक्सपेक्टेशन एक रहता है, रियलिटी एक रहते हैं। देखिए एक्सपेक्टेशन।
अरे तूने सर का व्हाइट मैटर डिसेक्शन देखा और वो वाला प्रेजेंटेशन देखा, सर का पेपर पढ़ा? अल्टीमेट, मुझे नहीं लगता कि इंडिया में ऐसा कोई काम करता। अपने को क्या करना चाहिए, सर से अब की बार पूछना चाहिए, कॉन्फ्रेंस में वर्कशॉप करेंगे, वहां पे जाके व्हाइट मैटर डिसेक्शन सीख।
हम सर से सीखेंगे ये।
आपके एक्सपेक्टेशन ऐसे रहते हैं, लेकिन रियलिटी में ये लोग क्या करते हैं, देखिए रियलिटी।
నీకు ఒక కరిపఫ్ నాకు ఒక కరిపఫ్ సమోసా నాకు సమోసా
వద్దు బిర్యానీ తిన్నాం మనం.
ఇంకోటి తిను
మీరు రెండు తీసుకోండి.
పేస్ట్రీ తింటావా
మీ వైఫ్ తిడుతున్నారు, మీరు సన్న అవుతున్నారు, తినండి ఎక్కువ.
अरे सर 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 अरे आप यहाँ क्या कर रहे हो? वहाँ पे बाहर स्टॉल पे बहुत अच्छा वाला बैग दे रहे, लेदर वाला.
मेरे लिए ले क्या
सर वो
वो पेन भी दे रहे हैं फ्री में।
पेन तो दो ले लिया, बैग एक ही दे रहे सर.
अच्छा लंच का क्या करना है अभी?
सर
बिरयानी खाना है.
यही आ रहे हो कॉन्फ्रेंस को?
बाहर नहीं, अभी कॉन्फ्रेंस में है कि नहीं बिरयानी?
पूछते एक बार से देखते.
क्या कर रहे हो आप?
लंच के लिए कुछ प्लान करना है, अभी ये कॉन्फ्रेंस नहीं सुनना है मेरे को।
कहाँ जा रहे हो?
बाहर जाएंगे कोई।
सर कॉन्फ्रेंस का बिरयानी बहुत अच्छा है, ये आया है।
अच्छा तो है ना?
खा के आया हूँ, टेस्ट बहुत बढ़िया है सर।
अच्छा तो है ना?
बढ़िया है।
उसके बाद घर जाएंगे।
हाँ ठीक है सर।
अब इसे क्या करोगे, कॉन्फ्रेंस में फूड ही बंद करना है।
भगवान, इन लोगों को तो अवार्ड प्रेजेंटेशन तो छोड़ो, दिमाग तो दे दो बस, लाइफ में अपना जीना जिएगा बस।
ये क्या, कभी भी देखे तो उनके बारे में ही सोचते रहते हैं, उनका अवार्ड, उनका दिमाग, उनका ये, उनका वो। आप लोग अपने बारे में कभी भी नहीं सोचते।
मेरे लिए मुझे क्या चाहिए?
वो तो सही है, आपके पास सब कुछ है, पावर, पोजीशन, स्किल्स, वेल्थ, सब कुछ है, लेकिन थोड़ा हेल्प तो मांग सकते हैं।
इन लोगों के साथ
हाँ वो भी ठीक है, ये तो आपका बीपी शुगर डेली बढ़ाते रहते हैं। हाँ, ये है, लेकिन तो उनका दिमाग पूछना ही ठीक है, तो आपका हेल्थ अच्छा रहेगा, बीपी शुगर मेंटेन में रहेगा।
ये तो पूछा ना मैंने।
अब यही रहता है कभी भी। वैसे एक बात तो पक्का, वो सब लोग जैसे भी हो, जो भी हो, एक बात तो कॉमन है उसमें, कि वो सब लोग आपसे बहुत प्यार करते हैं और बहुत रेस्पेक्ट करते हैं। एक पॉइंट से इतने दूर से भी इतने सालों के बाद आपके लिए आए, दैट इज सो ग्रेट। दे ऑल लव यू अ लॉट। थैंक यू सो मच सर।
Uh, as a resident, like means many times you shout, but we also learn shouting. The first shouting I learned from my mother. My mother is a gynecologist, head of the department, and then she shouted every time, and then probably imbibed. And later, as a resident, I learned from Dr. Sastri, Professor Sastri. So I think one of the worst day he shouted in the morning, and evening he called for dinner to his home. So that is how we learned. Many times you shout not actually to demean you, but so that you learn something. You should also understand that somebody takes stress to shout at you. And then when you become teachers, you will understand that what shouting means. Um, we had an opportunity to spend money to get an entertainment, but then we thought to unravel the hidden talents of Kim's neurosurgery, I asked them to do something, and today you saw that they will be more successful in Tollywood and Bollywood than in neurosurgery. And Dr. Krishna Adi and Dr. Bhaskar Rao has been very supportive when I joined. And Dr. Bhaskar Rao has always means whatever you go and ask, whether it's for resident, ask for resident, he has got a conference in Malaysia to go, Turkey to go, support them. He supported whenever he had gone to. I think somebody published also. They were given money also some as a token this thing for publishing. So he understood, though he is a cardiac surgeon, but he understood that neurosurgery has a potential, and he uh, he means whatever equipment we asked, he has invested. And as a private institute in the country, we have everything which many of the private institute in the country doesn't have. And this year we are lucky that he agreed to have a gamma knife and focused ultrasound.
and which is a project of more than 70-80 crores. And so that's the confidence he has in neurosurgery department. Professor Krishna Reddy wanted to have gamma knife when we joined in 2009. But then at that time, we felt that probably we don't have cases, But so he was just waiting for us to ask, and then we asked, and then immediately he agreed. And it's not that I went and met. I just made a phone call. We want gamma knife, and it's thanks. It's done. It's ordered. So it's lucky my transition from NIMS to KIMS was very smooth. He supported all types of cases, whether it's Arogyasri or CGHS or ECHS. So the number of cases which as a unit it did at NIMS did not differ at KIMS. And that's how we grew, and residents and fellow also actually contributed to the growth of the department. This function was to acknowledge and honor all the residents who have contributed to our growth. And that's why we made certificates. And Dr. Sweta will call, and I'll request Dr. Krishna and Dr. Bhaskar Rao to hand over the certificates to them.
Thank you, sir. Certificates ఎక్కడ నా దగ్గర లేదు. Names చెప్పు. I request Bhaskar sir to please hand over some of the certificates. Dr. Asit Rao. Dr. Narendra Singh. Dr. Narendra Singh. Next. Dr. Ankur. Next. Dr. Sunil Patra. Keep it here. No? Dr. Nikhil. Dr. Nikhil. Yes. Dr. Pulla Reddy. Dr. Anup. Mike level. Dr. Mallappa. Yeah. KIMS Neurosurgery 15-year alumni meet. Honoring Dr. Mallappa or whoever is the doctor. We deeply appreciate the indelible mark you have made. The contributions and lasting footprints you have left behind are truly cherished. Wishing you continued success and excellence in all your endeavors. Thank you so much for attending us. He is not here.
Kiran.
Hi. How are you?
Narsingarao, sir.
Fine. Wait. Will you?
Ramakrishna, sir. Satvik Shetty, sir. Vikrant. Dr. Sukriti Chauhan. Rajesh Reddy, sir. Dr. Amit Kumar. Amit Kumar. Dr. Rajesh Reddy, sir. Sir,
Rajesh Reddy. sir. Totakura Amit Kumar.
Dilip. Dr. Sai Kalyan. Dr. Brahma Prasad. Dr. Brahma Prasad. Dr. Sandhya. Dr. Pratik. Dr. Sangeeta. Manoranjita, madam. Dr. Puneet. Dr. Shiva Prasad. Dr. Narsingarao, sir. Dr. Sham. Dr. Sham. Dr. Rajeshwari. Dr. Satvik. Investor Wallet. Next.
Next.
You go now. Dr. Ravish. Dr. Mohan Rao, sir.
Sir. Oh, okay.
Mohan Rao, sir. Bharat Bose. Dr. Ambrish. Dr. Ambrish. Dr. Chirag. Dr. Maulik. Cross check.
Last. Yes. How are you? Geeta is not here.
Viruddin.
नहीं
Narendra Singh Bhatti.
माइक
I know that all of you like Manoranjita, Sweta, and all those, Sandhya. But whenever any female resident or fellow used to come and talk with me for resident, all the boys will come and tell, sir, don't take, sir, don't take, sir. We have to suffer, we have to suffer. But then at the end, they become friends and they have worked as a team. And I don't regret that I have taken female residents. And rather, we got an appreciation because our fellowship has accreditation from the Asian Society, ACNS, Japan. And actually, they asked that every year they ask how many women residents are there working in the department. So that was like a win-win situation for both, and rather he was rejected at Apollo for DNV. Then we accepted, and every time I meet any Apollo consultant, I tell them that you have missed a good resident.
थैंक यू सर थैंक यू सर
Let me thank. You tell something.
I think this skit showed me a lot of things and insights which I am not able to visualize, even though I'm sitting in the fourth floor. One important message you people should have learned is the attitude is the one which able to build the either a consultant or a department and all. What I'm saying is, you all know that Naidu has joined in the beginning itself as a started looking into the construction time onwards. Not only that, he is I know his family last 50 years. His brother-in-law is my classmate, and we worked there, and their father and all we know. And then Krishna Reddy joined, and both of them, when he realized Krishna Reddy that he cannot able to take the department to a different level, then he himself is requested both of them Manas because of the Manas name and all those things. So he built it. The one important attitude here is that Krishna Reddy has brought him in spite of being a competitor and knows that he is going to take. That is the one good attitude where you people should able to appreciate. The second important thing, Naidu, in spite such a big figure, he could able to sustain, take the challenge and continue to do, even though many people called him. That is his attitude. And Sujit joined as a resident with Manas, and Manas has accepted him again as a consultant in the same department. Funny could not able to. He has got an opportunity along with Krishna Reddy to go to Kondapur. He went there. So here, the whatever you do, you people able to keep the attitude. Institution is the priority, and then we should able to work together. And many departments I see, they are always looking for an individual growth, not allowing the other people to come, not looking for the growth of the organization. And I'm very fortunate that the right people have come to their department. That's why we could able to grow. And there is a great potential. That's why we are, whatever they are asking, we could able to invest. And not only in the patient quality care and also training programs. If you people, any department want to grow, if there is a good training program, good conferences, good paper presentations, then only the department will be recognized by nationwide. Now many people will know when we done this sign and all those things. That conference has opened our eyes to bring this magnetic resonance guided focused ultrasound. That's why we brought. Then he wants now gamma knife. Immediately we could able to go. The thing is that with the technology we'll able to improve the knowledge of the consultants, and also they will utilize this technology on the patients to improve their quality of life. So that's where we are forefront. Now we have nearly 14 hospitals, another 8 hospitals we are starting in the next coming year. 3 in Maharashtra, 3 in Bangalore, and 3 in Kerala. With all these things, we have been ordered the good technology. And first, what I want in conclusion, attitude is the best mode. Don't worry about your own growth. If you look for the organizational growth, you automatically grow. Everyone will grow.
That is the most important take-home message for all of the KIMS family members who has been trained well here. Thank you very much.
Thank you, sir. I,
I didn't see the angle of Sweta so active, and I thought only Mamata Banerjee was here with us
Oh.
all these years.
I thank each and everyone for attending and making this evening very happy. And especially thank Krishna Reddy sir because even though his health is not supporting, he took pains to come here. Thank you so much, sir. And thank you, Manu sir, Naidu sir, Sujit sir, and everyone, especially the alumni who came from long distances. Thank you, everyone. Now the inauguration ceremony will start.
I thank everyone once again. I really appreciate Dr. Sweta for such an insightful event, which made everybody mesmerized to just get involved. Thank you once again. Good evening, everyone. We're all assembled here at this venue. Yours. I request entire KIMS alumni come forward to join us for the group photograph. Very nice.
వద్దు నో
Yes. A very good evening, everyone. I request everybody to be seated in their chairs. A very good evening, everyone. We are all assembled here at this venue for this prestigious NSSA Spine 2024. We are about to commence the ceremony of inauguration by lighting the lamp. The light symbolizes the knowledge, and the Lord is the knowledge principle or Chaitanya, who is the source and illuminator of the knowledge. Hence, light is worshipped as the Lord Himself. I'm deeply delighted and privileged to welcome the respected chief guest on this occasion. I would call upon respected and honorable Dr. KVR Sastry Sir, Chairman BAS, onto the stage. I would also request Dr. Manas Panigrahi Sir to come onto the stage. I would request Batuk Diora Sir to come onto the stage. I also call upon our chief guest, respected Dr. B. Bhaskarrao Sir, please come onto the stage. Next, the guest of honor, respected Dr. P.S. Ramani, sir, please come on to the stage, sir. Today, Akshara is with us, who is going to sing a prayer song, who is the daughter of Dr. Raghavendra. I would also request Dr. Savitri Shastri, sir, please come on to join the crowd. Sir, I request everybody come forward for lighting the lamp, sir. Akshara is singing the song for us. Thank you, Akshara, for coming us today.
Ga 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 ma gari sari sa ni sari ga sa ga ma gari gari ga ma gari ga sa pa sa ni sa ri ni pa sa gari ri ni pa sa gari pa da pa ma ga ma gari sari sa ni pa sa शक्ति सहित गणपतिं शंकराब्धि सेवितं विरक्त सकल मुनिवरसुर राजविनुत गुरुगुहं भक्तालि पोषकं भवसुतं विनायकं बुद्धिमुक्तिप्रदभूषिताङ्गं रक्तपदाम्बुज भवयमि बुद्धिमुक्तिप्रदभूषिताङ्गं रक्तपदाम्बुज भवयमि हंसवाहिनी शारदे वीणा विनोदिनी शारदे भावराग विनोदिनी लयतालिनी शारदा विद्या जयति जयति धर्म स्वरूपिणी जयति जयति मोक्ष प्रदाय जयति जयति विघ्न विनाशिनी जयति जयति मां
Thank you, Akshara. You made a special entrance. Thank you so much. Now I would request Dr. KVR Shastri, sir, Chairman BAS. Sir, please come forward to address the gathering, sir.
It is my proud privilege to welcome you all to the 27th NSSA meet. Dr. Ramani, sir, founder president of NSSA, is the guest of honor to this inaugural function. Sir, this association is your brainchild and has grown over the years. You have contributed a lot to the spine surgery with your innovative techniques, implants, and training many neurosurgeons over the years in the art of spinal disorders, surgery for spinal disorders. Dr. Bhaskar Rao Garu, chief guest of the evening and MD KIMS Hospitals, has established KIMS as a major referral hospital in a short span of 20 years and also developed many in various cities in Telangana, Andhra Pradesh, and other parts of the country. You are not only a great cardiovascular surgeon and an administrator, but also a vivid supporter of academic activities. Your support is appreciated by one and all. I welcome my teachers, Dr. Rajareddy Garu and Dr. Satyanarayan Garu. I welcome the overseas faculty of Professor Amit Thapa and Dr. Sharma from Kathmandu, Dr. Kulkarni Aprajay Ghosh from UK, Dr. Marcus Wagner from Brazil, Shin Hoon Kim and Chung Ki Ko from Korea. I welcome all the delegates from India, to senior, some of them, Dr. Atul Goyal, Dr. Chris Garber from Calcutta, Dr. Kale from Delhi, Suresh Nair from Thiruvananthapuram, Dr. Muthukumar from Madurai, Dr. Sampath from Bangalore, Dr. Ashish Parekh from Chandigarh, Dr. Patkar from Pune. To all the delegates and guests, a warm welcome to the city of pearls. I would like to extend a warm welcome to Dr. Manas, Dr. Savit, and
Bakut Dayeria for being actively involved in organizing this meeting. The next few days will not only be a scientific exposure to the various aspects of surgery for spinal disorders, there will be cultural and gastronomic extravaganza as well. Before I conclude, a word about BAS. BAS is Brain and Spine Society, formed as a trust. It is the brainchild of Dr. Manas. BAS supports many academic activities pertaining to neuroscience. It also takes part in social activities as part of its CSR. We have recently donated liberally to both Telangana and Andhra Pradesh Disaster Relief Fund. I welcome you all. Thank you.
Thank you, Dr. KVR Sastry, sir, for addressing the gathering. Now, I would request Dr. Manas Panigrahi, sir, to say a few words about the events.
Good evening. Respected distinguished guest on the dais and seniors and teachers in the audience and my friends. I'm associated with Professor Ramani since 1998. He first came to Nizam's to demonstrate. We did a live surgery. He demonstrated corpectomy, cervical corpectomy in 1998, along with Dr. Parthivan, who he did a lateral mass plating. As a resident at NIMANS, we were not exposed. We were more of doing a brain surgery, not much of spine. And at that time, like 1998, there were very few neurosurgeons who actually were interested in spine. And as residents, we used to think spine is something it's not like the cream of neurosurgery. So, but then it took 3 years, because I finished in 94, 3 to 4 years for us to realize that spine is as important. As you know, now we come to know that spine is more important than brain, because more patients suffer from back pain and neck pain than brain. And that's how we got a very good response. Like, we had more than 400 people registered for this conference. I like to thank each one of you who have come all the way to participate in this meeting, especially not only the national faculty, but we have collaboration with 3 international society, from the British Society of Spine Surgeons, then the Brazilian Society, and the Korean Society. The aim of having Professor Ramani as the chief guest of honor, because he not only initiated us to a lot of spine surgery, but he one day in the corridor, he just said, "Manas, you have to do the conference." So I couldn't refuse, and then that's how we landed in doing the conference. And then we don't regret, because it taught us a lot of things in spine and made us realize that spine, we have to encourage among youngsters that spine is something which have to be given importance. The next point was thinking of another celebrity for live surgery as a chief guest. And when I discussed with Dr. Bhaskara, he said, "I'll get you the health minister." And I said, I don't want health minister. Because we don't want celebrities. As doctors, we have not realized that we are also celebrities, and Dr. Bhaskara is one of them. And that's why I invited him, because though he is a cardiothoracic surgeon, morning we had hot discussion between cardiothoracic surgeons and neurosurgeons. But as a cardiothoracic surgeon, he has a lot of respect to neuroscience, and he has allowed us to develop as the center in the country of having everything in one center. And this year we are getting gamma knife and focused ultrasound, which is an investment of almost 70-80 crores. And he's ready to invest to develop more in future. Thank you, Dr. Bhaskara, for coming. And actually, he was in US, and then he came just to encourage us. I'd like to thank the Society of NSSA for giving us the opportunity, though I'm a part of the society also, for Dr. Batuk and all from Bombay, who have the executive members who have helped us in planning the program. I'd like to thank Professor Sastri, who's always been encouraging behind whatever activities we do, and he'll be always there. Means whether his health permits or not, he'll be there, and Professor Krishna Reddy also will be there. Many times, over a period of time, we get associated, we hurt people because we are nice for 5-6 years, but then seniors get hurt with many things knowingly and unknowingly. And so if I would have invited Professor Satyanarayana and Professor Krishna Reddy, probably they would have told, I'll not come, I'm not well. So I used the psychology of granddaughter and grandsons. So I didn't phone up, I didn't call anybody. I told Sandhya Sweta to call Professor Krishna Reddy. And then his Spani came and told, no, he'll not come, he's not well. Then I told Manoranjita, you call up. So grandfathers can never deny a grandson or a granddaughter. And so that is what the connection between the past and the future. And that is our job. And so I didn't invite Professor Satyanarayana, I sent Raghavendra. So Raghavendra invited all the persons who had to be felicitated. He only spoke to everybody. So that is what I kept Savita Sastri to learn, that a conference is not only to organize just an academic meeting, but to connect the past and the future and the present. With these few words, I'd like to thank all of you and please enjoy the meeting.
Thank you, sir. Thank you for your words. Now I would request Dr. Batuk Diorasa come and just say a few words about the event.
Respected Professor Dr. Ramani, guest of honor, Professor Bhaskar Rao, chief guest for the inauguration function, Dr. Manas Panigri, President NSSA, Dr. KVR Shastri, Chairman Bas, and Dr. Savitra, Secretary. Ladies and gentlemen, as a Secretary NSSA, I invite you all for the inauguration function of 27th NSSA conference in Hyderabad. So it's my proud privilege to present the annual report of the society. So, Neurospinal Surgeons Association NSSA India was established in 2001 by our beloved Professor Ramani, with the aim to bring together all the concern in the development of the spine surgery, to stimulate the education, learning, and the knowledge in this field, to stimulate the research, to conduct the live surgery as well as the operative workshop, to organize the conferences, and to increase the cooperation between the neighboring and friendly developing countries. The aim at the establishment of the Neurospinal Surgeons Association of India was to train the young neurosurgeons who are interested in spinal surgeries, to spread the knowledge to the public, to propagate the idea not only to the country but beyond the country, around the world, to interact with the societies in the world, to hold the conferences and exchanging the views, to promote the research, to publish in the Journal of Spine Surgery, and to provide the competitive and traveling fellowships, hold regular election for all the posts, and to establish a solid corpus for the association. So under the guidance of Professor Ramani and the NSSA Foundation, that includes Dr. Prakash Moda, Dr. Parthiban and Shraddha, along with the executive committee, we continue various activities of the NSA throughout the year. We run the NSSA website, that is being updated in keeping with the rapid progress in the neurospinal surgery. In fact, this branch has progressed so rapidly that today is recognized as one of the most popular surgical branch. The website helps to bring the neurospinal surgeons not only from India but the whole of the world together in understanding each other and the knowledge expertise acquired by the individual spinal surgeons. This is the website. So every year we hold the annual conference of NSSA. It is widely appreciated and become the prestige point for the society in helping the exchanging the knowledge in the meaningful ways. For the young neurosurgeon, it's a matter of great satisfaction and provides a warm personal feeling that is an invaluable aspect of this meeting. So the last year, that is 26th annual NSSA was organized in the month of September at Hotel Vivanta, New Delhi by Professor Kale and his team, Dr. Sachin Borkar, various international societies that includes the International Academy of Spine, Korean Spinal Neurosurgery Society, and the British Association of Spine Surgeons were the participants of the meeting, and almost more than 500 delegates, including 30 international faculty members, made this conference grand success. NSSA Foundation and the organizing committee congratulates the organizing team for the excellent hospitality, academic content, and the conduct of the conference. We regularly organize the cadaveric and live spine surgery that was organized in the month of January at Rajkot by Dr. Prakash Moda and the team, along with the live surgery that was performed by Dr. Atul Goel and few other neurosurgical faculties. And this cadaveric workshop as a part of the conference was organized at the Pandit Deen Dayal Upadhyay Medical College, Rajkot. And these are some of the glimpses. NSSA Executive Committee congratulates Dr. Prakash Moda and the team. In the month of March 2024, Vivek Joseph organized the cadaveric spine workshop at Christian Medical Vellore, and almost more than 60 delegates participated in this meeting. NSSA congratulates Dr. Vivek Joseph and the team for the successful organization of the cadaveric spine workshop. Dr. Ashish Tandon organized the live operative spine surgery in the month of April in Jabalpur, and the theme was minimal invasive spine surgery, where they included all sort of a minimal invasive in the spine surgery, including the endoscopic spine surgery. And these are some of the important pictures that Dr. Ashish sent me. Thank you, Dr. Ashish and the entire team. Every year, Dr. P.S. Ramani's annual basic course is being organized in Mumbai. So last year we organized, so this year, sorry, in the month of June, we organized in the medical college and hospital at Cooper Hospital, along with the HBT Medical College. And during that workshop, Dr. Muhammad Jileli has delivered the second PS Ramani oration. He's an old friend and a committee member of NSSA. NSSA thanks for meeting was actually organized by Dr. Jayesh Sardara and Shraddha Maheshwari. NSSA thanks Dr. Jayesh and Shraddha for organizing this cadaveric workshop. As a part of the various state level spine chapters, Dr. Achal Gupta organized Endospine 24 at Lucknow under the guidance of Professor Ramani. So this year we are celebrating 27th annual NSSA conference at Marigold, Hyderabad, with that is being successfully organized by Dr. Manas Panigrahi and Savitra Shastri, as Manas mentioned about more than 400 plus registration. I think we should give a big round of applause for Dr. Manas and the entire team for successfully organizing this meeting. So every year, as I mentioned, we work in collaboration with the international societies. So every year, the members of the NSSA visits the different conferences. So year 2023, in the month of September, Dr. Goel and Dr. Parthiban, along with Dr. Bhatoi, Dr. Venu visited the spine conference in Korea. This year again, like our past president, Dr. Kale, along with Dr. Savitra, Dr. Apurva, visited the spine conference in South Korea. NSSA also runs a peer review journal that is called Journal of Spinal Surgery. That is official publication of Neurospinal Surgeon Association of India. It's a peer review print plus online quarterly journal, and that allows a free access to its content and permit author to self-archive final accepted version of the articles on an institutional or subject-based repository. Dr. P.S. Ramani is the founder editor, along with Dr. JKBC Parthiban and Dr. Jayesh Sardara, Sachin Borkar, Praveen Salunke, and the Venugopal are the editors. One can submit the articles like on these are the website where one can submit the article for publication. NSSA also runs websites, and that is every second month in the we have started since last January 2023. The fifth webinar was arranged on the 13th November that we always celebrate as a Neurospinal Day, and the theme was essential in the spinal surgery. The last webinar was conducted in the month of May on the management of osteoporotic spine fractures. Dr. Jayesh Sardara is in charge. Thank you, Dr. Jayesh. NSSA also quarterly publish a newsletter that mentions about the various activities being conducted all over the country by the NSSA, and under the leadership as well as the guidance of Professor Ramani. Dr. Apurva Prasad is in charge of NSSA newsletters, and I thanks Dr. Apurva for regularly publishing newsletters. Training is an essential part of the society, as Manas mentioned about, and the NSSA regularly holds of fellowships, that is short as well as long fellowship. Short fellowship for 6 months, 6 weeks, and the long fellowship for 6 months. And we have selected the Fortis Hospital, Mumbai, and the Aditya Super Specialty Hospital, Jabalpur, under the guidance of Dr. Jayesh Sardara and assistant respectively for the NSSA training. Those neurosurgeons, spinal surgeons wants to get a training can write to the secretary or to the respective faculties. So NSSA having a very essential, now more than 650 members, that includes the national and international members. So the membership is a very strong drive as a part of the NSSA. Organizations to become a member, one has to scan the QR code. The form and the QR code is available outside at the registration booth, and I will insist for those residents and those neurosurgeons has not become a member should be a member of NSSA. And finally, the next year we'll be organizing the NSSA Spine 25. That is will be the 28th annual conference in Coimbatore with Dr. JKBC Parthaban Chairman, Dr. Selvan Organizing President, and Dr. Rajkumar as Organizing Secretary. Thank you.
Thank you, sir. Nextly, I request our chief guest, Dr. Bhaskar Rao, sir, a few words about the events. Thank you.
Good evening, all of you. It's a great pleasure for me to be here. And when I was in America, Manas called me that we are organizing a conference. We need some chief guest. And I said I can able to arrange a health minister. And health minister, that means political people will never come in time. So then we keep on, has to wait. Then I kept quiet. Suddenly he sent one message that my name was there in that. So I'm not a legend. Legend usually they are not able to come freely to the society outside because there's a lot of problems for them. And now I'm very happy that after seeing Professor Ramamani, I can sit peacefully. Manas can work for the next 30 years. So I need not worry about that important thing. And the dais and off the dais, and it's 400 people and a subspecialty gathering and conducting a conference is a huge task. And I see from since last 14 years in Manas is with us, and the way he conducts and the way he smoothly runs, of any person of his nature, his stature, of a star, there will be nightmares for the management because these people always go and keep on putting pressures, this, that, and all. He never comes and asks for anything. That is his mindset. At least in every day, 1 hour of my time goes to fix an appointments for him because anybody calls him, the appointment will get only after 3 months or 4 months. All these VIPs keeps calling me, please help us to see some. Then I have to put him in the before going to the theater or maybe in between the cases and all. In spite of his busy schedule of surgeries and other things, he will give more importance to these conferences, training their students, at least in a national or international conferences, and every year he conducts about a couple of them. Last year also we did in one in Sign. And with all these things, and the patient quality care will not be compromised, and that's why he is keep growing and entire thing. And conducting this type of conferences will also enrich your knowledge, and you also get more of ambition to do when we are making a lot of deliberations in the conferences, so that we will have a to get and achieve what we are not able to do as of now. That's why all the new things, innovations, new surgical procedures, and bringing all the surgeons in the worldwide, and we go and watch them. That's how the ambitions will able to create, and then we'll able to grow. That's why the department is keep growing. That is one important task where I could be able to find our neurosurgery department. And KIMS is mainly meant for academically oriented, and that's why all the departments, when one department is doing, other departments automatically does all the academic activities. Even our neurosciences does more of the paper presentations and everything. Every department in KIMS is doing that. Now, as he mentioned that when we want to keep on upgrading ourselves and we want to be the number one in national and international level, whatever technology that is available in the world, we should be able to bring it to our own patients, and that will be well get trained. As he mentioned that we are bringing the gamma knife and also the magnetic resonance guided ultrasound, focused ultrasound, which can able to treat more of the tremors. That will be the second in this country. First is in Coimbatore. In this MRI, what we got is the Hero 3T, which is the first in Asia, and nowhere it is got. By seeing that, we want to, there are so many people, the tremors in this country requires this type of treatment. That's why KIMS has ordered about 4 machines. One is coming to Hyderabad, another one is going to Bombay in Thane, third one is in Bangalore, and fourth one is in Kerala. All these 4 states we are going to establish these 4 in the next 12 months time. And wherever there is a new technology that is available, our consultants are very eagerly looking for it and bringing them and utilizing them, and utilize this technology to make sure the quality of the patient should be able to improve. I must congratulate my entire neurosurgical team and the neurophysicians, all the consultants. Once again, thanks Manas and the entire team that conducting this type of conferences. I don't know when he will take rest and when he will be able to sleep. And Anuradha has to tell whether he is spending time with family or not. So one side conferences, another side training the people, another side taking care of the surgeries and all those things. I'm very fortunate that to have my department here. Sir, I must salute Professor Ramani that you at this age you are able to inspiring many of the young people. Today I am finding many people after 50 or 60, sir, I am getting old, I am tired, this, that and all. That's why After seeing you, I asked Manas what is his age. Is 90. So then I can keep quiet for next 30 years, not look for anything. So he cannot able to retire. There is a precedent is there, so you should able to work for it. So having given me this type of opportunity for me, I thank for this PAS and all other organizations internationally collaborate, and especially thanks for Manas to give. Thank you.
Thank you, sir. Now I would request the founding members of NSSA, Dr. Prakash Moda, sir, Dr. Parthiban, sir, Dr. Selvan, sir, come on to the stage, sir. Now, Dr. Selvan, sir, it is over to you.
Good evening, ladies and gentlemen. It's a pleasure to be here among the colorful crowd in Hyderabad on the inaugural function of the NSSA Spine Conference. I must thank the organizers for making it a colorful and wonderful themed event. And as a gesture of honoring leading spinal surgeons or those who have served the society to the greatest extent, we used to honor them with one Lifetime Achievement Award and honorary membership awards. And this time, for that presentation, we are all here with you. And I request Dr. JKBC Parthiban to make an announcement and a small introduction of our Lifetime Achievement Award awardee this year.
Thank you very much, Dr. Selvan. And we've been thinking that usually every year we give this award of lifetime achievement. So mainly to respect the person who has done a lot to our society. And also we also see the quality of contribution and the dedication to the society and also to the specialty. So we were thinking where and whom we can select. That's the time we realized there is a big Himalayan structure standing next to us. Who else is nothing than my good friend, Dr. Sushil Parkar. Please. So, thank you. So we were realizing the reason is, sometimes we do not realize what is very close to us. We do not realize what exactly is very close to us. My relationship with Sushil is a very, very long association because of one primary point is Professor Ramani. We were too young at that time when he started his microlumbar discectomy and anterior cervical discectomies of different types, which were a fascinating surgery 35 years ago. And when we were the young neurosurgeons, we were attracted to that. And 2-3 people coming to us that we started moving with, myself and Sushil. And that never ended. Now it is more than 30 years. So the discussions goes whether you are sitting in the bus or in the hotel or during all the time we talk about the subject and what Professor Ramani has taught us. One simple explanation I will tell you. We ask Sushil will say one thing. Whenever he do the microlumbar discectomy or anterior cervical discectomy, we will say that you cut the annulus like a cake. I will tell the same word and he will tell the same word to his students. Then only we realize where it came from. It came from Professor Ramani. Because he told us the same thing. You cut the annulus like a cake. It should be perfect. When you open the annulus, it should be like a cake. So that is how our relationship went ahead. And it went on, it never ended for more than 30 years. And we have been involved much interested in the cadaver teaching. The amount of cadaver teaching we have done is very amazing. So many good things I can say about Sushil Patkar. Sushil Patkar is a very innovative person. Very innovative. If you talk to him, you can find not only innovation, you have a lot of humor inside. Probably many of you don't know about the humor, the child inside him. You know only Professor Dr. Patkar you have seen as a very aggressive uh, neurospine surgeon who talks something which is you cannot even imagine how you do this. So I have a great pleasure in inviting my friend Sushil Patkar. Sushil.
Good evening, everybody. Of you. It is indeed a very emotional moment for me. I've been conferred this award. There are various kinds of people, some are born great like Dr. Raman. Some become great with hard work, and some like me have greatness thrust upon them. Whether I deserve it or not is not an issue. It's a matter of debate. But I'm extremely lucky. I've always been lucky in the sense that I found a great teacher, mentor. I can say like he's I'm not his biological son, but he's my father who groomed my career all throughout, right since the beginning when I joined him way back in 1993. And he taught me not just neurosurgery. He has this capacity of laying the seeds inside the brain about everything, including science and philosophy of neurosurgery, neurospinal surgery, and about life. There must be some kind of good deed which I must have committed in past lives that I came proximal to Professor Ramani, got the opportunity because I feel that learning and becoming a good surgeon is like riding a bicycle. And for a bicycle, you always not only need a bicycle, you need somebody who's ready to hold your seat and take you down the road and till you develop the balance. The balance is something you cannot get from the books. Nobody can give you the balance. The balance has to come and which is given to you by a mentor who's there to hold you till the balance comes into your mind. So I will just say that I can only be for all. Thank you very much.
Thank you, sir. Now we are just moving on to NSSA felicitation ceremony. I would request Dr. Raghavendra to take over the mic and lead the session from now.
Everybody, my pleasure to present in front of you. Thank you all for being here today as we gather to honor and celebrate the life and legacy of our esteemed mentors. I'm Dr. Raghavendra, consultant neurosurgery, and it's my both privilege and heartful responsibility to stand before you and share my thoughts about the incredible persons who played such a pivotal role in our life. Great teachers was more than just a mentors. They were a guiding light, source of wisdom, unwavering support, knowledge. For the moment we met, took us under their wing and provided the guidance, encouragement, knowledge, and have been instrumental in shaping our own personal thoughts. Their insights and perspectives were always profound, and their ability to see the potential in others were truly unremarkable. They had unique talent to make complex concepts simple and accessible, and their passion for teaching and mentoring was evident in everything they did. So I just call all my mentors, and I also ask all the dignitaries. I call all the great mentors and for honorary membership by NSSA team for felicitating our this one. So I request all the dignitaries along with Ramani sir, please come to this one. The first is BS Bhavani Shankar Das sir. Sir has left the world. His qualification is MBBS, MS and KG, from MS from KGNC and MCH from AIMS. Sir is worked as a registrar in Institute of Pediatrics, Cuttack, and is a registrar of neurosurgery in Cuttack. He was the founder member of the Department of Neurosurgery at VSS Medical College, Burla in 1980. He was a professor and head of the NIMANS in 1981 to 96. Sir has headed in the Kalinga Hospital, Bhubaneswar, as a leading neurosurgeon. You had a fellowships in the Edinburgh, Scotland, and England, fellowship in the Queen and so on. Sir has given n number of dozens of orations like Sarveshwara Memorial Oration at AIMS Delhi, SC Memorial Oration at KGMC Lucknow, Natarajan Oration at Madurai, Jacob Chandy Oration and RM Oration at NSI, and Seth Rangachari Oration at NSI. Sir, and I read a lot of when I was doing these presentations, one thing I nicely saw that Obcharya Bhavani Shankar Das was an article was written by Indira Devi Madam from Nimans. Sir has left the world on 5th August 2022. But his memories will be there for the generations to come and the students and the patient he has made us to learn. I request his son Kanishka Das sir, please come on and receive the award. Now I request one of the great, sorry,
Good evening. I bring in a lot of gratitude from my family, my mother, Dr. Sarla Das, and all of us for this remembrance of my father, who has been, I know, an icon in neurosurgery in this country. It's been 2 years since he's passed on, and I'm glad that there is so much of remembrance, fond remembrance about him. I'm indebted. Thank you.
now I request one of the great teachers, N. Muthu Kumar sir. Sir is a most iconic. I request sir, please come on the stage. He's a founding member of NSSA and the present he is all the conferences he has attended. Sir is the head of the Department of Neurosurgery at Devadas Hospital, Madurai, and the former head of the Department of Professor Neurosurgery at the Madurai Medical College. Sir has done extraordinary fellowships in Barrow Neurological Institute, Pittsburgh, and Japan, and also he has a membership of 7 international and 8 national professional members. Sir has been recently awarded with the gold medal in the Melbourne in the Spine Week 2023. When I was going through the sirs, the contribution to the neurosciences is admirable. He had 91 publications in both indexed and the national journals. He has a high index journals of 23, and he has written a textbook of editor, and he also has written 5 chapters on various component neurosurgery. And one more important thing is he has trained 60 neurosurgery, and he has been a referee for the now both national and international journals. He's a former honorary secretary of NSI from December 17 to 21. He's a CMA convener of NSI. He executive committee member of 2015 to 2017. He's an associate editor of neurology. When it comes to spine contribution, when I was I saw the excitement in Sir's face today when Sir was sharing the session. 2 people during his presentation gave his own article as a references. So it's very wonderful for this. One is in the transverse screw entry point screw has done, and one more in ossification of the yellow ligament in the dorsal spine. He gave 2 important new concepts to the literature. One is tram track sign and the common sign. So I just thank for all us all the support in the reaching the people. Thank you, sir. I request Muthu Kumar sir to speak few words about it.
Good evening, one and all. It is on and off the dais. I am indeed humbled and honored by this gesture of NSSA. I sincerely thank all the office bearers and members of NSSA for bestowing this honor upon me. Say thanks to one of our mentors, Dr. Ramani. Even though I was not a direct student of Ramani, my first encounter with Dr. Ramani was during my residency days when one of the schemes of NSI, Dr. Ramani presented the ACDF fusion. In those days, we used to do only single level discectomy without fusion, and he was the first person who told us that the graft has to be put. And at that time, he used to talk about Clovert's technique. And since then, once the spine meeting started, I don't think I ever missed single meeting of NSS. Most of the time, even though I am called as a faculty, I have to acknowledge that I have learned also a lot. And even in this meeting, in the past 1.5 days, I have learned a lot from all my colleagues, including the younger surgeons. Thanks once again for this honor.
Thank you very much, sir. The next I call Shivaraju Venkata Rangarao, sir, is a chief neurosurgeon at SVR Hospitals, Vijayawada. Sir has completed his graduation MBBS, GMC 1975, MS AIMS 1978, MCH from NIMANS 1982. He is also from NBA 1982. Appointment, sir, worked as a lecturer in Sri Chitra Institute of Medical Science, Trivandrum. He worked in a government service as a professor of 6 years in Gandhi Medical College and Usmania Medical College, Hyderabad. Sir is a professor in 16 years in SMC Vijayawada. Sir has been extraordinary in private practice for 20 years. Now he is working in SVR Hospitals, Vijayawada. He is known for his vast experience in 4,000 plus intracranial and 8,500 spinal procedure surgery in the last 42 years, exactly of my age. So, Sir has multiple national and international publications. Sir is an active member in the Andhra Pradesh Neurosciences Association. Please, sir. I request, sir, please have your words.
Good evening, my teachers, the dais, my colleagues, and honorary members on the dais. It's one of the memorable events in my life. As I rightly told, the 42 years, if one look at back, definitely hard way of training, just 2 minutes of my your valuable time. When I graduated way back in 82 from NIMHANS, I was at Usmania Medical College and General Hospital and Gandhi Medical General Hospital, the only qualified assistant professor neurosurgery, either at the OMC or at GMC for 6 long years under the able guidance of one of the legends, Professor Sachadamurthy garu and Professor Rajareddy garu. Mind you, every day I was operating 22 to 3 cases a day for 6 years. You will be surprised to know no corporate hospitals at that time in Hyderabad, 82, 89, no corporates. Only one center has come in Medinova, that too only body CT in 83. All CT angiograms, all surgeries. The NIMHANS background from Dr. Verma and Professor G. Narayan Reddy Vidyasagar helped me to face the situation, and I go in front of my mentors, Professor Sachadamurthy and Professor Rajareddy, who gave me so much confidence in my surgeries and taught me what I am today. I thought my life will be easier after that, but not so. And then I had been to Vijayawada in 89 as a professor in a Taluk hospital, SMC Medical, at the Taluk Hospital, private it's under entire UHS. Again, I'm the first neurosurgeon for the 5 districts: Krishna, East Godavari, West Godavari, Khammam. And used to again work from the scratch for 15 years. Though I'm a professor, worked as a house surgeon. Did develop in practice, used to see neurology cases, neurosurgery. Again used to operate around 200 in private practice and 200 to 300 in general hospital, all alone, with teaching general surgeons, anesthetists, all MS assistants, and taught the anesthetists. I taught what is neurology, what is neurosurgery to that 4 districts and I'm today what I am. I thought after total 15 years, I got a bit of not happy with what I'm doing. Then I started my own hospital. There alone, for the past 20 years, I'm the chief surgeon in my own hospital, Sphere Hospital, multi-speciality. Even though today also I still operate around 150 200 per year. Unfortunately, even today, even though I got 35 neurosurgeons in Vijayawada, hardly anybody comes and assists because my times of working starts from 5 a.m. and they wake up a little bit late. So I don't know how my 40 years experience, but I'm always happy. I'm able to go around 12,500, intracranial 4,500, spinal maybe a bit this way, that way. Reasonably successful, maintaining all ethics taught by my teachers. Even today, I follow the same ethics and I operated 3 generations. And that's what I am today. And I don't know how far I deserve this august audience with my little documentation, publication work, whether deserve this honorary membership. But still, as I'm honored, I thank from bottom of my heart to Professor P.S. Ramani. In fact, you should have remembered, actually, I attended his one of the first workshops. From him, I learned that stiffy plate fusion. Afterwards, I started the cases at cadaver workshop at Vijayawada. But all these are all alone, no publicity. That's not much exposed. But from then onwards, I taught so many people in those 4 districts on the first to do all spinal instrumentation, the cervical, lumbar, and whatnot. I thank you, sir. I thank Professor Manas, Professor Bhaswarao Garu, and other dignitaries and dais to give me the opportunity. And thank you very much.
Thank you very much, sir. Now I call one of the greatest persons. Sir could not make out because of his illness. Now we call Professor Raja Reddy, sir. His qualification is MBBS, FRCS, and FRACS. He worked as a professor of neurosurgery at the Gandhi Medical College, Usmania Medical College, and the Nizam's Institute of Medical College, Nizam Institute of Medical Science. He was worked as the director of the Nizam's Institute of Medical Science. He has been a visiting professor of the Northwest Unit of Chicago and Detroit and PGH Chandigarh, India. There is many publications in both national and international journals. He has published many books. At present, he works as a senior consultant neurosurgeon at the Apollo Hospitals, Hyderabad. The sir has received major awards in the medicine like Cornell Vargiri Gold Medal Award for the medical research, Rajiv Ratna National Award for Medicine in '93, Lifetime Achievement Award in Neurosurgery by Madras Neuro Club, January 2013, and Lifetime Achievement Award by NSSA in 2016. One cannot just remember, sir. Wherever the word fluorosis, the sir stands beside that. He has written a many number of chapters on the fluorosis, Indian textbook of neurosurgery, APA textbook of medicines and tropical neurology, handbooks of neurology. And one important thing, at the age of 80 plus, he's still the chairman of Pneumatic Society of India. When I was asking about the data, he just started expressing all about the interest, how the coins and the history. I request now Shastri sir, please receive the award on behalf of Raja Reddy sir. Please come, sir. Thank you, sir. Now I request Subbara Bavaraju sir, as due to certain personal reasons, he's in USA now, so he could not make it today. Sir is in MBBS, MS, and MCH. Sir is a professor and head of neurosurgery in the Guntur Medical College, Andhra Medical College, and the Kakatiya Medical College. He is a director of medical and health sciences government of Andhra Pradesh. He was worked as a superintendent of MGM Medical College, Warangal. He was worked as an additional director of medical education for the government of Andhra Pradesh. Served as president of the Andhra Pradesh Neurosciences Association. He has many published books and chapters and articles in both national and international delivery. He has been invited for more than 20 orations and the guest lectures. And he has been chaired many sessions at University of Health Sciences. He has been awarded with the recognized as the best teacher by the North Andhra Surgical Society in 99, honored on the Teachers' Day by the Medical Education Cell of Andhra Medical College 2006, Lifetime Achievement Award by the AP Neuroscientist Association, the founder secretary of AP NSA 1995 to 99, founder coordinator of Medical Education Cell at Andhra Medical College. After this experience is shown a very extensive research on the biomedical engineer. So now I request Manas sir take this award on behalf of Subbarao sir, please. Thank you for being our guide, our teacher, and our inspiration. Thank you for the wisdom, the encouragement, and the countless memory. We carry your memory in our heart forever and strive to honor you in all that we do. Thank you, everyone, for being here today. Thank you, one and all.
Thank you, Dr. Raghavendra, for sharing the page. Now I would request respected Dr. P.S. Ramani, sir. Sir, everyone is waiting to hear you. Just few words from your side.
Our respected chief guest, Bhaskara Rao, other dignitaries, dais, ladies and gentlemen, for during your speech, you made a mention about inspiration that I give to the young. You did not tell them what is my age. I'm a man now. I will tell you my age. I'm just next month finishing 86, going on to 87 years, you see. But heart is young. For many years more, you will not be able to touch it. Third November, running a marathon. Yeah. Like to join. In this conference, we have international cooperation from many countries. Very active country is South Korea. Of them, Seun Kim is one member who attends our meeting very regularly for many years. So much so that 6 years back, he even attended my birthday. Dr. Seun Kim, thank you very much. Just say hello to him. Yeah. Similarly, I would also like to thank Dr. P.D. Kulkarni. He has been very responsible for bringing English neurosurgeons to this and making it absolutely very exciting. And they will be cooperating with us more and more as years go. Thank you. Thank you very much. Coming to NSSA, as an old man, I feel very happy and contented with the progress of the neurospinal surgery that is happening. You have all seen that. I come from Maharashtra, speak Marathi, and remember one poem which I will send one sentence. इवलेसे रोप लाविले द्वारी वेलू त्याचा गेला गगनावरी मोगरा फुलला मोगरा. It means that 27 years ago, I implanted a pod of NSSA. It grew very wild, very fast, and spread all over the world and started giving flowers. And its smell has been mesmerizing everybody, not only in India but also abroad. NSSA, like any other organization, has its ups and downs. But when the down came, we were not depressed, we were not irritated, we were very calm. We sat down and worked out the formula to proceed ahead from these difficulties. And that is why today we are where we are. That requires unilateral dedication of the mind. And to get that dedication, you must do at least 10 minutes every day meditation, because this mind is all jammed with lot of thoughts. To organize that, you require to do meditation. If you got good thoughts, you got dedication and deliberately, then you can go ahead and ahead. But to go ahead for a long distances, your body also must be strong. Or you do not probably realize that in this organized function today, how many times we made you get up and thankful to us, we gave you exercises for your knee. They are very fair. We made them strong. If you do this exercise every day, you will be very strong in the body also. Right, yeah? Your body must be strong, and therefore you must do regular exercise. Yoga is a very good exercise to do every day for some time. That will keep your body healthy. And then you must do pranayams so that your lungs remain very healthy. They get tremendous capacity. So however distance you have to run or walk, you don't feel breathless. Therefore, pranayam is also very, very important. So lungs, body and mind, a combination of all this together will lead to success. Hardly any failures. And this doctrine must be inculcated in children when they are young, that they must start thinking independently and find out in what subject they are interested, rather than just listen to the parents and the seniors in the house. If they do that, if they think independently, they are definitely bound to success in life. That is a very important message for these young children. The parents are here, they should introduce that to the young children. With these words, if we keep your body, if we keep your mind, if we keep your lungs strong, you can go much, much further, and we'll be able to go much further, provided all of you follow this doctrine and then achieve more and more success. Thank you very much, everyone, for coming here today and making it success. Thank you. Thank you very much.
Thank you, sir. Thank you so much for